Good morning, everybody. Let me know if I'm too close or too far away from the microphone. Okay. I'm Lynda Mitchell. I'm CEO of Allergy and Asthma Network. I'm also an asthma mom and a food allergy mom. My son was born 33 years ago. He had a lot of asthma attacks as a baby, had a lot of hospitalizations. And, back then the asthma treatment was 2 shots of epinephrine and a bolus of Solu-Medrol, and then he was put in an oxygen tent and sent up to the floor. And we had a lot of recurrent hospitalizations, a lot of oral corticosteroids during his first year of life. I have pictures of him with little chubby cheeks that I know was because of the steroids. I stayed up a lot of times at night just watching him breathe, wondering how fast he was breathing, whether I should take him to the emergency room. So this probably sounds familiar to a lot of you who maybe have children with food allergy or work with children, have children with asthma or work with children with asthma. But that was 30 years ago, and there's been so much innovation and science for those who are living with asthma and for children living with asthma. There's new options and treatment that didn't exist back then, like biologics, which are miracle drugs for many people who've lived with severe asthma. Those treatment options just weren't even available back then. So people who suffered immensely now have options that weren't available then. We also have better guidelines for asthma management and guidelines-based asthma care and education opportunities like this, so people who care for those with asthma can instruct them on how to live and manage their asthma day to day. Asthma control is still a struggle for many, though. So we're hoping to share some interesting and fun ways to learn more about asthma control and how you can share that with the people that you work with or your family or friends, so that a better asthma control can be a future for many. I'm going to do a brief introduction about our work here at Allergy and Asthma Network, and then I'm going to hand our program over to Dr. Nancy Joseph, who's our facilitator for today. So you can go ahead and get started with the first slide. I'm going to let you do it. Whoops. You can go ahead to the next slide, please. First, I want to thank you. Thanks to our sponsors, Amgen, AstraZeneca, GSK, and Sanofi Regeneron. We couldn't have this program today without their generous support, so I thank all of them. So about Allergy and Asthma Network, for those of you who may not be familiar with us, we're a 38-year-old disease advocacy organization. We're based in Virginia. All the staff are remote now. We were founded back in 1985. Our primary audience is the patient and caregiver, and health equity is a primary lens through which we plan and deliver our work. Our mission is to end the needless death and suffering of those with asthma, allergies, and related conditions through education, advocacy, outreach, and research. Next slide, please. Our North Star, as I mentioned, is the patient and caregiver. It's where we plan and deliver our work, and we advocate for those and include the patient voice in everything we do. Next. Our main health equity program is called Trusted Messengers. I'd love to spend more time talking with you about that, and maybe as we close later this afternoon, I'll tell you more about what we're doing there. But we do a lot of health equity work through all of our mission areas, and these are just examples of what we're doing. We have work that health equity work we're doing in advocacy, in our educational resources. We have Eczema and Skin Color website, which is a partnership with the American College of Allergy and Asthma and Immunology. We have as I said, our Trusted Messengers program. That's an outreach program where we go into under-resourced communities. We send our asthma educators. Some of them are actually in the room. Laonis and Leandra, do you want to raise your hand? They do really important work going out to the communities, sharing educational resources about asthma, allergies, and related conditions. And then doing an assessment for those who are willing to take a survey-like instrument to kind of identify whether they have asthma and asthma control. And then also if they have signs and symptoms of eczema or food allergy. And then those who do have evidence of asthma, we invite them to enroll in a free virtual asthma coaching program where asthma educators work one-on-one with them in a virtual platform using their smartphones and deliver a 6-week program on asthma self-management education. It has great results. It shows a lot of improvement in asthma control, asthma maintenance, improvements in quality of life and other factors, and it's sustained at 7 months and 13 months after the 6-week program has begun. Love to tell you more about that. And if you have health events in your local community where you think we could come into your health event and share our information about these programs, please let us know. I won't stay long on here, but we've been doing the Asthma Summit for quite a while, and we're here in Anaheim, California. Next. So I'm going to try to launch this first poll, and hopefully we'll get an idea of where everybody's from in the audience. I want to welcome the people in the audience. I know we had about 800 people registered. So those of you who are on the online program, thank you for joining us here today. Those in the room won't be able to participate unless you are logged on as a virtual resident or registrant. So while we're waiting for the virtual registrants, how many here in the room are from the East Coast? Welcome. Southeastern or South? You? Midwest? Southwest? Anybody here from California and the West Coast? Probably a lot, right? And Puerto Rico? We might have some Puerto Rico registrants online. Anybody from outside the country? Welcome. Thank you. Okay, we can show the results now.
Lynda, I just ended the poll.
You, pardon me?
I just ended the poll.
Okay. Oh, it has to be manually stopped. Okay. These are just little technical things we're going to have to do today. That's a little different than we're used to. Great. Thank you very much. All right, and you can advance to the next slide. Oops, we're going to have to launch another poll. Who are you? Are you a person with asthma? A parent or caregiver of someone with asthma? Probably you're playing a dual role, right? State asthma control program representatives, welcome. A doctor or healthcare provider here, welcome. Asthma educator, certified asthma educator, that's great. Thank you for being here. Respiratory therapist, nurse, and industry partners. Anyone else? Waiting for it. Okay, thank you. Okay, you want to show the results? A lot of asthma educators. Thank you for all joining us online as well as in the room. Great. Okay. Oops. Advance to the next slide when you get a chance. Okay. So what I'd like to do now is welcome Dr. Nancy Joseph. Dr. Nancy Joseph is going to be our facilitator for today. She's a double board certified physician in general pediatrics as well as allergy immunology and is currently based in Massachusetts. Dr. Nancy Joseph is a consultant and medical advisor for Allergy and Asthma Network. She's a member of the American College of Allergy, Asthma, and Immunology, and she's a fellow, as well as the National Medical Association, in which she's active locally and nationally and is the immediate past chair of the Allergy, Asthma, and Immunology section of NMA. She has collaborated with the NAACP, speaking about COVID during the height of the pandemic, has been featured on NMA Talks as an expert panelist discussing asthma in the African American community. Dr. Joseph hosts the How Do You Medicine podcast, highlighting healthcare professionals doing medicine their own way. This podcast is under her brand, The Dynamic Doc, which she has created to inspire and empower others to live on purpose with purpose. Dr. Joseph was recently awarded the top physician under 40 by the National Medical Association. So with that, I'm going to say Welcome and thank you, Dr. Joseph, for being our facilitator today.
Hello, everyone. I'm used to seeing that picture on my computer. So when I see it on two screens, it's like, oh, okay, she did a good job with that picture. She's my friend, so otherwise I wouldn't have paid her, but she did well. She did well. So I can just click on here, right? I, perfect. Y'all don't have to keep. Gotcha. The big button is forward. Got it. So like, don't mess it up. The green button goes forward. Ah, it worked. Amazing. So, as Linda said, I am Nancy Joseph. I am your moderator, or like I said, the hostess with the mostest for today. If you have any questions, let me know. But really, I just really wanted to do kind of a quick, hey, why are you here? Kind of recap, but they say, tell them what you're going to tell them and then tell them what you told them. So this is the gonna tell them part of the summit. So I really just kind of talk to you about, why are we here? Why is this important? And then really we'll go from there. So, well, actually, I think one of the other things that's not on here, my new job is being editor-in-chief of Stat Pearls, which is like an up-to-date alternative, really. And that endeavor is really trying to provide information even to underserved areas, maybe that don't have access to books and things like that. So currently is my brand spanking new job that I just started, but I wanted to add that. So really, why are we here? So first of all, we're here really to increase awareness to a disease that's very important and is very prevalent. So we want to increase awareness and give a voice to asthma, share best practices, discuss the importance of asthma education, discuss the importance of access to care. We'll hear some stories today when access to care goes wrong, and really just trying to really emphasize why that's important. And so I come here, representing the National Medical Association. I am the immediate past chair of the Allergy, Asthma, and Immunology section for that. And I wanted to kind of take a quick moment. A lot of people don't know what the National Medical Association is, and I really wanted to take a moment to talk about that. So the National Medical Association is an organization that represents over 50,000 African American, physicians of African descent. And really the main purpose of that organization is to combat health disparities and to be a source or and a voice really for underserved communities. And we do that in multiple ways, from the colloquium that happens in the spring in DC to our national convention that just happened this summer in New Orleans. And the next one is in New York in August of next year. But throughout the year, we do various things like the anime talks that Lynda had talked about that I do. They also, our president, Dr. Yolanda Lawson, does various talks, really just trying to bring awareness to both health disparities and really trying to not only combat it in our clinic, but there's a power in numbers, really trying to bring physicians together that care about the disparities that I'm going to talk about to really help move the needle forward when it comes to health equity. So why is health equity important? So when we talk about health disparities, we have to talk about a lack of health equity, right? So it affects every aspect of society. It affects, so we'll talk about more about social determinants of health today, but really a lack of health equity, the health disparities really affect all aspects of life. And the CDC defines health equity as the non-medical factors, the determinants of health as non-medical factors that influence health outcomes. So we know that, it's not just what you do in clinic that affects someone's health, your whole environment affects someone's health. And so the lack of equity in and outside of clinic really affects our patients greatly. So we'll go into my first and only poll question. So how much more likely is an African-American child, how much more likely are they to die of asthma than a non-Hispanic white child? So we'll have online, we'll do their polls, but here we'll have a raise of hands. So raise your hands if you think twice as likely. Okay, what about 3 times? All right, 4. You can't vote twice. You can't vote twice. I'm looking at you. I can see. No, that's not the right slogan. Vote early and often is not. I support voting. I support voting, but I don't want to. I don't want people to get the wrong idea. Don't do that. Did we do 4 times? Is that what we just did? Perfect. Listen, I don't even remember what I had for breakfast yesterday. 5 times. Okay, great. And 7 times. Okay. All right. So it looks like 4 and 5 times are the most popular. All right. Let me make sure the poll is closed before I. Oh, I can't do it.
The results of the poll are up on the screen.
Just
Right
go
here?
all the way to the right.
All the way to the right.
It's an extended desktop now over here.
Oh, got you.
Close that at the
Gotcha.
top right. And then just click back into the PowerPoint.
Got you. Yeah, because it automatically pops up into the poll. Gotcha. Gotta find my mouse.
Just go all the way back to your left until it comes onto the screen.
Got you. Thank you. And the answer is, look at that. Wait, where did it go? Where did it go?
Dr. Joseph, I don't think there is an answer slide. You're going to have to answer the question for us.
It's 7 times, but I don't know. No, but I like the big reveal with the whatchamacallit and the thing. Ah, man. Anyways, you guys get it. It's a large disparity. It's a problem. That's why we're here. But yeah, so it's like 7 times more. Right. Alarming, right? Alarming. That's why we're here. So it's, asthma in general, obviously, is a large disease burden. 26 million Americans and counting live with asthma. I do find that a lot of people live with asthma, and that's the people who've been diagnosed with asthma, right? We all know there are a lot of people that live with asthma that aren't diagnosed with asthma. Maybe during the family reunion, I use my cousin's albuterol or things like that maybe, they fly under the radar. Some people also don't call themselves as having asthma, especially if they use as medicine PRN. So this the number one cause of missed school days. Asthma and health equity kind of go hand in hand. Asthma affects African Americans more, especially in underserved areas, and the prevalence is increasing. As income decreases, asthma prevalence increases. So it's indirectly proportional. And I don't think that surprises anyone because as you guys know, asthma medication, there is no $5 list for asthma education. There's $5 for other things. All the other things are important. However, breathing is very important. And so the fact that that's not, so we were just at Asthma and Allergy Day on the Hill in May, really trying to lobby for things, just legislation that will really help both take care of patients and really just help patients adhere to their medicine. Because we know a lot of times when patients aren't able to take care of themselves, it's not for a lack of desire. It's due to a lack of ability for a myriad of reasons. But yeah, so when your income decreases, you can't afford your meds. I have there's patients who have to take one med before they take what will work for them, and so it's like, well, I have to spend my copay money on this medication because my insurance says I have to try it first. When we know that this is not going to be adequate to control them, but it's like, all right, well, I guess this is what we have to do for insurance, right? And that's doing the patient a disservice in all, from a financial standpoint, from a time. And we know that when it comes to asthma, the lack of control increases lung remodeling. So we're spending a month trying to try you on this medication that we know is inadequate, during which time your lung is remodeling, it's inadequate symptom management, but the insurance says you have to try it first, otherwise you'll get denied. Let me not get into my soapbox. Let me come on down because I'll start preaching on today, and it's not Sunday yet. Okay. So asthma in African Americans, see, that plot was the thing with the question with, you get it. Anyways, so the African American population is 30% more likely to have asthma, 3 times more likely to have an ED visit associated with asthma, 3 times more likely to succumb to death due to asthma, but the kids are 7 times more likely. I think the 3 times, some of you guys may have picked 3 because, from an adult perspective, that type of thing. But once you get into kids, that's when it really jumps up. So they're 7 times more likely to have an asthma death than their non-Hispanic white counterparts. So the numbers is, really help us really bring home the disparity that is in asthma. And I mean, we'll spend today talk about asthma guidelines, talk about maybe some reasons for disparities, and talking about how your whole environment as a whole. And it's really a systemic issue as to why these disparities. So you really just it's a whole big picture thing. So now, let's get back to a little bit to equity. So why is that health equity important? I went over these stats because just the stats alone help emphasize why health equity is important, especially in children. And so if we're talking about how, that the children are our future, it's a great song, everyone sings it. But if we are really, right, if that's really important, right, then that number alone should be enough to push legislation. That number alone should be enough to, push insurance changes, plan changes, subsidies, maybe to help some, maybe to help a maintenance medication or make some maintenance or most common maintenance inhalers, at least the pediatric dose, be on like a cheap list, if not $5 or something like that. So those numbers alone should help. However, the key word here is should. We know what should happen, but we know what doesn't happen, and we know what, so we're here really to come in a collective force to increase awareness where there isn't, to give a voice where it's needed, and to really help come together to help problem solve what we know is a problem or is an issue. So when we talk about that, we talk about representation is important. Oftentimes, your people taking care of you don't look like you, and that is a whole host of problems that it can prevent. But being able to relate to who's trying to take care of you is really an important part of healthcare in general, right? You think about therapy. If your therapist is able to understand you, it's much, more likely that they're able to help you. So we want to be able to better understand our patients, but, we realize diversifying the face of medicine helps just take care of our patients in general, because it helps the field taking care of them look like who they're taking care of. But, physicians are, there's less than 5% of allergists in the United States are Black. And so that's really important for us at the National Medical Association, more specifically the allergy section. I'm the immediate past chair of that section, and it's really important that we increase awareness of the profession. I can't tell you how many people I meet that have never met an allergist, much less a Black allergist. And when I throw the I word in there, everybody gets lost. Immunology, and it's just like, all right, well, there's just a system. And then when you get sick and it's, never mind, this is not a party trick. Anyways, I'm an allergist, it can get a little bit, but again, trying to increase awareness, because a lot of people don't realize there's a specialist that can really, tailor your care to the point that you can thrive. And maybe you've wanted to be an athlete, and, all these things that you want to do, that we can help you do better. The Journal of American, the JAMA, I'm getting all mixed up. But anyways, JAMA, realized or did a research and realized that the presence of Black physicians in a particular county, I don't know what that word says, but it's supposed to say county, improves many aspects of community health. So meaning just the presence of one improves all aspects of that community's health. Adherence to medication, their likelihood to actually seek care, their decreased mortality in Black patients. Really, so diversifying, increasing representation helps all of us in general. All right, so running the end here, what can we do, right? So I talked about the stats. We talked about how stagnant it is. We talked about what's important of health equity. We talked about what the lack of resources. We talked about all that. So the question is, what can we do? So first, we can increase the awareness and education of asthma allergic diseases. Without knowledge, the people perish. We all here, a lot of us are health professionals, and we have the knowledge. It is our duty to increase that knowledge and to share it with others, because a lot of times things aren't done because of a lack of knowledge and lack of awareness, not from a malintent. It's really a lot of times people don't know, people don't get it until something happens to a loved one. And then you realize how staggering the numbers are. And so partnerships like the Asthma Allergy Network, the National Medical Association, the EPA, those partnerships are important, because together we can, and being able to, really help us push the needle forward together is really helpful. Patient education, like Lynda talked about with the Trusted Messengers program. We want to increase awareness of health disparities, right? Because a lot of people, maybe asthma is an issue because somebody you knew had asthma or succumbed to asthma. But those numbers I talked about really drive home the disparities and really kind of help, should spark a question of to why. And really we can get into, we'll get into that, with the lectures later on today. We want to, talk about legislation, which we talked about before. We want to give a voice to health equity, which we talked about with the National Medical Association. And we really, lastly, we want to gather like minds alike, which is what this is all about. The ASthma Summit, the National Allergy Conferences, which is this conference, the ACAAI conference, the AAAI conference, that type of thing. So you just, sometimes the struggles you're going through is not unique to you, and you can meet someone else that maybe had gone through that struggle, whether it's, trying to take care of a complicated asthma patient, that type of thing. So tell them what you told them. So our journey today, we'll start with some facts and stats, which I just went over. Some people are going to go over some more of that. Talk about asthma programs, patient education tools and programs. We're going to hear about some stories. We're going to talk about asthma care guidance updates. I'm talking about the culture of asthma for the culture, and then talking about environmental factors, the environment and all its factors that can affect asthma. So that's where we're going to go. So with that, let's get started with the summit. And it's thanks. Oh, stop it. No, keep going, keep going. I'm kidding. So Dr. May is our next speaker. So Dr. May is what I like to call a powerhouse. She's currently the president of the ACAAI. She is the division chief of the AI in Peds Rheumatology and Medical College of Georgia, professor of pediatrics. She's the program director and fellowship. Before she became what she's doing now, which is amazing and powerhouse, she actually was in private practice for over 20 years. And she is on the board of regents for ACAAI and has been awarded Distinguished Service in Women in Allergy Awards. I can go on and on about her because she does so much and do so much, and she looks so humble. She looks normal. You're not normal like us. You're not normal like, I could, we could write a book. But please, everyone, Dr. May is going to be talking about the current state of asthma in the United States. Please welcome Dr. Kathleen.
So first to figure out how to get my slides. No, but the slides themselves. Or is it?
You advance it.
Just advance.
It's all in one.
All right. And how can I see my thumbnails? Yeah. So a bigger, okay.
Maybe.
That'd be nice. I have some.
Do this,
Yeah, I'm gonna need to see. Can I shrink this?
Oh, you want to just make it bigger though?
Yeah.
Oh, and you want to see this instead of right here?
Yes. Sorry.
Like this? Or is that too small? You want to just minimize this?
I want to be able to see this. So yeah.
We'll just do that.
Okay.
And then
And
that
now
way
I can
that
just
still-
advance.
Yeah, hopefully
Okay.
that still works.
Thank you so much. Thank you. I think we're good. So I very much appreciate oh, are you all right? Very much appreciate the collaboration that we have with the Asthma and Allergy Network. The college and the Asthma and Allergy Network have had a great partnership for, I think, as many years as the AAN has existed. So we're very proud of that collaboration. And thank you for the opportunity to speak to you this morning about the state of asthma in the US. I'm going to go over some statistics and kind of touch on some legislative and advocacy issues that affect all of us, and just give you a general overview. Slide. So our current concerns are that despite what we know about asthma, and despite all of the advances, we still have asthma that is life-threatening, and we still have asthma that is severe and really affects people's day-to-day lives. And so I think back to my time of practice, and even when I was in practice, the two patients in my community who died from asthma both had been labeled as having mild asthma. So even, mild asthma can have severe exacerbations and can result in significant morbidity and mortality. So we're faced with challenges right now, and this is going to increase in time, not decrease. Issues of climate change, issues of pollution, urban crowding in some areas, wildfires, concerns with indoor air quality. So all of these things are sort of coming to a head, and I think they're going to only increase in terms of triggers for those with asthma. So, I mean, certainly, and Dr. Joseph was talking about this, as our population becomes more diverse, and it is becoming more diverse, we really need to understand about how all of the conditions of allergic disease and asthma play out in our communities. COVID-19 certainly has shown us that there's a very variable effect on those with asthma, but mostly we have a number of asthmatics who have had exacerbations related to COVID. So RSV, emerging pandemics, other things that we can't maybe see on the horizon add to the uncertainty of care for people with asthma. Certainly, we know that COVID can have long-term effects, and patients with asthma are not spared from those long-term effects. So finally, the economic realities of healthcare really are putting pressure on our ability to care for patients. Some people have difficulty with access to care, access to inhalers. There was a recent editorial on The Hill that kind of talked about this. I don't know how many of you had seen that, but the concern is actually being raised to the level of Congress. Can people afford their medications? And are we creating, are the barriers so high now that we're creating these huge gaps in care for people with asthma? So we also know that recommended care based on national guidelines is really not always adopted by state health insurance programs and other health insurance programs. You're going to hear about the updates from the NAEPP and GINA guidelines for asthma later. But we know that the medications that are recommended in those guidelines aren't FDA approved for the indication that we're using them for. And often they're not on insurance formularies. So that has become a huge barrier to care for those with asthma, those of us who want to continue to progress and have those patients benefit from these therapies aren't always able to get those therapies for our patients. So question, how many deaths in the US are due to asthma each year? How many would you? I don't know if you have a way to, if there's a polling mechanism here. I don't think so. So how many would you think? So, okay, how many think it's 2,100? Raise show of hands. How many think it's 3,200? How many think it's 3,600? Okay. And how many think it's 4,200? Well, sadly, this is actually, and I can't seem to advance it now. I'm sorry, what? You probably know this better than I do.
We gotta close the.
Close the poll.
Yeah, sorry, it's on the.
Yeah. I don't have access to that. Because I'm looking at the slide.
Yeah, I got you.
You need me to maximize this? I had minimized it.
Yeah.
I may need your help. I don't know.
That's not good. Should be good.
But I can't see my slides, which I need. Sorry about this. If there's technology involved, I will find a way to break it. I guess that's, love to see a larger view of that, but okay.
Is that good enough?
I think so. Okay. But they can't see it on the screen now.
We'll get back to this.
Okay, we're here. So this slide highlights that the asthma prevalence in the US affects 25 million people. I don't know, the print is fairly small, so I apologize. In the upper left corner, asthma affects 25 million people in the US, and of those, 6.1 million are children. And unfortunately, we have 4,200 deaths per year. So we know that without an allergist, care is much more costly, and patients go to the emergency department and have increasing hospitalizations. So this is $3,266. Does this have a pointer? I guess I don't think so. Anyway, so kind of lower left, $3,266 per year, $82 billion in healthcare costs, and again, much higher costs among those who, a magnitude of higher costs of those with severe uncontrolled asthma account for the proportion of those healthcare dollars spent. So we know that asthma quality and allergists improve asthma care and asthma quality. We reduce costs, we reduce emergency department visits. So board certified allergists are very, and have been great at doing this. This is not new news. And really reduce missed days from school, missed days from work. All of these things are very impactful on our patients' day-to-day lives. So asthma, was once upon a time thought to be a single disease. And we now understand this as a spectrum. And not only is it a spectrum, it's multiple different entities within the spectrum. So we've become very good at identifying what are called phenotypes or sort of patterns of asthma, and also what's called endotypes involving biomarkers where we can kind of track and assess the asthma this way. And so this has allowed much improvement in the medications we can offer. And those are precision medications that are targeted at specific phenotypes and endotypes. So since 2006, there have been multiple biologic or monoclonal antibody therapies, and those have been a game changer for those of us treating asthma. And that's a game changer for those who have access to those medicines. So those medicines are expensive, and not everyone is going to have the same level of access. But once you can get a patient that, and we really advocate for our patients, we in the college, the AAN, everyone advocates for their patients for this, but it may not be uniformly available. And so there will always be new biologic therapies and other therapies that are coming along the pike, but we're very excited about the future of this. So we have increasingly recognized that there are racial, ethnic, genetic, and environmental differences in disease states among patients. So continued research is ongoing regarding treatments that are developed based on the role and the understanding of what we call Th2 or T2 inflammation, involving a cell called the eosinophil, which really is foundational to our treatments of asthma currently, and how those cells influence the immune response to cause asthma. And I can leave the slide up because I see some folks taking photos. So asthma guidelines are always evolving and updating. The NHLBI started doing this in 1989, which is the US NIH sponsored guidelines. The GINA guidelines, or Global Initiative for Asthma Guidelines, were started in 1993. They're celebrating their 30th year currently. And those guidelines are updated annually to reflect the most recent advances and the most recent research in asthma care. So we all use the GINA NIH, and the word SMART stands for single maintenance and reliever therapy. And that comes from the NIH guidelines, just for frame of reference. So we use these guidelines in our day-to-day practice. So with each of these guidelines, there's an emphasis on personalized treatment. So, we don't just see a disease, treat a disease, we're treating the patient. So every patient I see, and I'm sure this is true for Dr. Joseph as well, every patient we see, we engage in shared decision-making, because not everything fits for one person that would work for another person, and vice versa. So that is truly important. And if the GINA guidelines, which you'll hear more about today, there's a continuous cycle of review, adjust, assessed in those guidelines. And that's a very key component of treating asthma now in this day and age. So our definitions of reliever therapy and maintenance versus controller therapy is sort of changing, and you're going to hear more about that. So once upon a time, a reliever therapy was a short-acting beta agonist. Now reliever therapy could be something else. Maintenance therapy, controller therapy, all these definitions are changing. As of this year, we have FDA approved albuterol budesonide combination therapy, which is not yet available, but will be shortly. And that is also another aspect that is novel in the past year. So the trend for adults is toward using a rescue inhaler or a short-acting beta agonist with an inhaled corticosteroid or anti-inflammatory therapy. So this has actually been shown, if you look at the data, to reduce hospitalizations, emergency department visits, and need for systemic steroids. So this is a huge thing. And as we get more data, that association becomes even stronger. So the signal we're getting is even more now. So again, I talked about SMART therapy, that single maintenance and reliever therapy is one inhaler with both types of medication. And again, this is the issue we're running into with insurers. Sometimes this medication isn't even on the formulary, right? So we're having a concern, and that is something that we are strongly advocating for. So again, nothing is static with asthma. Asthma can change over time. So we are continuously relying on stepping up or stepping down therapy based on where a patient is. And we assess the patient often and readjust. So of course, that is assuming the patient is able to get to us, which we acknowledge those access issues in some communities. So on September 7th, a new working definition for clinical remission on treatment in asthma was published in our Annals of Allergy, Asthma, and Immunology, and I was proud to be part of this consensus work group. This involved the college, the academy, and the American Thoracic Society. After we came out with this was also approved by Euphoria, which is the European Forum for Research and Education in Allergy and Airway Disease. And so with more treatments available, I mean, this is a great problem to have. We actually are finding people under control enough that we are now defining clinical remission. I don't think, other than someone who would naturally sort of outgrow or kind of go into remission in their childhood, I don't think we've really ever had a point in our, not in my practice lifetime, which is 30 years, we have not ever been to a point where we can even begin to make a definition of remission. So this is exciting. So this is just the start. Obviously, this is a starting point. And the idea of these clinical guidelines is more for kind of research to follow these patients along. They're not really clinically applicable yet, but we will be looking at this over time to see and refining it to see what is really, how would we define remission? So this is a new concept. So what qualifies as remission? I'll give you some of the criteria. So the following, we thought that the following criteria should be met over a 12-month period and applied to those receiving a monoclonal therapy, because that's the group we're seeing this in. So number one, no exacerbations requiring a physician visit, emergency care, hospitalization, and/or systemic steroid for asthma, which could be oral, injectable, et cetera. No missed work or school over a 12-month period due to asthma-related symptoms. So these are a pretty high bar. And then thirdly, stable and optimized pulmonary function results on all occasions when measured over a 12-month period. And we thought we should at least know at least twice during the year that this was normal. So there are some additional criteria that deal with frequency of use of certain therapies, as well as measures of asthma symptoms using a standardized questionnaire like the asthma control test or the ACQ, or that's the ACT, the asthma control questionnaire or asthma control test. So this definition of asthma remission does not really create any change in how we're practicing, but we're just excited that we can even go there. So it allows for us to gather more data, which will go to evolving the definition further and sort of give us some guidance. So areas of interest published research in 2023 in the Annals of Allergy, Asthma, and Immunology, which is our society journal, include long-term use of biologics, use of telemedicine and technology-based interventions for monitoring, maintenance, and symptom control, techniques in asthma evaluation and assessment, the role of Th2 cells and eosinophils in asthma and other allergic diseases, equitable access to treatment, which is a very important concept or a very important issue for us, outcomes for patients with various treatments, treating pediatric asthma in the face of obesity, COVID-19 in asthma patients. That's something that our members are engaged with. So many of these articles are free to the healthcare community, and you can find them at amallergy.org. So if you want to take down that website, you can find a lot of resources there. Obviously, these are more technical, but there are some certain take-home points that I think are applicable and would be, even those of you who are not medical people could probably get something out of it. So the college serves as an important source to help the allergy community stay up to date on information about COVID and asthma, including research and recommendations. So you probably are aware that allergy immunology played kind of a central role in treating asthma since the emergence of COVID. And we've intersected a lot with patients regarding COVID questions, especially regarding vaccines in our specialty. So we know that from an asthma treatment standpoint, it's more important than ever to keep up with the medications and make sure that they're taking their medications regularly heading into a viral season. We can answer questions about vaccines because there's still a lot of vaccine hesitancy. I just actually, and this is a bit scary, saw some news breaking through my AMA link that the pediatric immunization rate is the refusal rate or the exemption rate is at an all-time high. So the COVID vaccine hesitancy is actually spilled over into other routine vaccines. So as allergists, we play a key role in making sure that not just patients getting COVID and seasonal flu vaccines, but that everyone is staying up to date on their vaccine. So we play an important role in that vaccine hesitancy. And I've mentioned all these other points. So our priorities for 2023-24, now we always have a strategic plan and we review this strategic plan every few years. And our strategic plan always includes good patient care, our asthma care for all. And so we want to raise awareness among our PCPs about the benefits of referring patients to allergists for care, not just if their symptoms are not well controlled. So that continues to be a priority. We continue to support the community with the latest information on conditions, treatments, and staying healthy as possible. We have and I'll talk more about the community grants program. We have a grants program with the objective to decrease disparities and promote health equity in the treatment of allergic disease, including asthma. And certainly you see our annals of allergy, asthma, and immunology. We're continuing to publish world-class research in our journal. So we, as I mentioned, we provide grant funding through the foundation and this is to practicing allergists, be they in community practice or academic practice, to address disparities. There's a pilot grant, and then there's a longer term grant that you can apply for once the pilot grant is completed. And we partner with academic programs to increase awareness of the specialty among students from diverse backgrounds. And we certainly have had a longstanding diversity task force with some great folks, Dr. Cherie Zachary, among others, who has helped us assure that we are meeting the needs of our community. And Dr. Joseph highlighted, wherever she went, she highlighted some of those issues I heard as I walked in the door. So certainly, we provide physician education, and we also provide patient and public information. We provide brochures, and we also publish those in Spanish as well, because we feel that it's important to acknowledge that not everyone has the same command of English, and we don't want that to be a barrier for great asthma care. So certainly, as hopefully some of you will be participating in our annual scientific meeting this year, this is one way that we obviously keep our members and our public abreast. We are developing timely and practical resources on a wide range of conditions. Our new anaphylaxis toolkit is an example, which doesn't directly apply to asthma. We do have new yardsticks, and these are kind of very timely updated references. And this year we did one on adult and pediatric cough, which kind of overlaps with the asthma spectrum. We advocate for patient safety, fair payment, and access to care. And I'm going to talk a little bit more about that. So for our patients, we have actually a very robust patient and public facing website. We have about 400,000 monthly unique visitors. So this is an area that is continually updated, and we refresh content. So that has information on asthma and allergic disease. So we actually had a campaign this year, which was directed at primary care providers to increase awareness. This isn't really pertinent to patients, but what it did was it increased awareness to PCPs about the importance of sending the patients to allergists. So this has trickle-down effects for the allergy community. And we actually hired actor John McGinley. That was the actor from Scrubs. I don't know if how many of you, some of you probably know who he is. He's very funny. So he did some very funny kind of targeted kind of commercials or spots for us, which were directed at PCPs. And we've had 3.2 million people look at these videos, and 160,000 have gone to the microsite. And that actually tracks those patients and those providers to allergists and has them hook up with allergists in their community so that they can send patients to those folks. So we continue to stay on top of public health and patient safety issues and advocate for patient safety post-pandemic. It's not really post-pandemic, we're just endemic, but what we're continuing to advocate for our patients. I mean, post-pandemic is a little bit of a misnomer here. So we continue, as I said, to work collaboratively with organizations, including the Asthma and Allergy Network. We work with other specialty groups representing physicians and nurses who provide key touch points for asthma patients. We want to continue the college's position as an advocacy leader for the specialty. And we actually have an advocacy council, which is a separate entity within the college that is our Washington facing group. And we actually had a strike force in shortly after your allergy and asthma Capitol Hill Day, and we work in collaboration with the AAN on that. So we continue to promote world and publish world-class research to enable better diagnosis and treatment. So this year, one of my personal biases is that we don't have enough allergy presence in our schools. So a lot of our learners, our medical students, residents, obviously fellows already know, but a lot of our medical education does not have an allergy immunology presence. And so I realized this coming from practice into academic medicine. But we have the first year of our 2-year initiative for the college. So my presidential year is called the Community Allergist Partnership in Education. And what that aims to do is actually help practitioners in the community set up elective rotations for students, medical students, residents, and then possibly fellows to kind of expose them and to the field. I mean, initially for the medical students and residents to expose them. Obviously the fellows in allergy already know about the specialty. So we recently launched our website to facilitate this, and there's kind of going to be a toolkit for practitioners. So there are 84 allergy fellowship programs in the United States. We graduate about 150 fellows a year. And if you think about the millions of people who have allergic disease, you actually would understand how not all of those patients will even know what an allergist does or have access to an allergist. But we feel that by educating other healthcare providers from their educational, when they're in their education, that actually will help influence their knowledge of our field and kind of who to refer and sort of what we do. So that will provide ultimately better care for our patients. That's where I'm going with this. So in phase 2 of this, we have plans to launch, and this is Dr. Galen Marshall, who's going to be president after Sunday. Dr. Galen Marshall is talking about adding a research component to this so that the community practice can kind of aggregate data about our patients and for the betterment of our patient population, because metadata is very important. And in allergy, we're very fragmented. We don't have access to a large data pool. So this may be something that is possible down the road. Details to be determined. I will let him speak with you about that next year. So we're excited about kind of broadening and increasing our education of our medical colleagues in this regard. So specific advocacy examples, we continue to support Medicare payment reform. We are working to reduce prior authorization burdens by supporting access to safe, effective, and affordable medications and treatment options for our patients, affordable and high quality healthcare and insurance coverage, innovative therapies and technology to advance medical treatment. And this includes, expansion of the telehealth or emergency and payment for that, because the concern is that access will go away for some patients over time. We support physician-led team care. I talked about the telemedicine already. We are trying to limit insurers' carriers' ability to impose these unreasonable limits on step therapy and these unreasonable reviews, which are also creating barriers for our patients. And then we recently, the Advocacy Council has invested in tracking state legislative activities that affect our patients, because what we've learned is each state has different challenges and the patients in those states may have different barriers to care. But these state activities can often trickle up into national issues too. So we're trying to kind of have a more global and more state-specific approach at the same time. So we continue to work with other organizations on funding requests and legislation. So one example was a request to the CDC for full support of National Asthma Control Program funding for 2024. And we did this in conjunction with a number of groups as noted here, including the Allergy and Asthma Network, of course, which is listed first, along with CHEST, ATS. I might have had a little help with these slides. So we will always advocate for our patients and to have access to allergist care and appropriate treatments. So for more information about the college, our public-facing website is ACAAI.org. There's a tab that you can say for the public, and then for us in the profession, it's college.acaai.org. And with that, I will take any questions that you might have.
Hello, everyone. I have a microphone, so if
good
anyone
to
has
see
any
you.
questions, I can bring you a microphone.
Good morning, Dr. May, and
Morning.
I'm Nation Hornsby from New Jersey Department of Health, Assistant Commissioner. I thank you for the presentation. I also thank you, Dr. Joseph. One quick question on the slide where you talked about remission. That's very
Yes.
exciting.
Yes.
What I would like to know is, what do you have in mind? I know it's developing, but do you have in mind that it would be the remission would be called by the pulmonologist, allergist, immunologist, respiratory therapist? Who's making that call? If it's twice a year, and once you get on that category of remission, what's the next check?
So the initial impetus to do the remission was that we were noticing people doing so well. So right now, this is mostly a research tool. So this is still in development. So this is going to be used for data generation. So we actually, to answer your question, we're not quite sure on the next step, but we are using it to collect data to see where we are. Because right now, think about this, we don't have any of these metrics, right? So this doesn't exist. So we thought we'd start with a framework and kind of go from there. But the idea would be that it would be the specialist who's calling this, because really the person who's going to be prescribing the monoclonals is going to either be a pulmonologist, pediatric pulmonologist, or allergist immunologist. So that's going to have to be who is the driver of this. But the idea is that the data is not really available yet. I mean, we don't have good data on this. We just felt like, okay, if we start with this, we don't know how many are going to achieve this benchmark. We don't know what therapies, we don't know the patient mix. We don't really know. So it's exciting. So this is, again, this is not a clinical tool yet. Now it'll start as a research tool. I envision, maybe 5-10 years down the road, we'll know more, but I don't think we're there yet on the clinical piece. So I just threw this out there because I'm passionate about it, but I'm not sure it has an applicability in the community practice as of yet. Does that help clarify? Okay.
Hi, Dr. K. I'm here.
Oh, okay. The light is right. You're right
just
below.
right
Okay.
where I am.
Blinded by the light. Yes.
I'm Wanda Dunham from the American Lung Association, and just kind of follow up on Sean here on the remission. I just heard it not too long ago from one of our doctors in Florida. I'm in Florida, and she said allergies and immunologists and asthma too. She's double. Dr. Nina Ramirez. Hello. But anyhow, on the slide that you talk about remission, it just talks about the biologics. So what in that data, and I know there's no, I just heard you about that. What about the patients that they're in biologics, but also are in a controller medication too?
This wasn't to the exclusion of a controller medication. So this was just, the only bar would be someone who's on a biologic. We know with the other controller therapies that no one has really met. People don't meet this definition. So that wasn't really even considered. But now some people are going on biologics and we tell them not to, but they stop their controller, not they just do it because they feel better. But this isn't, this doesn't so the controllers aren't included in this. This is going to be more rescue therapies, and the
More
controllers, the
biologics.
maintenance medicine is not an exclusionary issue for this. So
Okay.
that's a great question.
Thank you.
Yes.
So
And-
Dr. We have some online questions and there's 4 of them.
I can't
And
see them.
they right. So I'll just kind of summarize it succinctly as possible. All 4 of them are expressing concerns about medication access, not having access to the medication they need because of cost, because of co-pays, because of the step therapy, things that we're dealing with and things like that. And the question, generally speaking, is what can be done in order to address all these issues? And it's we know that it's just not the college alone that can solve this problem. It's a big problem across the country.
So our advocacy council is constantly surveilling kind of, like I said, state level issues, national to the extent we can. And we actually reach out and speak with specific insurers, but sometimes the problem is much larger than the insurer. So there's another group of middle management, for lack of a better word, called pharmacy benefit managers. And that is really where we are having increasing challenges, because we can't often identify who to contact in those groups. And those groups may or may not be taking, they may not be as open to conversation. So pharmacy benefit managers certainly work with the insurers to kind of control these things. So that part has been challenging, but we are doing what we can. And either by state or national, depending on which insurer we're talking about, and working with the groups to the extent we can. There's not really one answer, unfortunately.
Right, and we work on that issue too through our advocacy efforts collectively.
And this will be something I'm sure that we will be looking to do at next year's strike force. I mean, I think this is a big enough issue. This may be something that we are bringing forward to our legislators in Capitol Hill. We continue to do that, but this might be a focus, is what I'm saying.
Dr. Kathleen and Dr. Joseph, you guys talk about less doctors in less color and people of color in the allergies. What are you? How do you try to recruit them to interest them to come to that side? Like we have a lot of foreign doctors.
Yes.
That they pass the exam, that they're not because they don't match. They can't do anything.
Right.
There might be a fellowship that can help them to get into this side and interest them and be able to work more on that. And the second one, sorry, the second question was what are the prevention? I mean, we talk about the medication. Is there any prevention to help mom to know this is how to go about it, what to do and what not to do to encourage them and have a community that prevent? I know when people, they used to talk about theophylline medication, and which is high in tea. I know a lot of people don't drink teas here, but is there any way for prevention medicine and all this?
So, I mean, asthma is a complex disease, and there is a section on, so I'll address the second question first, if I may. So asthma is complex, and there is a section, and there are sections in the national guidelines on preventive measures. I'm going to defer that to Dr. Angela Hogan, who I believe is speaking with you later today, because this is kind of beyond the scope of my presentation. Although, I mean, we would love to prevent it. The issue is there are genetic and environmental influences that, so there are things that may be beyond our ability to prevent. I mean, certainly reducing exposure to environmental irritants and you know, but this is a complex process. So the prevention piece, there are some things, but we haven't really found a good way to do that. And I don't know, I'm not aware of any current research looking at the prevention aspect, although others might be. So to address the second piece, there is a program that the college does called SPARC, and this is to spark an interest in the allergy immunology field. And last year we expanded this program to historically Black medical colleges. So we are actually reaching out to those schools and bringing people to our meeting, you know, just to try to improve the representation, the representativeness of our specialty. So that's one thing. The other thing is, in conjunction with the AAP, there are lectureships that go to the historically Black medical colleges. I can't speak to the foreign medical graduates because I don't know how we would capture that, but we can do things in the United States to try to attract an increasingly diverse physician pool to our field, because we are probably among the least recognized specialties in terms of representation. Now, my hope also is that through the CAPE program that I mentioned, that some of our physicians of color may have rotators come into their offices and then increase the kind of visibility in their communities as well. So I think this is going to have a chain trickle down effect, but it's just going to take time, because we really want to be intentional on ensuring that we represent the population. So and the same is true in Georgia. And I've trained 3 African-American women in the last 5 years. So I agree with you.
So I think, is this on? Because I just have a big voice, so I never tell if it's the mic versus me. So answer your question, I think you had asked both us the question. So I was gonna let Dr. May answer the previous question about prevention. I agree, it's a multifactorial issue. So you have to have a multi-pronged approach. But the first thing is environmental factors, which we can control when we talk about secondhand smoking. And then there's been research about third-hand smoking, right? Yeah, just because you take your clothes, you know, you change your clothes when you get back into the home does not, you know, it still affects the baby. So, you know, the environmental things that we can change was one of the very important preventative measures. But in specifically talking about when we talk about diversifying, right, the face of medicine, because we talked about the importance of that. I can speak for the section, our section, the allergy section in the NMA. We, in addition to those programs and partnering, we've now, a lot of us have now recognized the importance of partnering with HBCUs, right? They have the population that we need to increase in all professions. So partnering with them, as Dr. May said, is very important. Us for the NMA, what we've done, we're kind of a boots on the ground thing. So the National Medical Association has a counterpart called the Student National Medical Association. And what we've done is, at least during my term as chair, we actually went to the Student National Medical Association conference, which happens in the spring, and really just increasing the awareness about the organization and really just allergy in general. All those, a lot of people, they come into medicine and they know they want to be an anesthesiologist, they know they want to be pediatrics, and some people don't have exposures to even the allergy and asthma or allergy immunology in terms of a rotation. So, right. So, and then they go to, then they pick their residency based on maybe you want to be pediatrics, but maybe if you think about being an allergist maybe early on, maybe your choice in a residency program, you'd want to pick one that has exposure with that. So just kind of planting the seeds early from that perspective. The SNMA is the largest gathering of Black pre-medical students in the country, and that particular conference. So we go there to try to do that, but also there are programs in the NMA that help these individuals get funding to come to the NMA conference. So that way they can see allergists, talk to allergists, and really talk about what it means to be a Black allergist in the United States, and really help not only spark their interest, but really let them know that there's a pipeline that's going to help you through this should you pick our profession. And also we all look very happy. So yeah.
Thank you, Dr. Joseph. I think I might be over time.
Can I just point out one quick thing on this as well? So there's also the National Medical Fellowship. It's an organization devoted solely to diversifying the medical profession. And it leads the way in providing scholarships to young people of color, BIPOC populations, and it ensures that we are increasing diversity along a number of disciplines in medicine, and it would include this area as well. I happen to know because my best friend leads the organization. The second thing is sometimes we need to look at some of the programs that are funded by the government. And so HRSA in particular, the Health Resources and Services Administration, has a Bureau of Workforce Development. And I, at the State Department of Health, am in charge of workforce development for New Jersey. And so we collaborate with HRSA on funding programs like the Loan Redemption Program, which is very important for minority students. They're going to go into debt trying to get this education. They need a means by which to pay it off. They need to know as they're planning, how am I going to do this? And so that's one program. There's the Health Service Corps. There's a number of different programs. J1 Visa, when you talk about foreign docs, that program I oversee in New Jersey as well. So just those 2 points about some of the federal programs and also the National Medical Fellowship. Thank you.
Thank you. There's another question. I don't know if we have time for another behind you. Turn.
Okay, this will have to be the last question.
Yeah, I don't know. I just see people's hands up.
Hi, my name is Rosa Garcia. I work for Northeast Valley Health Corporation, and we have about 14 clinics. So going back into the remission question or information, we do have an action right now in our clinics for our patients that we have them, the providers, actually, not the allergist or the pulmonologist, but the provider, to have a patient in remission diagnosis, but after 2 years of not having any asthma symptoms, presenting any asthma symptoms, not using any albuterol in any situation. And then when that happens, that's when we providers have them in remission. I'm looking into the plan that you're having on the future for 1 year. It's a little hard for 1 year because sometimes we have patients not even coming back through the whole year until the physical when we're talking about pediatrics, and even worse for adults. So I'm thinking about like in a year, maybe it's like a short time to have a patient in remission, but I'm just sharing what we're doing at this point. And then of course we reinforce the parents that if they show any symptoms, they need to let us know right away. So we bring them back into the asthma tracking. But that's what we're doing right now so far. And in regards to the question of our colleague over there and how we can improve the asthma to control, asthma educators has to do a lot with the providers, and we are asthma coordinators. So we are the ones that actually can spend hours with them, and then we can help as much as we can to go through all those triggers and, you know, the environmental, and that's a clue. That's a very important part of the process of improving those patients and their asthma.
I thank you for those comments. I want to make a very clear distinction. So the clinical remission in asthma is, I think it's not clear, but it's directed at those with more severe asthma. We're not talking about the group who remits in childhood. So I think those are two different groups. So this is the criteria you see here among all these specialty groups were directed at those on biologics. So by definition, these are going to be severe asthmatics. So that's the very small population we're talking about, but important. So thank you all for your time, and I appreciate it.
Thank you, everyone. Thank you, Dr. May. So we'll move on to Dr. Stukus. Awesome. So we're talking about Dr. Dave Stukus next. So Dr. Stukus is he's a social media powerhouse, but he is currently the professor of clinical pediatrics in the Division of Allergy and Immunology at Nationwide Children's Hospital in Columbus. He's the director of the Food Allergy and Asthma Center. I'm sorry, the Food Allergy Treatment Center at Ohio State. He is also the social media editor and of the ACAAI, and he's the producer and the host of a podcast series that they have. He's on the board of regents for the ACAAI, and he's the associate director for the journal Annals of Allergy, Asthma, and Immunology. So for the past 10 years, Dr. Stukus has really dedicated his social media account, Allergy Kids Doc. It's on Instagram and on Twitter. I don't call it X. I don't know what that, no, I refuse. I would not conform. But he really uses that platform to highlight evidence-based medicine and try to combat, provide information, try to combat misinformation. We all know how hard that is because people with misinformation are so convincing. I don't know why people still think the earth is flat, but it's really convincing. So without further ado, I forgot to say he is a board of regents of the ACAAI, and I wanted to make sure that he gets distinguished. He wanted me to say little, but I wanted to say a lot because I know he's a big guy in the game. So please, he's going to be talking about the impact of social media in patient care. Please welcome Dr. Stukus.
Thank you very much for that very long and kind introduction. So why on earth is somebody who focuses on pediatric food allergy speaking at the USAsthma Summit? Well, two main reasons. One was my first love was asthma. That's why I got into allergy and immunology. I helped start our complex asthma clinic at our institution, and then I sort of transitioned to food allergy because I think where we are with food allergy now is where we were with asthma 15 years ago, and we're on the cusp of truly individualized care. But the real reason is because there are very few people in my life that I can say no to. Lynda Mitchell, we've known each other for 15 years. I cannot say no to this person. She is a powerhouse. She's fantastic, and anything I can ever do to support her and her efforts, by all means. So it's a pleasure to be here. All right, what we're going to talk about this morning is how social media impacts all the folks that we're trying to reach, whether you're a healthcare professional, a clinician, whether you work for an advocacy organization, a government organization. I'm going to take you down the rabbit hole and show you some of these. These are my disclosures. And here are our objectives for what we're going to talk about today. So here's my main goal. We're going to go down the rabbit hole. I'm going to show you just a few examples. We could spend all day going over this, but I want to give you just a few examples of how people are being impacted by this. And then most importantly is offer practical tips, because all of us, as you'll see, have a role to play in combating misinformation. So I think, I'm going to try to maximize this so I can see a little better. I asked ChatGPT. I mean, when you give a talk these days, you should ask ChatGPT, right? So I asked, what's the impact of Google on patient care? And it gave some really good answers. And it talked about 10 or 11 different things, how Google is really impacting, the care that we give it. There's increased access to medical information, great access to research and publications, electronic health records have transformed the way we care for our patients, more health initiatives, symptom checkers and things like that, access to health services, machine learning, awareness, education. I think we'll all agree these are very good things. The one thing that ChatGPT did not spit out at me was the role of misinformation. And misinformation was termed the word of the year by dictionary.com in 2018. So this wasn't just a pandemic thing. We've been dealing with this for years and years and years. And before COVID-19, we were dealing with people, 2% of the population believes the earth is flat. That's a true story. 9% believe that the chemtrails from airplanes that fly above us are a form of government mind control. There's anti-vaxxers, which we'll talk about. People used to blame 4G technology for spreading, mind control agents. Now it's 5G technology. QAnon, people drinking bleach to cure various ailments, anti-GMOs, alternative medicine, things like that. And then during the pandemic, the World Health Organization declared this an infodemic in March of 2020. Before it even really spread to the United States. And the reason why is because there was so much information coming in so fast, nobody could wrap their heads around it. And this is when we're talking about alternative treatments and theories about where the virus came from, how it spread, and it was really negatively impacting patient care. And we're all familiar with social media. So this is the way that our world interacts with each other in real time. We're all on social media in some manner. These are just a couple of the different platforms that are available, but we are now communicating with each other in small snippets of information in real time, which is very different than, of yesteryear of long format journalism where you vet the information and things like that. And things have gotten so bad that in July of 2021, the US Surgeon General put out a publication. You can read the title here, Confronting Health Misinformation. The US Surgeon General had to put out a publication confronting health misinformation. That's how bad things have gotten. We heard Dr. May talk about low vaccination rates. This is not getting any better, folks. It's just spreading faster and faster and faster. When I talk to my colleagues who see patients in the office, I do a lot of work trying to understand how our patients are impacted by this, but this really impacts all of us. So if you think about it, when somebody doesn't feel well, what do? They often will go online and they'll look for information for themselves or for loved ones. That can be for their children if they're worried about them. It can be for themselves, and they're going to come across all kinds of different information. And if you just do a common search, and we'll talk about this sort of at the end, this is one of the best ways to understand all of the bad information that's out there. And oftentimes what happens is if you take a chronic disease such as asthma, where there is no single cause, there is no known cure, and there's a lot of desperation, right? This impacts tens of millions of people, and they can truly suffer. We heard about disparities, we heard about the deaths and things like that. This is one example of where snake oil is being sold. So snake oil has been sold for hundreds of years, and people offer miracle cures and false promises and things like that. Asthma is just one example, but this is sort of the playbook that people sort of take advantage of here. And if I lacked a conscience, and if I didn't want to look myself in the mirror, I believe I understand the playbook well enough that I could probably take my show on the road, sell some snake oil, and become a multimillionaire. I have no interest in doing that. In fact, now that I know the playbook, I'm trying to combat it, but here it is. It's really simple. So one, use your medical expertise or celebrity testimonial. I'm Dr. Dave Stukus. I know the cause of asthma. I know how to cure your asthma. Come with me. I'll take you on a journey. I offer a very long pseudoscientific explanation using very big sciencey sounding words. I provide a list of research that backs all of my claims. I discuss why everybody else is wrong. Nobody else has cured asthma. I have the answer for you. I'd make broad claims about what I can do with my products or with my testing or services, and then I would sell. And this is what happens. So you normalize it through saturation. So this is when people show up on Dr. Oz's show and other syndicated shows. You permeate social media. You get yourself into retail pharmacies. We see this. I do a lot of work with food sensitivity testing and how it's unvalidated. Now you can order that through DoorDash and get it sent to your home, and they scan your blood for all the food sensitivities that don't exist. But this is the playbook here. And if you know this, you'll see this everywhere. So when you see the sketchy things on TV or you see them on websites you come across, backtrack and see how they got there. This is often the playbook. So some examples, if you go online and start looking for things, there are all kinds of natural remedies that are being offered for asthma. This is from WebMD. I would say that the vast majority of the general public would say that's a trustworthy source. What do they talk about in this article? They talk about acupuncture, the asthma diet that's all over the internet, caffeine, we'll talk about in a second, biofeedback, some different breathing techniques that are promoted by holistic practitioners, yoga, weight loss, herbs, and supplements, and things like that. Dr. Axe, anybody familiar with him? Not a real doctor. He's a naturopathic clinician, and he has a very large following of millions and millions of people. This is one example of a YouTube video that has over 600,000 views. In this video, he talks about how you can eliminate asthma by 99% if you follow his advice. I showed you the playbook, right? That's the playbook. Remove your food sensitivities. If you cut out gluten and dairy, your asthma will get better. Not really. Talk about phlegm foods, sugar, big bad sugar, milk, bananas. What are you talking about, Dr. Axe? Why you're going to tell people to stop eating bananas? You're going to cure their asthma? Bone broth, omega-3s. There's a little pseudoscience in here right now. And then supplements. That's what this whole thing is. This is just a scam to sell supplements. But it doesn't stop there. If you go on YouTube, you can see there are dozens of these videos. Watch some of them. Learn from it. See how people are being led down this very bad path. And they're being told that they can cure their asthma by all these natural remedies, and you use these emotional anecdotal stories and things like that. So how do we fight back? Well, I think it helps to really understand some of the other tools that people are using to manipulate people. So we're gonna get into that a little bit. Okay, so here's our poll question. What scientific evidence is most reliable? For those of you in the room, show of hands. Systematic reviews, randomized clinical trials, cohort studies, case control studies. You're not sure. So online we have, what do we have here? Randomized clinical trials. Yeah, so if we think about evidence and the quality of evidence, systematic reviews combine the body of evidence that exists surrounding a topic. So that's what we want to use, but not all the evidence that's out there is of course, of that high quality. So I'm going to see if I can, is this where we're having issues? I'll let you do your job. You're very good at it. Okay, thank you. So we know what constitutes evidence, and you see the hierarchy here. So when we have these meta-analyses and systematic reviews, that's really where our clinical guidelines come from. When they publish the GINA guidelines every year, the NHLBI guidelines, they're not relying on one single study or one case series or cohort series or anything like that. Oh, it's still up there. But there's different levels of evidence while he does that. But for a lot of the folks out there, they think if you go online and you see something on a website or a YouTube video or a blog post, people construe that as being evidence. And if you find it on the internet, it must be true, right? Yeah, well, not so much. So we need to understand what actually constitutes good evidence. But the quality matters. So there's been more and more research in recent years that have been published looking at what's the quality of online information regarding asthma, anaphylaxis, food allergy. Do you think it's really high quality information? No, it's not. So it's very unreliable. And these are even from reputable websites and being shared by healthcare professionals and things like that. There's another example here of essential oils for asthma. I think there's a poll on this one, Lynda. Okay, so which essential oils are proven to be helpful for asthma? Show of hands, eucalyptus. You see where we're going with this, right? Tea tree oil, Roman chamomile, all of the above, none of the above. Did we get 100% none of the above? Almost. There's one person out there, the eucalyptus person. I don't know where you are, Mr. and Mrs. Eucalyptus. All right. So if we could take this one down. All right. So you saw the article, the headline, and things like that. So it very proudly, proclaimed, here are the essential oils that can treat your asthma. Thank you very much. I think that's our last one for this one. All right, there we go. But rule number one, always click through. Always look at the citations, no matter what website you're looking at. Before you believe anything, vet the information. So this is one example. They go through and they say, these are the essential oils. So I click through. Lavender, they quote a study done in mice. Unless you're treating a mouse with asthma, that has no relevance whatsoever. Eucalyptus and tea tree oil, there were studies done, but these were for non-asthma conditions, such as atopic dermatitis, or they just generalized to, they decreased inflammation. And they say, oh, if it decreases inflammation, asthma has inflammation, therefore it must treat your asthma. That's not the case. Roman chamomile just had a dead link. And then the ones at the bottom, these were human studies, but they were done with very poor methodology. So they have multiple citations on this website saying these are the essential oils that can fix your asthma. But if you actually look at the evidence, it's very low quality evidence and it doesn't actually apply. I talked about pseudoscience before. Once you learn how to spot this, you will see it everywhere. Inflammation is the sort of the catchphrase that everybody's using these days. As an allergist immunologist, I know that there's different types of inflammation. Oftentimes with asthma, there's Th2 inflammation that causes eosinophils to get recruited. There's Th1 inflammation with neutrophils, but people just throw this word out there. They talk about detoxes and cleanses and fatigue and all natural and going chemical free. They say that we're all shills for big pharma because we push medications on people and things like that. So these are just some examples. And if you learn how to spot them, you will see them everywhere. This is one of my favorite examples. Have you seen the Himalayan salt lamps? Yeah, you can buy these at Bed Bath & Beyond and other places, and they cost $20 to $50. So this goes back to years ago with people who had chronic respiratory complaints would go into these caves in the Himalayan mountains, and it would help them expectorate their mucus. So these geniuses said, well, instead of having people travel to the Himalayas and go inside the caves, what if we took a chunk of the salt, put a little light in it, and put it in their bedroom, and then we could treat their asthma that way? And here are the explanations. The main culprit of asthma lies in the water vapors that dance around in our room, and they're filled with allergens like smoke and odor and viruses. Oh, well, all right, that sounds really important. The surface of this pink salt attracts the moisture or water particles because it's astounding hygroscopic properties. There's some more pseudoscience for you. They constantly purify the air. And then they go into this long explanation about how we're all surrounded by negative ions. And they talk about how, do you ever feel better after a thunderstorm? Well, that's because the thunderstorm washes all the ions out of the air. And that's why you feel purified afterwards. $50, it'll fix your asthma. And then we get people that are sharing anecdotes. Now we know anecdotes are not evidence. Anecdotes are one person's story. And there's a common analysis that is done in medicine. It's called a post hoc analysis. The Latin translation is post hoc ergo propter hoc, after this, therefore because of this. So people go back and they data mine. They look at all the data that they collect and they say, oh, wait, there's associations here that we can kind of tease out. But their study wasn't actually designed to see if it was a causative or it was more correlation. And this is just one example in the cartoon I love. This person says, you've got to try this miracle cure. It's amazing. Well, how do you know that it works? Well, I took it and I felt better. But how do you know it wasn't just a placebo effect? Because I took it and I felt better. But isn't it possible that your body just took care of itself? I took the miracle cure and I felt better. And it goes into this whole thing. So we see this a lot with the gluten-free industry is $1 billion industry because they've sold us that gluten is the cause of all that ails humanity. And there's a really interesting phenomenon where people adopt a gluten-free diet. They often feel better. But what they're not taking into account is that it's not necessarily the gluten, but it's what they're eating that gluten is present in, like highly processed foods. And also maybe they're paying attention to their exercise more, focusing on sleep hygiene, cutting back on their alcohol. So one example that, we create our own narratives in our head and we don't like feeling that we're wrong. And we'll talk about cognitive biases in a second. Asthma and how it's portrayed in movies and television. Do you remember the movie The Goonies? Mikey? Yeah, so there's two things from this one. So one, early in the movie, every time he gets scared, he takes a couple puffs of his inhaler. So it shows that he's, it's a sign of weakness. And at the end of the movie, he finally gets the kiss from the girl and he takes his inhaler and he throws it in the ocean and says, who needs it anyway? So there's, so many portrayals of this. This is a great article that addressed this actually in self.com because it does talk about how they make asthma seem nerdy. And that's such a detriment to those people living with asthma. That is not the case at all, but that's how it's portrayed all across, regular media and things like that. Oftentimes people think that correlation equals causation. This is one of my favorite websites, Spurious Correlations. If you look at this, these two lines look like they mirror each other very well, right? So the red one is the number of people who drowned by falling into a pool. And then the black one is the number of films that Nicolas Cage appeared in that year. And as you can see, this correlates very strongly. It would be incorrect to say that Nicolas Cage is causing people to drown. However, he was in the movie The Unbearable Weight of Massive Talent where he spent time in the pool. So who knows what happened after watching that. And then we see these bad headlines. So this is where we talk about the very strong, very powerful, very rapid anti-vaccine propaganda that spreads like wildfire. This was just a couple of years ago. This study was not designed to see if childhood vaccines cause asthma. This was one of those post hoc analyses, but the headlines read this. And they took it and it spread like wildfire. And you'll see this everywhere. So when Damar Hamlin suffered his cardiac arrest almost a year ago on the football field, within minutes, there were very strong social media accounts online saying, another athlete dying suddenly. They're blaming the vaccines for this. People are becoming more and more aware of this. This happened when LeBron James's son collapsed on the basketball court. Within minutes, they blamed the COVID vaccines. When the actor Matthew Perry passed away a couple of weeks ago, within minutes, people were saying it's because of the COVID vaccines that he was a very strong proponent of. This is what they do. They weaponize it. And then if you read this, as we heard Dr. May say earlier, this is having very real effects. And people are not vaccinating their children for very safe, very effective, well-proven vaccines. And then, of course, there's the anti-GMO propaganda. It has been well established that these genetically modified organisms are very safe for human consumption. They're not causing increased, anything. This one article alone uses the word toxins 8 different times, and they use inflammation 4 different times. But this speaks to people's ideologies, because if you're already anti-GMO, this is one more piece of information that you're going to say, this just supports what I already believe in. And what this does is it creates unequal balance. And you see all of the scary headlines and the fear mongering, and it scares people and they don't know what to do. They're trying to do the best they can with the information that they have. But what do they do when the information is really, really bad? Our cognitive biases are very powerful mind hacks that we all have that help us navigate the world that we live in. We're constantly bombarded by different inputs of information. And this is the way that we, navigate the world. These can be very strong. One of the strongest ones we see is confirmation bias. We all have this. One example is, how many of you spend equal amounts of your time getting all of your information, 50% from CNN, 50% from Fox News? Nobody does, right? We all like to go towards our ideologies. We want to get the information that confirms our beliefs, and we're going to refute the information that goes against our beliefs, even when the evidence is really, really strong. And when it comes to health information online, that happens all the time. How many of you know friends or loved ones that say, I did my own research. I know what I'm doing. They're mispronouncing that word. What they're trying to say is, I did my own Google search, because research is not that. And the algorithms feed them the different things that they're looking for, and what shows up on your feed doesn't necessarily mean that it's legitimate. We already showed you some examples. But what's happening now is people are going online. They're saying, listen, I believe that X, Y, or Z cures asthma. You can find information to support that. You can often find research studies to support that, but I showed you they're not always very high quality. And then they refute all the other information. They live inside their echo chambers. They get told the same information over and over again that makes them feel good about themselves. And what we're seeing more and more on social media especially is people are offering medical advice. This is horrific. When this happens in my feed, I shut it down immediately. And I even post about this. I say, if you want to do a magic trick, you want to make like really bad information appear all of a sudden, go on social media and ask somebody a question about your health, because you'll get really bad information very quickly. And people truly believe that they're experts when it comes to this stuff. So what's the harm in all this? People really don't know who to trust anymore. There's, talks about how medical professionals are no longer seen as experts. We saw what happened during the pandemic, where we have vaccine experts that are being attacked by celebrities and those with large platforms, just because they're trying to put out good evidence-based information. And it's really taken on a life of its own. Here's how we fight back. So as we wrap up. So in the early days of the pandemic, we switched from in-person visits to 100% telemedicine visits. And this was in May. And, it was a rough time, if you all recall that. And I learned one day, I was doing afternoon telemedicine visits. It was National Superhero Day. And I said, I happen to have a superhero outfit. Perhaps I will put it on. And then it was interesting because it was only infants that afternoon. So all the parents were like, what is happening right now? But I put this up here because I don't have superpowers. All of us can contribute. Any of us have the skills. We can all fight back. And it's going to take all of us to do that. There's nothing special about me or about what I'm doing that any of you can't do as well if you're interested. So this goes back to that US Surgeon General's report. There were 3 take-home messages. 1, proactively engage with patients and the public. So we want to go where they are. We know they're going online. We know they're on social media. We want to reach out them where they are. That's where they are. Use technology and media platforms to share evidence-based information, partner with community groups and local organizations. Another reason why I love being here today is because look at this room. We all have different backgrounds. We all come from different areas. We have different target audiences, but we can all align together and we can fight back collectively and we can take control over all the bad information that's out there. Or we could destroy the internet. So I got my first email account when I was a freshman in college. So I am old enough to remember the world before we had information at our fingertips. And I sort of, miss those days in some respects. I know a lot of you remember those days as well. But I think what we really need to do is just acknowledge our online world. This is the world we live in. Love it, hate it. You can say, I disagree with it. It's not going anywhere. It's only getting worse. And now with artificial intelligence and deep fakes and everything like that, it's just going to go to a whole new level. So we can address all the noise and we can fight back and provide quality information. I mentioned before, if you really want to get involved or just spend time, grab your favorite adult beverage, start plugging in questions. And then don't stop on that first page. Go to the second page, go to the third page. And once you go down the rabbit hole of some of these bad sites, the algorithm will think that that's what you want to get. So it'll change your feeds. My search engines are so unreliable these days because of all the stuff I do looking at this stuff. It's just amazing. You can become an asthma mythbuster. There is no such thing as a hyperallergenic cat or dog. Sorry. So have you heard that milk increases mucus production? No, it doesn't. So this is a review published just a few years ago in the British Medical Journal. So there's no evidence that milk actually increases mucus production. Perhaps if you already make a lot of mucus or phlegm and you're drinking milk, it may alter the texture of it, so it may seem different. But there's pediatricians in my community that tell people to stop eating dairy when their child gets a cold. That's insane. There's no evidence to support that. So we can fight back. Go to the previous slide real quick. Oh, there you go. I've been on social media as a professional for about 10 years, and I get frustrated at times. I started creating memes like a year and a half ago. People love it. It's unbelievable. So I say, okay, I embrace it. And then I try to back it up with some good information as well. So forgive the memes. Caffeine, we saw that earlier, right? We've all heard this, right? Caffeine treats asthma. Let's look at the studies. Really only 6 trials, enough for a meta-analysis, 55 adult patients. And they took the equivalent of about 4 cups of coffee, 95 milligrams of caffeine. They did have a slight improvement in their pulmonary function for about 2 hours afterwards. But when we'd say, can we use caffeine to treat asthma? Heck no. What are the side effects of taking that much caffeine, right? And we have better options available. We have well-studied, proven inhaled medications that can bronchodilate. So why on earth would we tell people to take caffeine? It's interesting because cannabis also has some bronchodilating properties as well. But again, we're not going to tell people to smoke a joint when they're having an asthma exacerbation. At least I hope not. One thing we can all do is we can talk when people come to us with these concerns or they share this information. Let's talk about the harm. Okay, I thank you for coming to me. I'm glad we're discussing that. But let's talk about the downside. If you go down that path, what are you doing? You're delaying the time until you actually receive proper diagnosis. You're delaying the time until you receive proper treatment. What's that going to cost you? And as far as missed work days, missed school days, your quality of life and things like that. This is one of my favorite quotes of all time. If somebody comes to you with these crazy ideas, it's easy. It's super easy. What's the evidence? I am all ears. Please change my mind. I change my mind all the time. This meeting is filled with new evidence that in paradigm shifts with how we're managing asthma. We're using one inhaler for both maintenance and reliever therapy. That's unheard of until recent years. I mean, they've been doing it in Europe for decades, but these are paradigm shifts, but the evidence supports it. So we have to open our minds. So if somebody has, they're sharing bad information, what's the evidence? And you should have really good evidence. So if you say that you can cure asthma, you need to have boatloads of evidence to back that up. And then, of course, we have people that, do buy into these conspiracy theories. And there are multiple articles that really address this during the height of the pandemic, but we can all do these things. So just pause. I know our world, it seems like we need to share information at the exact instant that we receive it. Pause, vet the information. Very few people read past the headlines. Headlines are really, really bad. Headlines are often inaccurate. Read the actual article. I showed you earlier, I showed you one example. Just go through and click the citations. What are you actually sharing with other people in your network? Make sure that you're vetting it before you share it with others. And then when people share it with you, take the time and say, hey, I appreciate you shared this with me, but I want you to know this was really bad information and here's why. And you might be able to alter their practice as well. For clinicians in the room, especially within allergy and immunology, the concept of shared decision-making really has changed our specialty in the way we treat patients. I don't tell people what to do. That's not my job. It's my job to offer what I think is the most accurate diagnosis and discuss treatment options. I used to do this in the complex asthma clinic all the time because there was a lot of steroid phobia. And we'd see these children that had multiple ER visits and hospitalizations. I'd say, listen, we have 3 options. 1, We do nothing different. I have no reason to believe that your child's not going to end up in the emergency room again in the next few weeks because this is what they've done. So we do nothing different. We can see what happens. Number two, I can put them on high doses of oral steroids every single day, and I can guarantee you they will never have another asthma exacerbation. At which point they usually look at me and their eyes get big. I say, you won't like me very much because they're going to have brittle bones, they're going to have stomach ulcers and cataracts, and they're going to gain weight. I said, or we can consider option three. Why don't we try a low dose inhaled corticosteroid? We deliver the medication right to the lungs. Let's give it 4 to 6 weeks. Let's come back. Let's review and see how things are going. So when you frame it in a way where they have the choice, but let them know what the choices are. And now we have smart therapy and other things like that. We help them make the decisions that they're most comfortable with. And if they decide to do nothing, I fully support that. But please come back and see me in the next month. If things aren't going well, or we'll come up with a bargain. If we try your way and you're not improving, then we're going to try, X, Y, or Z after that. So as we sort of wrap up, for all of you out here, as I mentioned, I'm not a superhero. All of us can be online. We can combat this misinformation. So it's whether it's social media platforms, the website for your organization, or for you as a person or a professional. Anytime you can give media interviews, be a guest or a host of podcasts, any publications that you have, whether it's for the lay public or research oriented or things like that. YouTube is a very popular forum where any of us can go and set up a YouTube channel. It's very easy. You can post videos on there that go into longer, detailed explanations of things and stuff like that. So I joined social media about 10 years ago. I started on Twitter, whatever it's called now. That's a hellfire. I moved over to Instagram. I enjoy it. I see my job. I just try to put out good evidence-based information. I like engaging. I learn a lot from everybody I interact with. We have a course at our institution where we teach medical students and residents about how to use social media as a medical professional. We published a textbook on it. Our institution has blogs written by thousands of healthcare professionals at our institution. And this is just sort of the way I've approached it. But this isn't for everybody. And I would encourage you, just start small. It takes time. It takes time to find your voice. It takes time to find your audience, but keep at it. And I truly think you'll find it worthwhile. All right. So one thing we can all do is just, anticipate these concerns. We know that people are getting really bad information. We can address this every opportunity we have, ask permission to discuss. Oftentimes I'll say, if you come across anything online or somebody tells you something that is different from what we discussed here today, please reach out to me. I'm happy to discuss it with you. Send me articles, send me links. I love being available for follow-up and just make it a normal part of the conversation about this is the way things are these days. So in conclusion, let's go back to ChatGPT, shall we? So while Google's impact on patient care has been substantial and transformative in many ways, it's crucial to recognize there are challenges and concerns, such as maintaining patient privacy, ensuring accuracy and reliability of health information online. I couldn't agree more. And it's essential for both patients and healthcare professionals to approach social media with critical thinking and verify information from reliable sources. While social media can offer valuable support and information, medical decisions should ultimately be based on evidence-based practices and advice from qualified healthcare providers. Thank you, ChatGPT. I think that's a great way to end. So thank you all very much. I'm more than happy to take questions. I know I'll let you tell me how long we have, but thank you. Oh, before I forget, sorry, I forgot to put this in there. If you want good examples, all of these people have asthma. We could spend all day talking about all these amazing professional athletes and Olympians and actors and actresses and singers. And so when you have people that are say, oh, I can't exercise because of my asthma, right? Asthma means I can't do whatever I want to do. These are the examples that we can share with them. And these are positive ways that we can approach this. So, all right, I'm done now. Thanks.
Thank you, Dave. So just a couple follow-ups. Dave and I go way back for when we worked together on food allergy issues many years ago. But what he didn't tell you about is he went viral on TikTok one time, and he has a YouTube. It's a TED Talk, right? Is it on YouTube? And
honestly, I don't remember at this point.
You don't remember, but he has a TED Talk, and if you want to try to Google it and excuse us for using Google to find you, but Google it. It's a really interesting TED Talk where he talks about how he went viral, and it was about vaccines, if I remember correctly.
Yeah, so it was, oh my gosh, 9 years ago. It was a post on Twitter, and it was a conversation where a family refused the influenza vaccine, but they wanted the Ebola vaccine. This is 2014 when there were like 2 cases of Ebola in the United States and everybody lost their minds and they were shutting down airports and stuff like that. And that was like, that hit the nerve at the time. And yeah, it got like 10,000 reposts or so. This is when I only had, a few hundred followers, and it was the scariest thing, but you kind of learn what it's like now. And is kind of crazy, but yeah,
Yeah.
thank you.
Yeah, but I think the gist of your talk, and you can expound on this, is that, we as healthcare professionals, allied health, asthma educators, we have a role in social media just to combat this misinformation. And so if you're thinking, oh, TikTok's just a landmine, I don't want to go there, you need to kind of be thinking, well, I need to be there because I'm a trusted voice for my community and people can find me online. And, if you really want to be horrified, go on to TikTok and look at people demonstrating their asthma inhaler use. And I know everybody in this room will be pretty horrified at what they find. So does anybody have any questions for Dr. Dave?
Just if you know, are there strategies that authentic sites should use so that when someone does do that Google search, they rise to the top and they're not like, you have to search 20, 30 pages to get to legit material?
Yeah, that's a great question. So it's all about search engine optimization. And there's a whole, I encourage you to look at this because you can game the system. People can pay to play. So you can pay money and Google will elevate you artificially so you show up in people's feeds. A really basic way that I think about it is you have to saturate the internet. So it's not just a website, it's the social media channels. It's how often does your popular terms pop up in different feeds, and that's what elevates you. So great question. Thank you. No easy answer. Just you got to keep at it.
We have one online that I think is a good one to ask. With the increasing need to inform while taking into account health literacy and cultural competency, how do you address that in your work?
That's a great question. So health literacy, I don't know if there's talks later on today about it, but the vast majority of the US population has a low health literacy, which means it's not their ability to read, it's their ability to understand complex medical information and then apply to their life and take care of themselves. I think that's why social media is great. If you get a 30-second TikTok video that you get 1,000 people to watch that explains a very basic something about asthma, that's fantastic. I think it's just one example of, we can't just give people the written information. People want to consume it in different ways. So yeah, with health literacy, so these social media platforms force you to keep it simple. And I learned a lot from Twitter's 280 character limits. And if you can learn how to communicate complex medical information in 280 characters, boy, that makes you even better communicating in real life as well. But it takes a lot of practice.
Thank you. Anybody else have any other questions?
All right.
All right. Thank you very much.
Okay, everyone. So now we'll take a little break for everyone's bladder who's jumping up and down and needs, so now you don't have to worry about missing anything. So we'll take a little, about 15-minute break, but, and then coming back. I heard somebody like, oh, 15, I'll let you know when to come back. Just think in your mind 15 and then wrap up around that time and then we'll bring back. But we have it's in the agenda is in there too. Okay, thanks everyone. See you soon. Hello, everyone. The time has come. The time has come. We are back. We are back. Get the phone number, get the email, finish the conversation, get to the T faster, get to the punchline, because we have to go. Because I know sometimes you're in the middle of telling the story. Get to the T, just the T, or just email them the T. All right. Let us move forward with the summit. Welcome back from your break. I hope everybody got to use the bathroom and all that stuff. All right, so moving on, our next speaker is Natalie Sacramento. So she is a research scientist for California Breathing, which is the California Department of Public Health State Asthma Program. And she got her master's in public health degree from University of California, Berkeley. And she leads the California Breathing Asthma Management Academy, which actually is a training program for community health workers, health educators, and it really helps. It's really a program to help them show them how to use asthma education, or how to educate individuals on asthma. She works in various environmental and occupational health programs, including mercury and lead poisoning prevention. And she will be talking about California Breathing and the Asthma Management Academy model. Everybody, please welcome Natalie Sacramento.
All right, thank you everyone for the invitation, and happy to be here. My talk today will be the state of asthma in California and the Asthma Management Academy. Before I start the presentation, I'd like to introduce the California Department of Public Health State Asthma Program called California Breathing. We focus on asthma surveillance and developing interventions that improve asthma self-management, education, and environmental conditions that cause or worsen asthma in the most impacted communities here in California. The presentation objectives for today are: 1, discuss the burden of asthma here in California; 2, introduce the Asthma Management Academy; and 3, demonstrate the impact of the Asthma Management Academy. Now I'll go over the asthma burden here in California. While asthma can be controlled, it's still a large problem here in California. The first asthma measure that we look at is asthma prevalence, which is the percentage of people who have asthma. About 1 in 7 people reported having asthma in California. That's approximately 5.7 million people that have been diagnosed with asthma. To give you some perspective, 5.7 million is about the size of the total population in the state of Minnesota. Besides asthma prevalence, we look at other asthma measures to show the burden of asthma. Asthma-related emergency department visits, hospitalizations, deaths, and missed school and work days are all indicators that show when asthma is not under control. In 2021, which is the year of the most recent data that we have access to, there were 94,000 emergency department visits, 9,700 hospitalizations, and 351 deaths. In addition, 1 out of 5 children with asthma missed school, and 1 out of 9 adults with asthma missed work. Not only that, but asthma is a very expensive disease for the state. Asthma costs $13 billion per year in California, which includes costs from medical expenses, premature deaths, and missed school and work days. California Breathing is committed to decreasing the asthma burden in the most impacted communities. In the next few slides, we will look at asthma inequities. This slide shows asthma prevalence by race ethnicity. We look at both lifetime asthma and current asthma. Lifetime asthma is the percentage of people that have been diagnosed with asthma by a healthcare provider at some time in the past. Those are the blue bars, and earlier I mentioned that 1 in 7 Californians reported having been diagnosed with asthma at some point in their lives. That is lifetime asthma prevalence in California. That's about 15% of the state's population. We look at current asthma, which are orange bars, and current asthma is a percentage of people that have been diagnosed with asthma and report still having asthma or asthma symptoms during the past 12 months. As you can see, asthma prevalence varies by race, ethnicity. American Indian, Alaskan Native Californians, which are the first two sets of bars, have the highest estimated prevalence of any racial or ethnic group that we analyzed. American Indian and Alaskan Native Californians have a lifetime prevalence of 24% and current asthma prevalence of 15%. When we compare across racial or ethnic groups, American Indian and Alaskan Native Californians and Black Californians have higher prevalence than white Californians. Black Californians have a lifetime prevalence of 20% and current asthma prevalence of 12%, while white Californians have 17% lifetime asthma prevalence and 10% current asthma prevalence. Overall, Hispanic Latinos and Asians and Pacific Islanders have among the lowest asthma prevalence of all race ethnicities. Hispanics and Latinos have 11% in lifetime asthma prevalence and 7% for current asthma. And Asian Pacific Islanders have 13% lifetime asthma prevalence and 7% current asthma prevalence. When we look at other asthma measures, we see more racial and ethnic disparities compared to white Californians. Black Californians are more likely to suffer from severe asthma and die from asthma. Black Californians have 5 times the amount of asthma-related emergency department visits, 4 times the amount of hospital stays, and 3 times the amount of death from asthma compared to white Californians. Compared to white Californians, American Indian and Alaskan Native Californians are more likely to have asthma and suffer from severe asthma. They are 1.3 times or 30% more likely to have asthma and 1.4 times or 40% more emergency department visits. Compared to white Californians, Hispanic or Latino Californians are less likely to have asthma than white Californians, but are more likely to suffer from severe asthma. They have 1.3 times or 30% more emergency department visits and 1.2 times or 20% more hospital stays. Now let us explore another group. But before that, here's a poll question. How many times more likely is a Hispanic or Latino child in California likely to have asthma than a non-Hispanic white child? Is that 1.5 times more likely, 2 times more likely, 3 times more likely, 4 times more likely, or not sure? So what do we have? I can't see. 3 times. Folks are thinking 3 times. What about in the audience? 3 times? Okay, I shall reveal in the next slide, but I don't know. Thank you. Okay, thank you. All right, so let's see. So I'm gonna keep you in suspense because right now we're going to talk about just children in general. Looking at children compared to adults, children defined as 0 to 17 years old are more likely to have severe asthma, have 2 times the amount of emergency department visits, and 3 times the amount of hospital stays. Compared to white children, we see Black children are more likely to have asthma and suffer from severe asthma. They are 2 times more likely to have asthma, have 6 times the amount of emergency department visits, and 5 times the amount of hospital stays. And I think the emergency department visits, ours is a little bit less than that 7 times that was reported earlier, which is good, but still really stark. And then here's the answer to the poll question. Compared to white children, Hispanic or Latino children are more likely to have asthma and suffer from severe asthma. They are 2 times, so the answer was 2 times, more likely to have asthma, have 2 times the amount of emergency department visits, and 1.4 times or 40% more hospital stays. This slide shows areas in California with the highest asthma-related emergency department visits. The lines are the county lines, or county boundaries, excuse me, here in California. We define high asthma burden areas as census tracts in the 75th percentile or greater for asthma-related ED visits, which is represented by the red shading. Emergency department visits and hospitalizations are strong indicators of uncontrolled asthma. And as you can see, the red areas are scattered throughout the state from as far north as Del Norte and Modoc counties, all the way down to San Diego and Imperial counties. Because of these asthma inequities, California Breathing focuses on strategies to improve asthma outcomes in these 3 areas: racial ethnic groups with documented asthma disparities, especially in Black communities. We also focus on children and areas of California with high asthma burden, that red shading that you saw in the map. Okay, so now I will move on to the Asthma Management Academy, which I'll talk about for the remainder of the presentation. One way to address asthma and asthma inequities, such as the racial health disparities and areas with the highest asthma-related ED visits that I highlighted earlier, is through community health workers, also known as CHWs. CHWs are trusted members of the community that leverage shared experiences and linguistic and cultural relationships to bridge their community and health services. CHWs is an umbrella term. CHWs are often referred to as by other titles, such as health or patient advocate, outreach worker, peer educator, community health representative, community leader, case manager, care coordinator, community health advisor, promotores de salud, patient navigator, and the list goes on. Within documented asthma interventions, CHWs provide home visits, deliver self-management education, and assess homes for environmental triggers. As peer-reviewed and public health practice literature suggests, families that receive self-management asthma education from CHWs experience improved health outcomes, including reduced healthcare visits and the costs associated with them, better medication adherence, reduce missed work or school days, increase confidence to self-manage asthma, and the ability to identify and reduce asthma triggers. Because of the abundant evidence that CHWs can play an important role in improving asthma outcomes, California Breathing developed the Asthma Management Academy, or AsMA, spelled ASMA for short. The AsMA is a peer-to-peer CHW-led training for community health workers. Through the Asthma Management Academy, CHWs receive training on how to deliver evidence-based asthma self-management education, how to conduct an in-home trigger assessment, and review of best practices for asthma home visiting. The AsMA has 2 goals. The first goal is to reduce the asthma burden in the most impacted communities in California. And the second goal is to provide culturally and linguistically appropriate professional development for community health workers. So the Academy has a lot of components. Uh-oh. I apologize, there's supposed to be a picture of our wonderful trainers. But as I mentioned earlier, the AsMA is a peer-to-peer training facilitated by community health workers for community health workers. We partner with 2 wonderful community-based partners to deliver the trainings, and the Academy would not be the great training program that it is without them. They have the knowledgeable, passionate, and experienced community health workers to implement these trainings. Our first training partner is Comité Cívico del Valle, also known as CCV. CCV is based in Imperial County, so very South California, almost to the Mexico border. CCV has been with the AsMA since the beginning of the program. CCV's motto is informed people build healthy communities. CCV has extensive asthma education and asthma home visiting programs that they have been doing for almost 2 decades, specializing in rural communities. They bring this wealth of knowledge and experience to their academy trainings. We also have a new training partner that will primarily focus on training Black-led organizations and Black CHWs called Roots Community Health Center. Roots is based in Oakland in the Bay Area. They are dedicated to uplifting those impacted by systemic inequities and poverty through medical and behavioral health care, health navigation, workforce enterprises, and advocacy. They are also experienced in providing asthma education and asthma home visiting programs. And I also want to, unfortunately, you don't see their beautiful faces. We're missing the pictures. Maybe we could provide that to you later. But I just want to give a huge shout out to our CHW trainers, our current ones, and that's Esther, Martha, Isame, and Melanie from CCV, and Amanda and Demisha from Roots. We are so grateful for them. And I also see Consuelo in the audience. Hi, Consuelo. We used to partner with Esperanza Community Housing based in Los Angeles. And Consuelo was one of our excellent trainers. So hi, Consuelo, nice to see you. All right, so the Asthma Management Academy uses a curriculum that was developed by the Association of Asthma Educators, AAE for short. The curriculum is called Asthma Education for the Community Health Worker. AAE is a nonprofit organization dedicated to providing quality education to a multidisciplinary group of asthma educators. The curriculum was carefully designed and reviewed by over 35 asthma educators around the nation to ensure participants receive a high quality evidence-based curriculum specifically for community health workers. The training also reinforces the National Asthma Management Guidelines, EPR3, and the training uses the peer learning model so that CHWs train other CHWs. A certified asthma educator, also known as an AEC, is also part of the facilitation training team to provide asthma technical and clinical subject matter expertise. The curriculum was designed to be highly interactive, using adult learning theory because people learn a variety of ways and learn best by doing. The curriculum is also written in plain language, making the training and training materials very accessible. There's also a skill-based testing component, a competency test, which I will talk about later. So these are the different modules that the training goes through. When participants go through the academy, they go through 5 modules from the asthma education for the community health worker curriculum. Module 1 covers the basics of asthma, which includes asthma symptoms, causes of airway obstruction, as well as identifying care providers on the asthma care team, and the integral role played by CHWs. Module 2 covers trigger identification and reduction, so looking at allergens and irritants and how to reduce or avoid them. Module 3 covers medications, which looks at the role of long-term controller medications and quick reliever medications. Module 4 covers medication delivery devices, primarily focusing on learning how to demonstrate use of the metered dose inhaler and dry powder inhaler. And Module 5 covers assessment and monitoring, looking at the importance of evidence-based tools such as the asthma action plan and the asthma control test. There are 2 additional modules that we at California Breathing developed based on the need that was expressed by participant organizations, and those specifically cover asthma home visiting. The 2 modules are how to conduct an in-home trigger asthma assessment, where participants get to practice using the asthma home environmental checklist, and best practices for home visiting, which looks at elements of an asthma home visit and safety considerations. The asthma training provides about 18 to 20 hours of training over 3 days and covers 7 modules, so it's pretty comprehensive. Before the pandemic, all the trainings were in person, and because of the pandemic, we had to shift to virtual trainings, but we're starting to offer in-person trainings again. The training is also available in English or Spanish, depending on the need of our partner organizations. Our training partner at CCV is bilingual in English and Spanish. We keep the training cohort small at about 10 to 15 participants so that it can be full of interactive activities and participants have time to ask questions and get feedback. Many of the participants that go through the academy are learning about asthma for the very first time and are also new to asthma home visiting. The curriculum follows adult learning theory, like I mentioned earlier, which emphasizes that there are many different ways that adults learn. We really strive to make the training highly participatory because many people learn best by doing. We have a mix of lecture, big and small group discussions, videos, role plays, and quizzes to help reinforce the information. The picture on the left was taken at the end of September, and it was our first in-person training since March of 2020. In the picture, participants are reviewing the difference between long-term controller inhalers and quick relief inhalers as a big group. The facilitator would say a fact like relief from symptoms occur within minutes, and participants would hold up a sign of either long-term controller or quick reliever sign so that they could review the materials. The picture on the left is one of our virtual trainings. As I mentioned in the earlier slide, because of the pandemic, we had to shift to virtual trainings via Zoom, and our trainers have been able to keep the trainings very interactive with breakout rooms, polls, and lots of big and small group discussions. It's been very well received, so we will probably continue to offer the virtual trainings. One of the main interactive activities is for participants to learn how to do the teach-back method. The teach-back method is a way of checking understanding by asking clients to state in their own words what they need to know or do about their health in a friendly way. Literature shows that most people with asthma use their inhaler incorrectly, asthma inhaler incorrectly. According to one study, 84% of people with asthma use their asthma inhaler incorrectly. So the teach-back method is essential. Asthma participants are taught how to conduct teach-backs so that they can in turn use the teach-back method during their asthma self-management education sessions with their clients and families with asthma. The medication delivery devices that are taught in the academy are metered dose inhaler with and without a spacer, and one dry powdered inhaler, which we use the Discus. The pictures are examples of participants doing the teach-back method for these devices. Another benefit of the Asthma Management Academy is that each participant receives a training kit that includes the asthma demonstration inhalers, the MDI and the Discus, a spacer, and a peak flow meter. Participants also receive the AAE participant manual and other hard copy training materials. Participants bring these materials, especially the demonstration devices, the spacers and peak flow meters, and they bring it back to their communities and use them to educate their patients and clients. At the end of the training, each participant receives a certificate of completion from us at California Breathing. We use this to help us keep track of who has completed the academy. Some of our partner organizations are participating in some new medical policies for asthma remediation and asthma preventative services. The AsMA is one of the listed specialty training providers for asthma, and we want to make sure that we have these records available for the participants. A certificate of completion is also available from AAE, the organization that developed the curriculum. To receive the AAE certificate, participants take a competency test 1 to 2 weeks after the training. The competency test is a 1-hour Zoom-based test conducted by an AEC. The AAE requires that the participants show a higher than average understanding of the information presented in the program. So participants would need to pass with an 80% or higher. The goal is for the medical community to hold the certificate of completion earned by the CHWs in high esteem to further build their confidence in having CHWs included as part of the asthma care team. The competency test is scenario-based, so it's good practice for participants to think through what they would do with their asthma clients. This is not a certification exam, however, it's a certificate of completion. Next, I will talk about the impact of the Asthma Management Academy. The Asthma Management Academy was launched in 2018. So since 2018, the ASMA has trained 634 community health workers from 91 organizations, including federally qualified health centers, community-based organizations, managed care plans, local health departments, and hospitals. As I mentioned earlier, the Academy is committed to decreasing the asthma burden in the most impacted communities. This slide shows the asthma burden map that I showed earlier, along with the asthma management activity or Asthma Management Academy trainings that we have completed thus far. So looking at the map legend here on the right, the lines show the California county boundaries. The red shading shows the census tracts that are above the 75th percentile in asthma-related ED visits for all ages from 2015 to 2017. The yellow star shows where our training partners, our current training partners, Comité Cívico del Valle is located, which is down in Imperial County, and Roots Community Health Center, which is located in Oakland. The gray shading shows the coverage areas of managed care organizations trained through the Asthma Management Academy. And the blue dots show the different asthma partners, partner organizations throughout the state. Going to the map of California, here on the left side, we prioritize Academy partner organizations serving communities in these red census tracts. Again, the blue dots show the 91 partner organizations and where they are in California. In the first 2 years of the project, we focus our efforts in Southern California, which is home to more than 60% of the state's population. Looking again at our map of the census tract, it's clear that there's a high burden of asthma in the Central Valley, the middle of the state. So we focused on the Central Valley over the last few years. We were also able to expand to other counties in the last couple of years, especially in Northern California, through our partnership with the Asthma Mitigation Project, which was a statewide asthma remediation program from the Department of Healthcare Services that provided $12 million in funding for grantees such as community-based organizations, clinics, and local health departments, with a focus on low-income communities and communities of color who have disproportionate rates of asthma. To evaluate the Asthma Management Academy, we collect various data. The items on the left in purple are the data that we collected from asthma participants, the CHWs that went through that training. We look at data before, during, and after their participation in the asthma. And from these data, we can measure the impact of the asthma management trainings on their capacity to provide asthma self-management education. We collect knowledge-based questions, pre and post-test questions before and after the training, as well as post-test quizzes after 4 different modules. We also have skill-based metrics from the teach-back activity of the medication delivery devices and through the scenario-based competency tests. To evaluate asthma-related health outcomes for clients with asthma, we ask partner agencies to provide baseline and follow a cohort of clients that were seen by CHWs and other health educators who participated in the Asthma Management Academy. The items on the right in orange are the type of data that we collect from our asthma partners. Our goal is to collect 2 to 3 years worth of data from each organization, usually at 6-month increments, to show the impact of the asthma intervention over time. Some examples of client data that we collect include emergency department visits and hospitalizations, asthma control either through the asthma control test or other self-reported metric, and missed work or school days. So for knowledge and skills, asthma participants do very well when they take the competency tests. On average, participants scored 98% on the competency test, which covers the scope of asthma, asthma triggers such as mold, pests, and smoking, asthma medications, and teaching the proper use of asthma medication delivery devices. It also covers using asthma assessment monitoring tools like the ACT and Asthma Action Plan. When our participants hear that there will be an exam at the end of the training, they get very nervous. I know I do when I have to take a test. But as you can see, they do very well because the questions are scenario-based. The participants talk a lot about what kind of asthma services patients and clients would need. Participants are so excited to talk about all these different situations, and our AECs would need to tell them to move on to the next question because they'd be, so comprehensive about their answer. Our participants, the CHWs, are just so eager to help their communities. Oh, sorry about that picture. For the impact of individuals with asthma, we see that among individuals with poorly controlled asthma who completed at least one asthma education session taught by an asthma-trained CHW and health educator, we see that 83% had reduced emergency department visits and hospitalizations. 70% had fewer missed work or school days, and 70% had improved asthma control. So this shows that there is improvement in asthma outcomes for those individuals with poorly controlled asthma, which is what we aim for. So in summary, asthma continues to be a big health concern in California, especially for Black Californians. California Breathing Strategy to reach the communities most impacted by asthma is one of the strategies is the Asthma Management Academy. The ASMA is a peer-led training for community health workers where they learn how to deliver evidence-based asthma education. And asthma education delivered by these asthma-trained CHWs improve asthma outcomes in patients with poorly controlled asthma. So thank you for this opportunity to share our work. We want to thank all those who make the Asthma Management Academy possible. Thank you to our asthma facilitators. Our current ones are Comité Cívico del Valle, Roots Community Health Center, and previously Esperanza Community Housing. And we also would like to thank our certified asthma educators, all our asthma participants and partner organizations, the Association of Asthma Educators, and of course, thank you to our funders at the CDC. And that's it.
Does anybody have any questions they would like to ask? Yes.
Thank you so much for this presentation. It's great to see this work happening across California. My name is Naomi. I'm with the Asthma and Allergy Foundation. I'm doing a lot of work around stock-albuterol right now in schools. And I was curious if, and maybe I missed it, but can you share a little bit on the patients that these CHWs are giving these trainings to? Are they usually adults, parents, kind of, or is it kind of a range of ages? And thinking around kind of different environments, both school, work, or home?
Yeah, it's a range of ages. I think I have a slide that shows the breakdown. Let me look for it. Sorry, all the slides. Yeah, so the last time we looked at the data, about 57% were children, 0 to 17 years old, and 33% were adults. And so when it comes to children, the CHWs usually provide the asthma education to the families, the parents or caregivers. And we've worked with a variety of different organizations. As you saw, we work with CBOs, we've worked with managed care plans and clinics. We're starting to expand the different organizations that we work with. Some of the programs that we work with is specifically to work with Black-led organizations. We've had to work with non-traditional, like what we consider traditional CHWs. So some of them are like community navigators, and they don't necessarily have an asthma program in place, but we're trying to get that into the community. I don't think we've worked that closely with schools, but it is something that we are trying to be more involved in, especially because there was a pediatric fatality that we're investigating. Unfortunately, that happened, I think, a year ago. And so hopefully we can work more in schools.
Sorry, just as a quick follow-up, Governor Newsom just signed stock albuterol in California, and so it'd be great to have a cross-sector of advocates to show that this is something, a resource that they could be promoting in their own communities or their schools, and how do we make sure that people based in the community are asking their local officials and local school districts for this resource. So thank you so much for this.
Great. I will add that to our to-do.
Is this asthma academic? Is it on management academy? Is it only for California, or does it go, or do they have any training in other parts?
Yeah, for our program, it's specifically for California. But I think the Association of Asthma Educators, if you look on their site, they may, because they're the ones that created this curriculum, I think they're also offering some trainings that are available for other states.
Just one observation, and probably something that I don't know if California is doing, but in Florida, we actually are contemplating in bringing the community pharmacies into the asthma education component, because they distribute the medications, they communicate with their physicians, and kind of bring that circle of care between the families and the schools and the physicians and the pharmacy to manage that. So it's something that we just started to explore just a few months ago, and the community pharmacists are really, really happy and excited about participating in this.
Yes, that's great to hear. I think because of the new Medi-Cal, which is California's Medicaid, there was at least one community pharmacy that approached us, and they are interested in doing the Asthma Management Academy. So hopefully we can also start that, because yes, we need all the help that we can get.
Yes, hello. Our online audience has some questions. One question, have there been EPA studies looking at the home environments of the minorities with higher asthma prevalence?
That is beyond the scope of my presentation, but I think there's going to be an EPA presentation.
Have there been EPA studies looking at the home environments of those minorities with higher asthma prevalence?
Yes. Yeah, the asthma home checklist that the CHWs use to do asthma home visits was created by, I think, EPA, HUD, and CDC.
Another question, do you have asthma navigators in the hospital? And if so, has this helped with emergency department visits or readmissions to the hospital?
Yeah, so I think we do, so CHWs, that's an umbrella term, and I think we have worked with asthma navigators in the past, but I don't have that data about the impact on that specifically. Yeah.
Yep, and then we have one more.
Hi, thank you for your presentation. My name is Demi Anastasiades. I'm actually a pharmacist by training, but I work at Sanofi. And I would say I like your question about using your community pharmacists. They're very helpful in that sense, but with the demand of the workload, community health workers are very important. And my question is, in the state of California, are these community health workers reimbursed, or is it just a volunteer program?
I think Anne can answer that. Anne behind you. She's the expert on all things, yeah, Medi-Cal.
Hi, all. I'm Ann Kelsey Lay. I'm the director of RAMP, which stands for Regional Asthma Management and Prevention. I am presenting around 2 o'clock on that very topic. But yes, there are 2 new Medi-Cal policies within California that increase access to asthma education and home trigger assessments and trigger remediation provided by community health workers and other non-licensed professionals.
Thank you, Anne.
Thank you. One more online question. Did you see decreased emergency department visits post-implementation of your asthma CHW program?
Yes, emergency department visits?
Yes.
I think I had a swoop. Uh-oh, sorry. Let me show that slide. Yeah, so we saw 83% had reduced emergency department visits and hospitalizations.
Another question, how often do you retrain your CHWs?
So the CHWs only need to do the training once, but if they feel like they can't need a refresher, we do it on a case-by-case basis, but the curriculum hasn't changed since 2018. In the past, we've also offered refresher courses. We called them, I forget what we call them, but things that aren't covered in the Asthma Management Academy, like pregnancy and asthma. We've done trainings like that. And I think that was, yeah. But to answer your question, we don't retrain them unless they really need it.
Thank you.
Thank you. Oh, that was your computer. Wonderful. Okay, everyone, we're going to flow through the next presentation. We're running a bit behind. So we are having our first dynamic duo of the summit come up. So we have Corinne Young and Dr. Dee Gardner. So we'll talk about Corinne Young first. She is a nurse practitioner. She's worked in pulmonary medicine for over 18 years. She has a passion for advancing the advanced practice provider, which is why she started the Association of Pulmonary Advanced Practice Providers, APAPP. It's a national organization working in pulm care and sleep medicine. And so for over past 5 years, she's brought over $2 million of grant-funded educational program to its members, and she sits on the board of the American Board of Internal Medicine's Pulmonary Disease Board and the editorial board for CHEST, the magazine for CHEST. So that's Corinne, and Dr. Dee Gardner is the Chief Research Officer for the Allergy Asthma Network, and she has got a doctorate in public health with a concentration in leadership, policy advocacy, and community health from University of Texas. She leads the AAN and research mission that oversees the Trusted Messenger program, and she's responsible for leading the survey research programs and coordinates various partnerships and other nonprofit organizations. And so with that, they'll be talking about asthma medications and empowering patients to learn their options. So Corinne Young and Dr. Dee Gardner, please.
Thank you very much for that introduction. I'm glad I brought my glasses. Okay. All right. So I am going to be talking to you about empowering your patients and how to do that. That is my disclosure slide there. Objectives, we are going to try to understand the clinical nature of asthma, understanding this and being able, again, to break it down to digestible information for your patients and your community that you interact with really helps give them more power over this disease, which we're going to focus on. I'm going to briefly touch on GINA. There's going to be an amazing GINA lecture later today, but I'm just going to basically talk about some of the updates that are very relevant to clinical practice and getting out to your patients and sharing that type of information, and then discuss how to empower your patients in their care. So to understand much of anything, I think you have to understand its past and just kind of some fun things I think we don't really dig into on asthma, but it's pretty old disease. I mean, it was described all the way back to 2500 BC as a whistling sound with breathing. You know, we were able to identify that this was something abnormal and that humans have been suffering with for a very long time. 300 BC, Hippocrates termed the actual name of asthma. So that's how long that actual term has been around. And it means it's a respiratory distress causing panting caused by triggers. Even back then, they were able to identify that there were triggers. There were things that caused these patients to have symptoms. And I'm sure some of those triggers, were also demons and other things, but they did know that something was triggering these patients. And in 1905, the asthma treatment design framework is much like it is today, minus the biologic therapies. But really it is, address acute symptoms, have some sort of control treatment for them, and prevention of long-term complications in patients. I mean, here we are still doing that. With a lot more knowledge base, information. This is pre the first pandemic. We really didn't, even in 1905, have a great understanding of viruses and those types of things. And so even then, the framework was there and we've just built upon it. So asthma is present. A lot of this data, again, has been already shared, some worldwide information versus just US based, but a lot of people are affected by this disease, which is why we're here talking about it and have a whole summit about it. In the US, now I am community-based practice. Although my master's is in family practice, I have pretty much solely been seeing adults for the last 18 years. And so a lot of my information is biased towards adults. Kids are gross. But approximately 10 people in the US die of asthma each day. And as I get older, as I get crankier in my practice with patients, I like to bring this up with them because there are patients, although they will believe misinformation and try to treat themselves not traditionally, they will have this level of faith in you and their providers that asthma is curable, that you are going to prevent bad things from happening to them, and that people don't really die of this. It's not a very serious condition. And I love to tell them, people die of this disease. They still today, with all of our advancements in medicine, they still die of this disease. And you get a different look on their face when you tell them that. I would, say that it's very rare when I talk to a patient about that people still die. 10 people every day die of asthma, adult-wise. Most all of them look pretty shocked. I didn't know that, and so I challenge you to have that discussion with the people in your community that you interact with. It helps them level set, an understanding of how serious their condition is. In 2021, the deaths of asthma were around this rate here for adults mainly. There was this respiratory virus going around. I don't know if you heard about it. It was called COVID. Definitely, I think we're going to see fallout from these numbers coming in over the years that are going to be much higher than what we really anticipated as well. And in 2020, again, deaths rose for the first time in 20 years. Likely the C word had something to do with it. So one of the things I love about the new GINA guidelines is that they changed the definition. And this sounds so bureaucratic, but it really is so important, I think, as healthcare professionals to really get your arms around this definition, because your patients have no idea what the definition of asthma is. Their definition of asthma is what they see on Grey's Anatomy. It's what they see depicted in movies and those types of things. And they feel like that doesn't look like me. I don't have asthma. I don't have attacks and I'm sucking on an inhaler all the time. But really what I underlined here is it's defined by their history. History is so important in these patients, even these adult onset patients. If you dig into their history, you're going to find, oh yeah, when I was a kid, I had eczema and I always had a runny nose and I always had allergy issues and I couldn't play sports like the other kids, or someone told me I had exercise-induced asthma, but I never got an inhaler. Didn't mean they didn't need one, right? They just didn't get one. And so we really want to dig into their history. They tend to have these common symptoms, right? Wheezing, coughing, shortness of breath, mucus production, I think should be on there, but it's not. And coughing that vary over time and intensity. That is so key because they feel like diabetes, you always have some elevated blood sugars, or hypertension, you always have some elevated blood pressure, right? Unless you take your medication. Asthma patients are great until they're not, right? So they could be doing fabulous for days, weeks, months, years, and then something happens, right? And they lose control. And to them, a lot of times they feel like this was just situational. My kids were sick. This is just situational. Every spring I get whatever, right? So understanding that, no, that is part of the literal definition of asthma, is that it's going to vary. Our job for you is to try to level that out, so it's not so variable for you. You have more good days than bad. And then they also have variable expiratory airflow limitation. This one is important to me in pulmonary because patients will come from some level of community-based care where they had a handheld spirometry that was normal, and they were told you don't have asthma, right? Normal spirometry does not exclude asthma. And so, because it varies, and if we're not provoking them and sticking a cat in their face right before they blow into the spirometer, they're not going to likely have an abnormal level, right? So, these patients need to understand that although it's normal, it doesn't exclude asthma. You're not crazy. I believe you. You have symptoms, you have issues. Let's address those. So I love this definition if you can't tell. All right. Are we going to advance? No? Yes? Oh, that's how it's relevant to your patients in practice. There we go. Okay, and a poll question. All right, so which guideline, sorry, I blocked it. Which guideline does SMART therapy come from? NAEPP, GINA, both, neither. So I'll have you guys go ahead and answer. And you know what keeps me up at night about SMART therapy? The T in SMART is therapy, and then we say therapy again. So we're saying therapy. So do I call it SMAR therapy? SMAR therapy? SMART? Just SMART? I don't know. This keeps me up at night. Thank you. Okay. All right, so phenotypes. Gina did a really good job in 23 of really updating these phenotypes. I think we all that have been working in asthma have noticed that these patients tend to have these types of phenotypes or presentation. We've got the typical childhood onset, right? They tend to either have one or both of allergic or exercise-induced asthma. Adult onset, they tend to have an atopic history. Again, this is for me personally in adult medicine, digging into their past history of allergic rhinitis, eczema, that type of thing. And when we're looking at those endotypes of markers, they tend to have a little more IgE-driven disease. Adult onset non-atopic. So these patients tend to have had something that, in a nutshell, provoked their asthma. They had a virus and had post-viral reactive airway disease. They had a chemical exposure at work. In Colorado Springs, where I practice, we have a lot of military bases, and I had a kid who was in a tank and the fire extinguisher fell off the wall and filled the place up. He came out looking like a powdered donut, had a lot of inhalation injury related to that, and now behaves like a typical asthmatic patient, never had respiratory issues before. So these patients tend to have a cause effect. They were fine, they had an exposure, now they're not. And then the hypereosinophilic adult onset patients, these are the EOs gone wild, eosinophil-driven patients, and this is where a lot of our biologic therapy is focusing at this point. They tend to have some combination of, again, an atopic history, reactive airway, nasal polyps, allergic rhinitis, those types of things. They tend to have active allergic symptoms, independent or in conjunction with their asthma. And then there are these other phenotypes of asthma associated with obesity, which could be a whole discussion in itself and can be very defeating as a healthcare professional to talk to your patients about, because you start talking to them about obesity and then they have shame and they have, this wall that kind of comes up that you just think I'm breathless because I'm fat, those types of things that you really kind of have to break through with them that say, no, this is actually a type of asthma. It's not necessarily that you're just breathless because you're overweight. And then perimenopausal asthma. In pulmonary, we hate talking about anything below the diaphragm, but sometimes you got to go there. And, you see these women that are menopausal, perimenopausal age that were not symptomatic before, now are, again, something you might want to dive into those patients. And they don't tend to respond to a lot of your allergic therapies because sometimes they're neutrophilic driven, which is a whole nother discussion, and some research that's currently happening right now for neutrophilic driven asthma. And then obstructive asthma, which is not to be confused with asthma COPD overlap syndrome. So obstructive asthma are these patients that unfortunately have developed permanent remodeling of the airways, and they don't have that reversible component or a significant reversible component. They do not reverse to normal basically on their spirometry and usually never will. So understanding these phenotypes helps patients correlate their type of asthma and why it behaves the way it does, because a lot of times they feel like they're just under the influence of, the just life. It's just happening to them and they don't know why, right? And when we look at things that drive fear, the number one thing is the fear of the unknown. That's why scary movies are so scary. You don't know what's around that corner. You don't know what's in that basement. You don't know, you're worried about what you don't know what's going to come next. And that's how these patients live their lives. They don't know when their next asthma attack is going to happen because they don't understand these triggers, these phenotypes, and how their asthma, why their asthma is behaving the way it is. And this understanding it yourself helps you, again, make it digestible to the patients so that then they understand why this is happening and what's expected of their asthma and how it may progress. It also helps providers really focus on tailored treatment, which is something I think we're doing better and better at, but we can always do better. So some other clinically relevant updates that affect us in pulmonary and in asthma allergy is that they changed what a significant bronchodilator response is. So these patients, for those of you that are not working with spirometries, there is a percent predicted airflow for these patients based on their demographics, unless you're going to use GLI, which I put in here, don't get me started. There's a whole discussion I can have on GLI, but it used to be 12% improvement post bronchodilator, usually with albuterol, and 200 milliliter improvement. You had to hit both points to say, okay, they had a significant response. And now they're saying it's 10% of predicted, and you can use FEV1, their forced expiratory volume in the first 1 second, or FVC, their forced vital capacity. If you had that post bronchodilator response of 10%, okay, now it's significant, which again, you don't have to diagnose them with asthma. Asthma is a clinical diagnosis. It is not a pregnancy test. It is not, something that you are positive, negative for. It's a clinical diagnosis of their history and symptoms and response to therapy. FeNO, fractionated nitric oxide. It's also a device they blow into. It measures the amount of nitric oxide that they exhale in their breath. It's measured in parts per billion. Gina has always kind of kept it on the fringes of like, it's a tool, we don't know where to put it, but they put it someplace this year, basically saying if a patient has a normal spirometry, that's when you should consider doing FeNO on these patients. And patients who have elevated FeNOs tend to be patients who have asthma. So again, just another clinical tool to use, and Gina gave it a home this year. Other terms that are new this year that you may be hearing in community practice, that you may be hearing hopefully from your patients. So we get these smarty pants patients who go online, do their research, and come in and want to talk to you about these things, is AIR, which is anti-inflammatory reliever. That's what that stands for. So it has an inhaled steroid in it. And we have AIR-PRN, meaning as needed, versus AIR only, which is the only therapy that they're using. The inhaled corticosteroids that have been studied for AIR therapy are formoterol and budesonide, plus some sort of short-acting beta agonist. In the US, we use albuterol. AIR Supra is the one that's been approved by the FDA, which is the albuterol budesonide combination, which is an add-on therapy. So this would not be AIR only, it would just be AIR PRN in addition to their maintenance therapy. MART, which is maintenance and reliever therapy, and then SMART, which is the single maintenance and reliever therapy. So they're using their day-to-day budesonide formoterol, 2 puffs twice a day, and then they're also using that as their reliever therapy when they're in trouble. And then we are now using maintenance therapy versus controller therapy, and apparently mild asthma, not mild asthma. And I liked what they said about this. It was mentioned earlier today that, mild patients die of asthma as well, that using the term mild asthma and only categorizing them there risks the patient thinking their disease is not very severe. And so they wanted to kind of change the framework of mindset around, understanding mild asthma or apparently mild. So this is just a little more information on that AIR therapy. AIR Supra, right now it's only approved for 18 years old and up. It is 2 puffs as needed for asthma symptoms that are more than baseline at a max of 6 puffs per day. It is add-on therapy, not a standalone therapy at this point. The side effects are the same as albuterol and budesonide by themselves. They still should do oral hygiene because of thrush and hoarseness. And it did officially hit the US markets in October of this year. However, no one told the insurance companies it was coming apparently, and no one's covering it. There are like 7 free samples in my office of like 7,000 patients. So we're kind of hoarding them like gold, but in the GINA guidelines here on the slide there, I'm sorry, it's small, but it kind of shows you how they're using that air therapy in the steps, which is going to be discussed later during your GINA discussion. So SMART therapy. Just a brief overview of some of the information. This is a meta-analysis. We learned a little earlier today about meta-analysis and what they look like, but this is a look at 5 randomized clinical trials and using SMART therapy in those patients. It's about almost 5,000 patients with poorly controlled asthma. So they were not using, healthy asthmatics in these studies. They were patients who were very poorly controlled. And they split them into groups of giving them the SMART therapy versus stepping their therapy up or continuing on their GINA treatment with ICS/LABA plus a short acting as needed. And then they looked at to see which of these groups went longer without an exacerbation, who went the longest. And surprise, surprise, it was the patients who were on SMART therapy. So these were, again, stage 3, stage 4, late stage GINA guideline step up therapy patients. So again, not very healthy patients. And they even did well with using this SMART therapy. This is just some information about SMART therapy. I did include some pediatric information on here. I'm sure it's going to be reviewed also during the GINA discussion, so I won't spend that much time on it. There is a little caveat at the bottom that if you are looking at your GINA guidelines, talking about the dry powder inhalers versus the metered dose inhalers. Biologics, man, biologics is the equivalent of like the United States showing up in World War II. Like we have, for the last 18 years or so before biologics hit the market, we have not had a new class of therapy. It has been the same classes for at least 18 years, new drugs within those classes, but just those same classes. And then these hit the market. And those of you that have had patients with these experiences know that these patients are so excited once they start therapy. The right patients on these right drugs, they want to write you into their will. They're so happy. They're calling you crying. They've never felt this good. They really, again, for the right patient, do amazing things for them. So again, I won't spend too much time on this part of the biologics because it's going to be discussed again during your GINA discussion. This one, I'm going to spend a lot of time on. It was brought up a little earlier today as well, talking about this cycle of asthma care. And this is something everyone can do. It doesn't matter if you're a physician, a nurse practitioner, a PA, an RN, a community health worker. Every one of us can use this tool when you are interacting with patients to make a huge impact in their outcomes. So the idea is you assess them first, right? So do we have the right diagnosis in this patient? I've got a lot of patients diagnosed with asthma that come to see me that, guess what, don't have asthma. And vice versa. Patients who've been told you just have chronic bronchitis, and it's not chronic bronchitis, they have asthma. Or it's just allergies that affect my lungs. That's called asthma. And so we want to make sure we have the right diagnosis for these patients. And then we want to talk about their symptom control and level setting what is symptom control, right? And for some of them, it's like, well, I went from 10 times a day on my rescue to like 3 times a day. Well, that's fabulous that it got better, but that's not control. That's not what we want to talk about. I'm going to briefly talk about the rules of 2 as well. And then inhaler technique and adherence. Okay, air guitar. I don't need a guitar to actually play one, right? Your patients are not going to come to the clinic with their inhalers as much as we want them to, right? And we don't have enough demos to have every patient do it in front of us. So have your patient air guitar their inhaler. Are they shaking it long enough if it's an MDI? Are they holding it upside down because they have little hands and their thumbs are stronger, or they're arthritic adults? And those HFAs, if turned upside down in the canisters, only give them aerosol, do not give them drug, right? If they have been switched to the from the Advair discus to the Wixella discus, or the generic Advair, are they clicking that extra click, right? Because you have to open the container and then there's a trigger and then they have to exhale, then they have to inhale. Are they blowing into the device instead of inhaling it? So having them go through that air guitar motion of inhaler technique is very, very important. And then what are their preferences? I hate dry powders. Well, I'm sorry, that's what your insurance covers. Well, guess what? They're not going to take it if they don't like it, right? So what are their preferences and what can you do to help them get that? And then you're going to adjust their treatment based on their symptom control, based on their, do we have the right diagnosis, and then their preferences and how they're using their devices. And then you're going to review their responses by checking back with their symptoms, exacerbations, side effects from those therapies, all of that. So every time you interact with them, you should be doing this over and over and over again. This is a never-ending cycle. So what does that do? It gives opportunity for your patients to have shared decision-making with them. It gets them involved. And what I always like to say to my patients is, I am the user's manual for your make and model of vehicle. I'm going to tell you how to get the most mileage out of it. It's up to you if you're going to do the oil changes, rotate the tires, do all those things. I will love you if you do them or not, but I'm here to give you all the information so you have control over your condition. You can make those decisions for yourself, and I'm here to help you with that decision making. And that includes the misinformation. If you see something online, send it to me. I'll talk to you about it. Before you try it, before we are nebulizing hydrogen peroxide, which for some reason my patients like to do, could you please talk to me about it first? Let's talk about the data or those types of things. So let them know that you're accessible, and then also talk to them about sharing that decision. If we can get patients to engage in shared decision-making, we know there's a lot of information out there about improving their quality of life scores and their outcomes for hospitalizations, exacerbations, and death. And also then adherence, right? So if they feel like they're engaged and they've chosen this and this is the path they're going to go on, they're more likely to be adherent to therapy. So opportunity for patient empowerment. The more empowered they feel, the more control over the situation they feel, the better they do. Ways that we can empower them. The ACT, the asthma control test, I always like to give them a blank copy to take home and just say, check in with this once a week. Where are you on this scale? This is where you were today, and I want you to kind of watch this and see how you do. And part of sometimes their asthma action plan, for sometimes patients are very engaged, are nerds for numbers. I'll give them, if your numbers are in these areas, this is how you tailor your therapy. AirQ, which is another assessment tool. Peak flow monitoring, I love peak flows. I tell them I'm going to ask you every visit how your peak flows are. If I ask them, do you have a peak flow meter? Yes, show me how you use it. Again, air guitar, have them do that. A lot of them aren't pinching their noses. A lot of them aren't standing when they're doing it. A lot of them are doing a FVC maneuver versus an FEV1 maneuver when they're doing it. You want them to blast. When they're doing it, and then also gives them at home real-time objective data of what's happening to their airways. So especially your patients who are very exercise limited, and they don't know, am I breathless because I'm out of shape, or am I breathless because it's my airways? This is a great thing to look at for them to say, you're blowing 500, your predicted's 400, you're out of shape, or, your predicted's 400 and you're blowing a 200, it's your airways, and we need to get more aggressive with therapy. Rules of two. Are you guys familiar with rules of two for control? I love rules of two. I tend to simplify it a little bit for my patients to 3 rules of two. No more than less than 2 exacerbations in 12 months. And having them understand what exacerbations are, because they will tell you, oh, I just had bronchitis. You no longer get bronchitis. It's an asthma exacerbation. We just need to rephrase it, reterm it, and explain why we rephrase it. For example, if I get bronchitis, it just sucks to be me. If you get bronchitis, you risk hospitalization, pneumonia, and death. None of those things are going to happen to me if I get bronchitis, right? And it helps them understand it's a more serious condition. Understanding that using the rescue therapy, twice a week or less. And then the third rule of two that I like to talk to them about is less than 2 nocturnal symptoms in a month, where they're having to actually wake and use their rescue, or they wake because they're breathless, that type of thing. So rules of two are a great way to kind of dive into that further with your patient, of understanding when they're controlled and when they're not, and then reassessing that every visit for what can you change for them. There are a lot of shared decision-making tools out there. This is a QR code if you want to use it, of kind of a toolkit from AAN that they have that helps with shared decision-making tools with your patients and people that you interact with in the community. The other piece of that assess for diagnosis is that unfortunately in medicine, things don't happen in a silo. And so there's a lot of other morbid conditions that can happen that can mimic asthma that they could then develop. So if they're not responding to therapy, we want to be looking, are they developing cardiac issues? Are they developing something else that's causing problems? And then what is to come? So new phenotypes, we're looking at some autoimmune features, specifically the rheumatoid arthritis. There's some studies going on right now. And then new biomarkers, there's going to be more interleukins to memorize that biologic therapies are going to target. And again, there are these studies looking at neutrophilic types of asthma. And then drugs that are in the works currently, if you ever are very interested in what's in the pipeline, clinicaltrials.gov is always a great site to visit. If you want to see where trials are, what they're looking at, how they're designed, and what their endpoints are for your patients. Something that is changing that you may want to, it's not on your radar already, is that the Spiriva HandiHaler, tiotropium HandiHaler is going generic, or actually has technically gone generic, but like all new generics, it takes a while for other manufacturers to start producing it. So it's still at the ridiculously high price as the branded. But your patients may need to know that because formulary changes in January are coming, and probably a lot of patients are going to get switched over, which I'm going to get on a soapbox for a second. HandiHaler has never been studied in asthma patients, only the Respimat. And that is always very frustrating, especially for your patients who don't like DPIs or have milk allergies. You know, they don't do as well with these HandiHalers. Going away completely is the Flovent brand Discus and HFA. So those will be discontinued by the end of the year, just not available. So your patients who are on those therapies, you may want to have a backup plan if you don't already. All right, questions before Dee Dee comes up?
Well, actually, can you guys hear me? I'll just do my outside voice. So we'll go to the next.
Oh, okay.
And then we'll do all the questions
Perfect.
at once.
Perfect.
So we'll have.
Thanks, Corinne. All right, so before I start, just to remind you, we do have our wonderful asthma poster. It's brand new, hot off the press. You all get one, see Marcella. This is also hot off the press. I get to share the newest results of a preliminary study that we have recently been looking at of parents of children with asthma and their perceptions of oral steroids and biologics. We want to thank Sanofi and Regeneron for funding this study. It is the disclosure. So what we were trying to do is to learn about the parents' lived journey. And again, we're the AAN is the patient voice, right? So we want to bring the patient voice to research. And we're trying to understand what that parent goes through when they're making decisions about treatment choices, especially when it comes to oral steroids and biologic medications. We also want to try to raise awareness of those oral steroids, the overuse of them, because if patients and parents understand when to use oral steroids, Dave Stukus talked about that earlier. There's a time and a place, right, for OCS. And then also in regards to the potential use of biologics in children. So here we go. We wanted to measure that perception, examine their perceived understanding of what they know about short-term side effects versus long-term side effects. And we invited patients from a research panel. We partner with Dynata survey instruments. And this is an IRB approved study. So we pushed this out between October 1st and October 17th. And again, these are the preliminary findings. We were looking to have 500 people complete, and we actually just had that today. So we will have the results on Monday. The parents had to be 18 years or older. Actually, in some states, they had to be 21 years or older because they don't have the ability to give consent, if you can believe that or not, but it is real in the US. They had to have a child that was 6 to 17 years old, and they had to be diagnosed with asthma. So we found that majority of the people completing the survey are going to be between the ages of 30 and 50 years old. Like usual, females participate, so go females for participating in research. Most were Caucasian, non-Hispanic, and then you can see that they had education and then had earned an annual income of over $50,000 a year. And the majority of people had a child that had asthma exacerbation in the last 12 months. So from here, what we're looking for is to learn, using the rules of two, Corinne, if parents
recognized that their child had uncontrolled asthma. So we asked the question specifically here, does your child use their reliever rescue inhaler? You can see that there's about 69% of people that said, yes, they do use that rescue inhaler more than twice a week. We all know that that's a concern. Also, does your child wake up at night? Yes, they are. And then are you refilling that? So the parents themselves are recognizing, oh, the child does have uncontrolled asthma. So 91% of the people who are reporting for their child demonstrate that that child has uncontrolled asthma using the rules of 2. And I do have to give a shout out to Mark Millard and Mary Hart, our previous research director. They're the ones that validated the rules of 2 at the Baylor University of Texas. So we also looked at, did the child miss school? And that's a no-brainer of a question, right? We know that children are going to miss school, but 24% out of 380 people did not miss school. To me, that's still a large number, saying that, really, they didn't miss school? Are you sure? Where does the child seek their health care? Majority of people majority of parents, I should say, are taking their child to a doctor's office. 60% of them are doing that. And then after that, it's the urgent care center or the hospital emergency room. We wanted to understand what their perceptions of oral steroids were. And so, like we said, we gave them a definition of what oral steroids were. We attempted to show pictures, but we found when we pushed the survey out through our patients who gave their input before we pushed it out to the real population, our patients said that those pictures were very confusing to them. So we took the pictures off the survey and then pushed it out to our patient population or the research panel. We found out that patients believe that OCS are safe on a scale of 1 to 10, 10 being the most safe, 0 being the least safe. So between 7 and 10, they're saying that yes, that OCS is appropriate for my child. We asked them also, when was the last asthma attack and what occurred? So what occurred last time when the child had the asthma attack? This was out of the 326 people who said, yes, the child did see a healthcare provider. Majority of them received an albuterol inhaler or albuterol treatment. Then they were given oral steroids, maybe the liquid, maybe the dissolvable tablet for a child who is less than 12 years old, or they were given an injection, or they were given a prescription of OCS, or they were given a budesonide nebulizer. So patients, our kiddos are receiving lots of steroids is what the take-home message is here. In regards to the agreement of safety. So the question here is, I believe that my child with asthma will be sick longer when having an asthma flare if not treated with oral steroids. And so you can see that we have a strongly agree to strongly disagree. 50% basically or more believe that their child has to have those oral steroids in order to get better. That's a perception. They believe they have to have oral steroids in order to get better when having an exacerbation. And then we also asked, when I visit my healthcare provider, I actually expect to receive those. And again, you can see here that over 50% say, yes, I expect my child to receive those steroids. So they believe they get better and they expect to have them. Then we asked, what was the outcome? Did the kiddo get better? And ideally, what would we expect? Of course, they're going to get better. Dave talked about that earlier too. People get better on steroids. It fixes everything, right? So, whether your knee hurts while you're having an asthma exacerbation or not, all of that gets better. So then we started wondering, do parents understand what short-term side effects are versus what long-term side effects are? So short-term side effects, while you're taking the steroid and you have the wonderful, I'm really hangry or angry, I'm not able to sleep because I'm hangry and angry, all of those things associated with just the short burst. But then what are the cumulative effects of long-term side effects of oral steroids? There's been a study out that shows that 1 gram of oral steroid in a lifetime is considered the max that you should have. Many times patients who are taking oral steroids are receiving 4 bursts in 1 year, and that's actually almost half of that dose. So just putting in a perspective, that when we ask parents about familiarity with short-term or long-term side effects, you can see that 67% of parents felt like they did understand that what those were. However, we still have about 30% who aren't sure. And then you can see that we have kind of this balance on long-term side effects. So parents really are not aware of what long-term side effects are of oral steroids from a cumulative standpoint. So I have a 6-year-old who's taking oral steroids, then they turn 7, then they turn 8, and then they're 16, and then they're an adult, and then they're premenopausal. And so a whole lifetime of steroids. Again, time and place is correct, but there's also that concern for cumulative use or overuse. So we asked them a multiple response question where they could basically identify their most concern of the oral steroid short-term side effects. So parents are very concerned about their kiddos having anxiety. They're very concerned about them being irritable and then also not sleeping because, again, that impacts school days, right? And impacts their overall well-being. Then when it came to long-term side effects, for those that answered, we learned that they are definitely, when they saw the list, they understood what the definition was. Now, if you think about over a lifetime, now they're worried about their cardiovascular disease possibility of developing, and definitely anxiety and depression. So you can see that there's some differences here. And then the concern about sleep apnea, which we find is interesting. So from here, then we went onto biologics. So again, if you're a parent, your child has uncontrolled asthma, it's severe, it's not controlled with what you have going on, what are your next steps? So we asked, has your child ever been prescribed biologics? And we only had 28% say yes. Everyone else said no. And then we found that the type of biologic, the most common is DUPI, and then you have MEPO, and then all the way down to the bottom. So when we also considered what are the patient's comfort with this in regards to strongly agree versus strongly disagree, we asked specific questions about those biologics. So in regards to biologics, does the parent believe that a biologic would decrease the frequency of an asthma flare? And you can see the different coloring here, but basically we have over 50% of parents say yes. I strongly agree that the biologics will decrease decrease the frequency of an asthma flare. They also believe that their child would be able to be more active in sports because they're not having as many exacerbations. We also see that about 50% or so feel that biologics are safe for their child. And then we have a number, it's a little bit less than 50, it's 31% believe that biologics will decrease the use of oral steroids. So again, parents being a little concerned about that. So monthly out-of-pocket costs for biologics. So monthly biologic out-of-cost is on average about $1,200 a month to use those. We've had this huge range that when we interviewed patients, they said, a few patients said they actually were spending over $10,000 a month out of pocket. And then last, in regards to the benefits. So, parents definitely do see the benefits of what biologics are doing for their child, for those that did receive them. And you can see that, again, those asthma flares, that's what they're most concerned about, and the fact that they can reduce the rescue medication inhaler use. So you have the conclusions. Again, this is hot off the press. We'll have a manuscript coming out in the spring and some abstracts going out in the spring to our professional societies. But we do need, the gap is really there, right? Parents need education about what oral steroids are used for, when to use them, the right medication at the right time for the right patient, and then when is it appropriate to use biologics. So thank you very much. Appreciate time.
Okay, hi. Yes, we do have a couple questions. The first question I think is for Corinne. How much time do you spend with each patient, and how many patients per day do you see?
So I would say my average is around somewhere between 12 and 15 a day. And I get 20 minutes with established patients. I get 40 with new. Obviously you can't cover everything in that time frame. And so my new patients, I see back pretty regularly so I can get all the content in. Great way to build your practice. Also, if you're new. I try to see them back within usually 4 weeks, 4 to 6 weeks of their first visit, reinstate everything we talked about because repetition is the key with everyone for learning, to make sure they understood, okay, this is what we talked about last time. Do you have any questions about that visit before we move on to today? And then since the last time I saw you, is there anything new? And you'll ask them about, you'll train them on exacerbations. You'll ask them about exacerbations or flare-ups. They'll tell you no. You'll ask them about bronchitis. They'll tell you no. And then you'll say, have you had any antibiotics or prednisone since the last time I saw you? Well, yeah. Well, what happened? Oh, I had a lung infection. Okay. So again, just try different ways to talk to them, but to get all that information in, you definitely have to see them multiple times initially.
And another question regarding peak flow. Do you reevaluate that goal every 6 months until the patient is 25 years old?
So I primarily see adults. And so I definitely review their technique at least annually. Pre-COVID, we were doing peak flows in the office with a disposable mouthpiece, and we've not been doing that since. I want to reinstate it so that I can see it firsthand and see the effort. It's an effort-dependent exam, so see the effort they're putting into it. As far as their peak flow calculator or goal, for the most part for adults, it stays pretty stable. You don't usually have to change it.
Great, thank you. Any questions in person?
For peak flow monitoring, are you using estimator? Are you actually having them calculate or figure out their own personal best?
No, I usually use a peak flow calculator that I keep on my computer as a shortcut. And then I give them a range because not everybody fits into any kind of mold, right? And so I say, this is the lower limit of normal that I would like to see you in. I also encourage them to download a peak flow calculator onto their phone. They're free. There's so many free peak flow calculators. Just tell them pick one. It tells them if they're in the green zone, the yellow zone, the red zone, and then absolutely every single patient, I level set expectations of their peak flow. Your patients who you know are obstructed, we tell them we're never going to see the green, and that's okay. You know, our goal is to stay out of the red as much as possible. And how high in the yellow can I get you? You know, we may never see your predicted flow, and that's okay. We're going to try to get as close to it as we can, because your patients see they should be at 500 and they're blowing 175 and they're very discouraged. And then they want to kind of give up. Why even take this medicine? Right. So I love to level set expectations of their peak flows and what makes me happy. I'm happy with 200. Like, can we get to 200? And how long can we maintain 200? And making sure they understand it's going to change, you know, day to day, hour to hour, it's going to change. This is a piece of measuring how you're doing. It's not everything, just like our patients with pulse oximeters and just they're checking every 5 minutes, you know, they can get obsessive with their peak flow. So also maybe looking at your patients who may have a lot of anxiety, that could be something that you may want to talk to them about, because on one hand, it's a great objective tool for your anxious patients. Are you feeling anxiety or is it airway tightness? Peak flow is good. You know, it's probably anxiety. Peak flow is bad. It's your airways. But then you have patients who can be pretty obsessive with it and can, you know, affect their mental health too. Yes. If they come in with so the question was, in case you couldn't hear, how often do we do pulmonary function testing on these patients? So if everybody baseline needs one coming into the office to make sure we're not dealing with any other conditions that maybe are masquerading as asthma. If they have a normal spirometry or full pulmonary function testing, their first visit, I generally will repeat it annually if they're pretty well controlled. If they are having, you know, they got COVID, they got RSV, and they're just not returning to baseline, I definitely want to repeat it to see, well, what's changed? Has your lung function changed? So we'll repeat it more frequently for worsening symptoms that are not resolving with standard treatment therapies. But control patients annually. Patients who come in with an abnormal PFT or spirometry where they have obstruction, as we're escalating therapy in those patients, I'm definitely checking it like spirometry, simple spirometry, at least every 3 months, because I want to see, can we reverse that obstruction or not?
I wanted to ask about the nature of biologics different. So have you seen that like some of the social determinants of health are like barriers and do you have examples of how folks have worked around those barriers to ensure that, because that's going to be a big issue on equity. You know, people are they may not make a conscious decision about the option for other reasons. They just can't get to these types of settings in order to get the injections on a regular, consistent basis. So any examples on how
so
people
I've
have been
got some
handling
homeless
that?
patients, or they're intermittently homeless, and it makes it very difficult for any of you that have dealt with the biologics. It has to be shipped to a home address, and they have to answer a phone call before it ships. And so if they don't have phone service and they don't have a home to ship it to, that limits their access, right? And then they're getting intermittent care, and then they're not well controlled. So one thing we have done, I'm in a private practice, we have made the decision not to buy and bill, meaning we are not purchasing the product and then billing independently for it. However, what we are doing for our patients who are kind of housing challenged and technology challenged is we have them ship their drug to our office. And then we set dates for them every time we see them, whether you have your phone next month or not. You are here on the 2nd of every month in our office, you know, pending weekends, and we will give you your injections. We will store it in our fridge for you. It'll have your name on it. And so we just try to become a point of access for them. As far as financially, because they are so expensive, right now, the majority of these companies have financial grants. The challenge to that is some of the homeless patients don't have their last IRS tax forms and financial statements and things. So they get a little overwhelmed by the paperwork. We have nurse navigators that help them. I have a biologics coordinator that helps them get access to funding for that. But I don't know if you have.
Well, I mean, also we have patients that are caught in the bubble, right? Who they qualify for a biologic, but they can't afford the copay. So then that's a whole nother situation that you find people in. And so patients are then alternating treatment is what we're learning from our patients here at AAN, is instead of taking it monthly like it's ordered, they will push it off to be every 2 months or every 2.5 months, which is not how FDA prescribe, you know, how that has been approved, but that's their alternative so that they can afford what they need to keep themselves in control.
Perfect. And that's all the time we have for questions.
All right, thank you.
Okay, guys, you made it. You're halfway through. You feel good. You should feel proud of yourself. You're all educated and empowered. All right, great. And now with all the energy in the brain, you know, the brain is exclusively only uses glucose, you know, it's really greedy. So we get to feed your brains with some food. So please be back here by 1. So we're going to take a break and then back here by 1 o'clock to get some more asthma education and empowerment. Thanks, everyone. Hello, and we're back. We're back. Can wrap up the conversation. Again, get the number, get the IG, get the email, get the AOL, depending on the generation you're talking to. Wrap it up like a Christmas present. It's time to start back. All right, part two. I decided to be here. I shrink behind the podium in terms of height. I'm not vertically blessed. So I was like, behind there, you could just, it's just like Asthma Allergy Network in a head. So I decided to be out here, very similar to Steve Harvey's like hosting type of situation. So let's move forward to the next part. We're gonna be talking to Laonis Quinn. I love her and I love her story. And she's gonna be talking about the story of Tony. Yes. Ask her to show you her shoes after it. Just after though, not during, because that'd be a little odd, but after. So really she's going to be talking about the story of Tony. So by trade, she's a registered nurse, but she currently is the founder and executive director of Breathe Anthony J. Chapman Asthma Foundation. So she unfortunately there's an untimely death of her eldest son, Anthony Jamar Chapman in 2007, and from a fatal asthma attack. And so that'd be part of her story. But though that's obviously extremely sad and extremely unfortunate, that has fueled her passion to have really just unwavering passion for advocating for asthma education, increasing the awareness about asthma, the effects of asthma, and the effects it has on families and communities, and really to just use that to help save lives. Just really turning an unfortunate event to really, a blessing and fortune to, other families to hopefully not have to endure what she had to endure. She just kind of, I told you she has an RN, but she got her bachelor's in science in nursing in Eastern Michigan University, got her master's in University of Phoenix. She's a certified asthma educator. And she's a member of the AAN board of directors for the past 3 years. She also has asthma and she's had it as a child. So when we talk about Laonis Quinn living with asthma, living about asthma, all of that stuff, she is everything and all of that. Please welcome Laonis Quinn.
Hello, everybody. It's such a pleasure to be before you today. I want to thank the Allergy Asthma Network for the invitation, coming here to speak to you about something near and dear to me, especially asthma. I have asthma. My family has asthma, and unfortunately, my story today is a sad story. It's not a story of, wow, that really happened. That really happened. And I live with it every day. But from where I sit these days, I fight back. I'm a fighter, and I fight for my son, Anthony. This is my heartbeat, the greatest gift God has ever given me. Anthony Jamar Chapman. I know I know my story so well, but it helps me to read it. I stay focused better when I read it. The story is, like I said, it's a sad story, but it's also a story of strength, courage, love, unselfishness, but most of all, faith. The story is about an amazing son, my son, Anthony. I pray it will leave you thinking about the healthcare system, United States of America, how it has failed on some aspect or another. It failed us as a family, healthcare system that I trusted to take care of us. There's an oath that physicians take to heal and not hurt. And I still trust, but this time that this was happening to me, the trust was gone out the window for people who I thought absolutely loved and cared for my baby boy. I hope it leaves you inspired to seek change, change in the delivery of care and how you allow patients to have a say-so in their care. I am a strong advocate of shared decision-making process. At the time, it was not so much talked about like it is these days. I think it's a absolutely wonderful tool to use. I hope that my speech inspire you to do better, to have patients' voices count. Tony's voice still counts, and it counts through me. Tony is lovingly called T-Bone. If you knew Tony, T-Bone because he loved T-bone steaks. Love them. Mom, should get me a steak today. Mom, should get me a steak today. Go to mom, should get a steak today. And it had to be a T-bone steak. It could not be any other kind. Had severe uncontrolled asthma since he was 2 years old. His first diagnosed, we had a brilliant pulmonologist at Children's Hospital. She took such good care of Tony. She was kind, compassionate, attention to details. She listened. Listening to a patient has asthma is imperative and it's so very important. I could call her any time of the day. She was partnering with another pulmonologist in a private clinic, Detroit suburb, not in our city, in the suburbs. We had to drive like 25 minutes to see her. But for us, fortunately, we had transportation to get there. When Tony turned about 10 years old, she retired, and it was kind of bittersweet for us. Although we knew she was going to retire, the clinic that she was a part of, we had already been patients there for 8 years, and so everybody there knew Tony. We had been there in and out. We were there at least once a week. We were there in the clinic, so everybody there knew Tony. So the transition was not so bad. Even though at the time, Tony received such great care, he still had uncontrolled asthma. Many nights in the hospital room, many nights in the emergency room, and sometimes he would get to go home, sometimes he had to stay. It was always the 6th floor, room 611, every time. He became used to it, became part of him every day. So he turned 5, as you know. It was time for school, and our neighborhood schools, I went to 3 elementary schools. I was told by all 3 that we could not allow you to bring a nebulizer into the school because we don't have a school nurse there to take care of it. So I had to end up paying for school. I had to pay for private school, which I didn't mind paying because Tony needed his nebulizer treatments during the day. Michigan which is where I'm from, is ranked last in the number of school nurses. The 2019-2020 school year, there was one school nurse for every 4,169 kids. What happens to children like Tony, have chronic illnesses, and there's not a nurse in the school? What happens? Happens to these kids? It's sad that it's just how it is. As years passed, Tony had several bright spots. He had friends. I'm sorry, I'm crying already. He had friends and vacations, and he had girlfriends, and he even played ice hockey. He was so good at it that he made the travel team, all the while taking neb treatments, enduring emergency room visits and more hospitalizations. He graduated. Can I have the clinics? He graduated from high school. He even went to college. Thank you. He had a degree in computer science. Smart kid, just like any other kid. Sorry. And he had jobs. He had 4 or 5 jobs. Each job he had, he was not able to keep the job because he had so many missed work days at school from being sick. He was sick all the time. Hospitalizations were fewer, but exacerbations remained constant. While on a well visit to the clinic we had been going to so many times, thank you. After the spirometry, writing all the prescriptions, all the stuff you do when you go see the doctor, which we did a lot, went to the receptionist's desk, as usual, to pay. And we were told by the receptionist, oh, by the way, this is Tony's last visit here. He no longer has healthcare insurance. We can no longer see him anymore. Stunned as I was, I stood there initially, completely overwhelmed by what I heard. I asked her again, I'm sorry, what did you say? she repeated it again. This is Tony's last day here. He no longer has healthcare insurance. As a matter of fact, we have seen him for a month and he has not had healthcare insurance for a month. I started to just wail. I was crying, asking questions. We've been coming here his whole life. This is all we know. We've been coming here for 18 years. 18 years of his life, this is what we've been coming, and this is what you do to us. I didn't understand. Who's going to take care of Tony? Who's going to take care of this kid who's had severe asthma? Where do we go? All the time I'm asking these questions, Tony just stood there quiet. He never said a word. He just stood there. No mention of sadness, just quiet. We left there and I had to go home to try to figure out what to do. I did find a free clinic in our city. I made the appointment. We went there. They did spirometry. They asked all the right questions, allowed us to ask questions. I started to do my happy dance. I'm like, we're going to be okay, Tony. It's going to be great. Got somebody to take care of you. This is going to be great. They had an on-site pharmacy and you get your prescriptions for free, all your inhalers for free. Although the inhalers they gave him were for free, they were not the same inhalers that he was used to. Nonetheless, they had inhalers, it was free. I had somebody to take Tony when he's in trouble or follow-up appointments, or so I thought. At the end of our visit, the doctor said, Mom, we don't have a permanent physician here. So if Tony gets into trouble, you have to go to the emergency room. Okay, well, we're kind of used to the emergency room, kind of used to doing that. What happens if you need follow-up appointments? What happens to that? Well, you can get a follow-up appointment, but it may be a little while getting it. It may be somewhere down the road. Sometimes we don't have physicians to even take care of that. Again, another disappointment. Here we are again. Who's going to take care of Tony? Emergency room visits were frequent. I applied for Medicaid several times, denied several times. I applied for disability several times. Disability, asthma is not a disability at this time. He can work. He can find something to do. He cannot work. I went there arguing with these people with no avail, still nothing. All right. Tony became less interested in daily activities. I took him to a psychiatrist. If you're on prednisone, prednisone can cause depression, and he was depressed. I took him to a psychiatrist. They prescribed him some medication, antidepressants. He never took them. I don't want to take those pills. They make me feel weird. He never took the pills. So as time went on, more frequent emergency room visits. And I work nights. I still work nights as a nurse. And my youngest son or my husband would take Tony to the emergency rooms on those frequent nights. If you have anybody in your family that has severe asthma, you know that in your house is no sleeping. If someone is sick, everybody's in the house. We're all up. You all had it. There was no getting around of staying asleep. As time went on, Tony was sicker. I'm a burden to you, Mom. I don't want to live like this anymore. It's just too much for me. Those are the words that told me. And of course, you're not a burden, Tony. We're going to fix it. It's not going to be like this always. Just hang in there. Trying to encourage him became more and more difficult because he was not listening to a word I was saying. Fast forward, I was leaving work one morning because I work nights, and I was on my way to the parking deck, and my phone rang, and I answered the phone, and all I heard was screaming, high-pitched screaming, like a pain. Like I started screaming, I started running. I knew something had happened to Tony. I did not know what. I started running. And finally, it was my youngest son. He finally said, Mom, Tony left us. Stood there, just in shock. What do you mean left us? What does that mean? He left us like what? Was he went somewhere? You know, he left us. He's not here anymore. I still remember the scream. I still remember the moment that happened. I will always remember it. I will always remember it. My life has been changed forever, the unthinkable day. Years have passed from daily thoughts of suicide, trying to kill myself a whole bunch of times, to losing my husband 6 months later. I buried two people that meant the most to me within a year of each other. The following year, we had a very new president was elected. Things change. It's now where if you have kids, they're on your healthcare insurance till they're 26. The following year, Disability Act has now added asthma and allergy as a disability. The following year. So now I still grieve daily. I'm broken, but I'm blessed. Blessed enough to fight back. Broken enough to be able to have this memory etched into my heart, but it never erased my spirit. Through much suffering and grief, still today, the Anthony J. Chapman Asthma Foundation was born, and I can honor my amazing son and support other families who suffer loss like I did. I still do. I provide education and resources. I pray this foundation becomes an unwavering advocacy movement of commitment to my son and commitment to others who strive to do better for their children with asthma. Thank you for your time.
Thank you, Laonis. We find strength in your story. We find purpose in your story, and we find blessings in your story. Because despite the tragedy, there are some people that have been helped despite it and because of it. So, but you know, it's very important for those stories to be told. Because sometimes stats are stats, people see numbers and they just, you know, it doesn't have the effect. The personalization of any disease really helps those who don't get it understand what it means to live with asthma outside of the clinic. So thank you for that. So with that, we will move on to our next lecture that is by Dr. Elizabeth McQuaid. So she will be talking about the barriers to medication adherence in asthma and the importance of culture and context. So for her, she's currently the Vice Chair of Academic Affairs and the Professor of Psychiatry and Human Behavior and Professor of Pediatrics at Alpert Medical School, Brown University. She does work that focuses on pediatric disease management and adherence to medical regimens in the context of health disparities. She's had, her work has included investigations and psychosocial aspects of pediatric allergic diseases, including adherence to regimens for the, across the adolescent transition and individual family and community characteristics that influence health outcomes. So she has extensive experience in developing, evaluating, and disseminating disease management interventions for pediatric populations. She focused on cultural diverse groups. So this is the asthma in the culture that I talked about earlier. So without further ado, Dr. Elizabeth McQuaid.
Before I get started, I just want to, on behalf of the audience, thank you, Ms. Quinn, for sharing with us. I feel like I need to take a moment too. Thank you. Thank you. So this is just a list of my funding sources, what supported this work. But I feel like what's important to say here too is that there's a big team and also so many voices of so many families that helped shape the work that I'm sharing today. So I'm going to be talking about health disparities. And I want to start by stating something kind of obvious. So I'm going to be talking about health disparities and medication use in asthma. And so I'm going to be talking about culture and disparities. And I don't know if y'all have noticed, but I'm a white lady. And the reason I'm saying that is I want to give you a little bit of context, and that is that, I started this journey of research as a pediatric asthma researcher. I'm a psychologist. I was interested in how you help families manage all the things they have to do to help their children's asthma. So helping parents quit smoking and helping families, manage medication use. And so, but I very quickly, and this is about 25 years ago, it became clear doing work in that space that working with families and asthma really meant doing health disparities work. And really, because as we've been hearing and as we know, the families who are most affected are families of color. And so at that point, I leaned into the work and really have, with humility, and try to continue in that vein, but have tried to really build a team of folks who deliver our clinical services and who do our research together that is really more diverse and multicultural and bilingual. And so what I'm talking about today, really, I'm just the voice of a big group of people, and I just wanted to mention that. I will be talking some about the different barriers to medication use and how those can contribute to disparities, and also on a practical level, what kinds of things you can do in clinical practice to promote medication use. And there's been a lot of talk of shared decision making, so I have some thoughts about ways that you can enact that. So just another comment, race and ethnicity are social constructs. They don't really capture the deep diversity of people's experiences of themselves in their contexts. But it is important that we use these constructs and measure them because they help us understand health inequities and how outcomes and processes within the healthcare sphere can be different, particularly for people who are not white and privileged and able-bodied. One of the things that we've noticed, we do a lot of work, and I'm from Rhode Island, and I know people think of Rhode Island as, up in the Northeast, and there's an Ivy League school there, and it's maybe mostly white. We have a lot of Latino families, and also a fair proportion of Black families too. Most of our work has been with Latino families, and in talking to them about how they understand race and ethnicity, really, we get no answer to the race question most of the time. So people I'm Puerto Rican, I'm Latino. And so we have a lot of missing data based on that. So another just illustration of how, this is sort of an imperfect way of trying to measure disparities, but again, it's important to try to make people accountable. We know that asthma is more prevalent and more severe among Black and Latino groups. And if you look at this nice graph from the CDC, the bottom green line represents the prevalence of asthma among whites. And then the teal line is among Blacks. And then the top line is Puerto Ricans. And so that another sort of important thing to mention, and I was paying attention to the California demographics today, and it really has to do with ancestry, but Caribbean Latinos are particularly impacted by asthma. And, and in Puerto Rico, the rates of asthma are particularly high. Okay, so I have a poll question that I'm just getting oriented to. So on average, what percentage of prescribed medications do people take? Thanks. Oh, thank you. Just hit the, oh.
There he goes. Yeah. And
Did he do it?
Maybe. And then when it's done, you can just click in poll.
Can I, does this move it? It doesn't, I don't see it doing anything.
It's just this.
Oh, oh.
Drag this all the
Yeah,
way
we just can't
away.
find the mouse
Oh,
yet.
gotcha. I think you're on the screen, so keep going to the left.
Yeah. Oh. Oh, there it is. So when you're
Thank
ready,
you. We can close it out actually right now. Okay. Thank you. And then, so I think stop share. I can just go to the next slide.
Cool.
Thank you. All right.
And then you can get, that goes back to your presentation.
Thank you very much. So most people guessed. Oh
yeah. Because that doesn't advance it on the.
Oh, okay. Got it. Okay, thanks. I'm flying through these because I think I've been using the cursor here, which doesn't advance it on the Zoom for the folks at home. So back to this question. Most people guess 40%. And now I'm unfortunately stuck here again in the poll. Okay, but you don't see that. Sorry.
It's okay. I'm gonna drag this onto the other screen.
Oh, okay.
So you can see the results. Yeah, I'm gonna
You can just close it. I can say what the results were. Okay, I think now we're in business. We'll see. So the answer is 50%. So as we know, for patients with persistent symptoms, it's consistent medication use is really necessary to control asthma. And I know things are changing some with the SMART guidelines and around the timing of that. But overall, really consistent medication use is needed. And if you look across conditions, not just asthma, people typically take about 0.5% of their prescribed medication. They don't take it even daily. So, you know, in some of my earlier work in this, again, I'm a psychologist really interested in behavior and what are people doing and how are they taking the medicine. The gold standard of how you measure this is using these electronic devices. They have them for inhalers and, you know, there's a electronic pill cap that's in the top of that little white bottle. And then there's a counter on the dry powder inhalers, as people know. So what we find, though, in using these, that kids, very consistent with the data, kids use about 48 to 50% of their prescribed doses. Now, remember, this is in a study where they know we're studying medication adherence and they've gone and taken these devices home on their meds. So really, it's probably lower than that in actuality. It's not much better for adults, and in particular, young adults. You know, there's a recent meta-analysis that showed that young adults are taking about 1/3 of their prescribed medications too. So over time, we found a few different things consistently using this model that adolescents, no huge surprise here, adolescents take less medication than younger children. And in fact, we had a longitudinal study more recently where we took a bunch of 8th graders and measured it until they transitioned through into high school, followed them to 10th grade. And we found that they started at 48% and then they ended around 34%. So on average, our kids who are in high school are taking about 1/3 of their prescribed medication. And then we also found that medication beliefs and use differed by race, family race, and ethnicity. So the parents of Black and Latino youth were more concerned about these controller medications and their children were taking less. So there's a big problem with this. And that is if you focus on this clinical problem of how much medicine the person's actually taking, it really makes you focus on the patient as the problem. And you start to generate patient-focused solutions. But as we know, taking medication involves a complicated set of behaviors. So it has to get prescribed by someone, then it has to get accepted in the medical encounter. The person has to go fill it or figure out how it gets filled or sent to their home, and then they take it as directed. And so we were really only measuring this taken as directed piece. So, over the course of then this, a few decades of my research career, Rhode Island, like many places, becoming increasingly diverse. And in particular, as I mentioned, a lot of Latino families moved into Rhode Island. It became, typically people would come in through New York City, and then there was an impression that Rhode Island was more family friendly, and so we had a lot of a change in our demographics. And at that time, we really started doing a lot of work to try to diversify, as I mentioned, our workforce and our and our research staff as well. And so we were really interested in this question. Again, I'm still sort of fixated on the behavior, right, as a psychologist, but I'm hearing a lot about all the concerns. If we provide culturally tailored asthma education and adherence with our bilingual, bicultural asthma educators and provide feedback about the adherence, can we address medications concerns that people have and actually improve adherence? So I had a project at that time where we compared a control condition of education, which was culturally tailored, to this behavioral feedback and education. And we found that, the knowledge increased, medication beliefs changed for some, not all of the group. Everyone's asthma pretty much got better, but it didn't have anything to do. We did not change adherence. It didn't have anything to do really with the changes in asthma. So why didn't this work? Well, we know that not everyone believes that asthma controller medications work or are safe, and many people don't want to take them daily. And some of these attitudes are based on historical injustices that are very real. We also know that economic and language barriers that affect communities of color can also disproportionately affect access to medication, as people have talked about here earlier today. And also, even if you have the medication, like best case scenario is you have it and you actually want to take it and you believe it's important, sustained behavior change is hard. So thinking about this from a broader lens, so many folks today have talked about health disparities. I'm not going to go into detail in this slide, but within asthma, we know that there are differences in prescription rates and the encounters within experiences and within the medical encounters and outcomes across the board. One of the findings of the IOM report and later is that healthcare providers, and including many of us, have wonderful intentions, but also have explicit and implicit biases that affect the medical encounter. And this, again, can affect things like prescription rates and referrals, specialist referrals. So we became interested in looking sort of at this broader picture in terms of what kinds of things affect prescriptions and all the way through to medication being taken as directed. and had a wonderful opportunity to collaborate with colleagues at the University of Puerto Rico. And a shout out to the PI there, Clarissa Canino, and the other PI from Rhode Island, Greg Fritz. And we started a study, we had and completed a study where we had about 800 kids, and the 3 different groups were from the island of Puerto Rico. And then in Rhode Island, we had non-Latino whites and then Latino families who were specifically Puerto Rican and Dominican. So we could look sort of at what was the experience on the mainland, and then contrasting it to the island, and also look more closely at the disparities. And we were interested in disparities in the diagnosis and management of asthma, but also like barriers to healthcare access for the Latino families. So if you look at sort of the diagram on the left of the slide here, we were really interested in sort of knowing from the group that we were looking at, all the kids with asthma in our study, there were some who should be on controller medications based on their workup, their medical workup. They needed to be on regular medications to control symptoms. A proportion of those had them, not everybody did. And then out of those, you know, a proportion of them were taking them. So we were interested in looking at some of these different relationships and what predicted having medicine, you know, when you should have it, and what predicted then using it. Thinking more broadly again about these other contextual factors. So one of the things we were able to do is really assess the medication beliefs and concerns and the barriers to getting medication from the families. And I just want to explain, the graph on the left is kind of like a cost benefit analysis. So like, how necessary are these medicines? Okay, I think they really are, versus how worried am I about them? And so the closer that you get to 0, it's kind of like a wash. Maybe it's not worth taking them. And so you can see that the non-Latino whites in our sample had the most favorable balance of cost benefit analysis. And then the families on the island of PR had the lowest. And we found that, you know, the Latino families were really more concerned and less likely to think the medicines were necessary. And also, a lot of the families in Puerto Rico had a lot of barriers like cost and transportation. And that these attitudes and experiences predicted whether or not the families had the medicine. We were also interested in, you know, we had a subset of kids who were on controller medications across both of the sites. It was somewhere around 275. And, you know, thinking about it in retrospect, it was a little wild. And we were sending these devices out into the field and working, you know, in Puerto Rico and here. And but it was really an incredible source of data to help us understand what families were experiencing and choosing to do. So for each of our medications, we found that our Latino families had lower rates of medication use than non-Latino whites, and that family routines and parental beliefs, again, going back to like worries and concerns about these medicines and lack of trust that they were necessary, predicted how much the medication was actually being used. Also very important, you know, our qualitative data have showed over time in Rhode Island and in Puerto Rico that Latino families are using more natural remedies than the non-Latino white families. So they talk about aloe vera juice and praying, a number of different other kinds of things, oils and things like that. And it was pretty common to hear people say things like, not our participants or our families necessarily, but, oh, people substitute or they prefer. And so we were interested in whether or not that was actually true, if a preference for these natural remedies was associated with lower adherence to medications. And I put Vicks up here because like Vicks is a big thing, right? So, no, this is from Rhode Island too. Yeah, Vicks is we know it's a big, this is not an ad for Vicks, but it's a thing that people, you know, use a lot. So what we found though was really interesting, okay? In Puerto Rico, we found that use of natural remedies was related to barriers to getting medicine and not medication adherence. So in Puerto Rico, families who couldn't get medicine were using natural remedies, right? So it had to do with the barriers that they were experiencing. And then in Rhode Island, and this was only among our non-Latino whites, it was a different pattern. It was positively related to medication. So then we had families who were like, oh, take your medicine, take that here's the Vicks, like everything but the kitchen sink to try to help manage the asthma. So, so it really, I think, when you think about use of natural remedies, and it's important to assess it, but it's important to think about how it's being used and whether or not there are barriers, and that's why it's being used. Another really interesting component was that, we looked at the emergency department use in Puerto Rico was very high. And we found that there were institutional barriers that were interfering with access to controller medications. So in Puerto Rico, the Medicaid contracts were structured so that the physicians would receive a capitated payment, right? So like, here's a chunk of money per patient, and the cost of medications come out of that bucket, right? But if you send your patient to the emergency room, the cost of medications come out of a different bucket. So essentially, you have healthcare providers who are incentivized to send families to the emergency room to get medications. And this is was a clear socioeconomic disparity and institutional barrier. So, to summarize some of these findings, we were finding that, in terms of the prescription piece, Medicaid contracts were discouraging prescriptions. Families had concerns about medicine, and that affected whether or not they would accept the medicine. Barriers to filling the medicine, particularly in Puerto Rico, like cost and transportation, and then were relevant to filling it. And then, in terms of taking medication as directed, beliefs that the medicine was necessary and family management routines were what was related to that. So a couple of things to summarize here before moving into the next section. Cultural beliefs, as I mentioned, some of which have historical roots in significant mistreatment, affect medication use. Also, thinking about like adherence, we used to call it compliance, it's really medication use. Focusing on the individual behavior really might make you miss some of these important interpersonal and contextual factors. Patients and parents might use herbal remedies when they can't access medicine or in conjunction. And also developmental transitions like high school entry or transition to young adulthood pose more challenges also for adherence. So what can we do about any of this? I think one important thing is really making sure you have the data. So there are barriers to collecting data regarding race and ethnicity at local and organizational levels. And I was mortified to learn that in Rhode Island, Medicaid is one of like 4 states that have really not very good data on race and ethnicity in Medicaid. But organizations really need to collect their own data, right? It's one thing to look at disparities and hear about the rates it's another thing to, within your own organization, look at whether or not prescription rates are different by race and ethnicity. And that's one way to really motivate change. There is some evidence that, that cultural competence training for healthcare providers can help, without going into these specific studies, but that does have an impact on patient medication use. But it also has to be very thoughtfully delivered, and it has to address, it has to not reinforce stereotypes and also really address these structural barriers that families may face. Also, some strong data that, and most of the data is with physicians, but as we know, people who are delivering asthma care really, community health workers, asthma educators and nurses as well, and pharmacists and respiratory therapists. There is some evidence that communication training can improve adherence. So it is really the case if you really talk about how do you do the shared decision-making, how can you talk to patients, that makes a difference in terms of medication use. In terms of medication beliefs, there is strong evidence that medication beliefs vary by individual and family and culture, and that's associated with medication use. And so thinking about how to address those, making sure that that happens in the context of shared decision-making with open patient-provider communication. What about digital interventions? You know, they seem to have some benefit, small improvements in adherence. But a caution about those are really for people who have the medications and are motivated to try to use them, right? So there may be some pieces of that cascade that need to get addressed first. So thinking about what kinds of things, what steps can you take to address these barriers to adherence? I just have to tell you, like, I'm so motivated by people taking a photo. It's like, dear diary, today I was giving a talk and someone took a photo of one of my slides. So anyway, what steps can you take? You need to look at, prescriptions and prescription rates. We know they can differ by race and ethnicity. We know they do. Track the data, cultural competence, and communication training for healthcare providers can help. In terms of accepting the medication, so shared decision making, what option might work best for you? What strategies do you use besides medicine to manage symptoms? Filling medications, ask about the barriers. What might get in the way? And having medication taken as directed, assume there are going to be challenges, right? This is not easy. What times are going to be hard for you? What can your family do to help support, this person, this family member, in doing this more regularly? So, and I also want to say that you might notice that these are all open-ended questions, and those questions take a little more time, right? But I think that's really important, because you're not going to be able to really understand what's happening and how you can help unless you take a little bit more time. And that's why I think it's so wonderful to see, the field of who's delivering asthma care to be broadened to include community health workers, and as well as asthma educators and nurses and healthcare providers, advanced practice providers and physicians. So with that, I'm just going to end and say thank you all. And thank you. I also want to give a shout out to my team. I think some of whom are watching on the Zoom. So, and this work is I feel like I'm like Academy Awards here. This work is not possible without my team who's watching at home right now. But thank you all very much. Do you want me to stay up for questions, or do we need to go on? Okay.
Hi, yes, hello. We do have a couple questions. This first question, I'm not sure you're gonna be able to answer, but it's, how does the adolescent Latino asthma patient compare to the type 1 diabetic adolescent patient in terms of adherence?
So, I mean, I am what you call a pediatric psychologist. So I do think about like chronic conditions and kids and development. So I don't do work specifically with diabetes, but I imagine that there are many similarities. One of the things that I think is really important to assess is sort of what's happening within the family to support management, because the roles in the families may be very different depending on race and ethnicity and sort of cultural background. Not just for Latinos, but for anyone. So, so I think it's likely pretty similar. I don't know precisely the answer, but I think the strategies that you would use to try to help would be quite similar across those conditions. So.
And one more question. Can you explain a little bit more the cultural communication barriers with physicians?
So, yeah, so one thing I think that happens is there are data that show that if the physicians don't speak the same language as the patients, and you get interpreter services, right? to come in, if you have even have access to that, right? The exchanges are briefer and provide less information to the families. So I think it's very important to be mindful of that and make sure that, even if you are using an interpreter, that you get the full story. We also did a study, and it's not good practice to have family members serve as interpreters. We did a study with adolescents, Latino adolescents, who all spoke English, and the parents spoke some English and some Spanish. And we did a focus group with them and asked them, and many of them described, being used as interpreters and editing what the physician was saying, so that they didn't look bad. And so, So I think it's just important to be aware that there are many different ways in which things can, go awry in that encounter with regards to communication. If you're not sitting there with a person who looks like you, who you're used to communicating with in a particular way. So.
Thank you for that. Thank you for that answer. Really appreciate it. So, I noticed you said shared decision-making and how important that is. And in cultural context, we need to keep that in mind. And I think that's just such an important point. If this population doesn't want to use controller medicines, is there another alternative? And for everybody in the audience, since we're talking about guidelines-based asthma care, we were involved in a PCORI-funded dissemination project about a year or so ago. And we can distribute this in some follow-up emails, but there was a study done at the University of Washington in St. Louis. It was called the ASSIST study by Dr. Sumino out there. And she did a study comparing African-American children with mild persistent asthma, and was asthma control just as effective in daily use of controller medicine with occasional use of albuterol, or using both at the same time, but not using the daily controller, and it was found to be just as effective. And that would allow for asthma control and mild persistent asthma without that daily controller
Yes,
need.
right.
So that's just an example of how she was trying to research this, because she knows how hard it is to afford these medications and get access to it, but also provides a solution that might work with shared decision-making with the doctor. So I just wanted to point that out. And so we'll send that study around in a follow-up email. There's some they call them evidence briefs that the PCORI group has produced. And so there's one for parents and there's one for healthcare professionals with all the citations and the references to the literature that supports it.
Right.
Oh, yeah. Yeah. I mean, we
Can you
did.
repeat the question for?
Yeah. So the question is relating to adolescents' perception of illness and the fact that when their symptoms begin to improve, as often happens in adolescents, and people, they don't feel like they're even sick and don't want to acknowledge that they have asthma. Yeah. I mean, part of our longitudinal study, we also looked at discontinuation of medicine, and a lot of adolescents were just deciding, to stop taking medicine without consulting with their healthcare provider. And that was also related some to insurance barriers. But in answer to your question, I mean, I think it's, it has to do with having a consistent relationship with the adolescent, and to know that there are going to be these times, and to be prepared for when they come back and have had an exacerbation. And, as opposed to, I mean, it never works to give a lecture, right? To adolescents, like that's guaranteed to backfire. So instead, I think talking about sort of what their perceptions are, giving them some information, but also being there to receive them when they come back, and making sure that there's a safety net around them, right? Whether it's their, if there's a school nurse, the family, and, the healthcare provider, so that there are a number of people kind of watching out for them during that time.
That just came to my mind in here, being myself Puerto Rican that migrated to United States. long time ago. And growing up in Puerto Rico, and even the doctors telling my parents, I remember them saying, maybe you need to move out of Puerto Rico and her asthma will be getting better. And they suggested Arizona. So did you, because it was drier, but then they didn't know about the dropping in temperatures into the 20s.
Yeah.
We're not, our DNA is not made for that. However, so have you in this study encountered some of these Puerto Ricans moving to Rhode Island, thinking that living in Rhode Island will be better for their asthma?
Yeah, well, that's such an interesting question, and I'm not going to go on the amount of time I could go on about it, but in brief, across most illnesses, right, there's this sort of healthy immigrant paradox where people might be healthier in their home countries. They come to the US, they're eating our processed foods, and they don't do as well. With the Puerto Ricans and with asthma, it's the opposite. So if they do come to the US, their asthma does get better, actually. So the data shows sort of a different, so it is the case that that we do see some families. There are also families who are back and forth a lot, the circular migration, who they'll be there for a while, they'll come back. But we do see some families who have moved to the Northeast because they feel like the asthma will improve if they are not in Puerto Rico.
Any further questions?
It's not actually a question, but I would like to share a fact that I getting as a feedback from our patients in the clinics, especially with the teenagers. I know they don't like, all of us knows that they don't like to tell them what to do. So I find out that when I talk to them and now with the parents together, it is actually, they respond better of what we're looking into from them. And of course, I don't go directly of, okay, you need to take your medication. I start like you say, the relationship with them and looking into what they like to do or what they don't like to do. And then through there, I get that relationship with him or her, and I ended to get some of what we're looking into for them to get better with their compliance with their medications or understanding what's going on. So, but I just want to share. Then when I talk to them myself, they respond better than when the parents are there on the class. So we teach the parents separately, but then we take them individually as well.
That's like motivational interviewing, what you're doing there, right? But that's terrific. So.
One more question.
Okay.
I just want to pretend like I was going to see what happened. Hi, my name's Charnette. And my question is, being a parent of asthmatic, I've noticed my daughter's 12. I noticed that a lot of times it's not just that they don't want to just take the medicine. It's also becomes like a laughable thing, just like they had showed you before in the previous where it's like, oh, it's a nerd doing the Goonies thing.
Yeah.
Or people look appalled like, oh, you're sick.
Yes.
So it causes them to lack confidence in being
Yes.
able to use their medication in front of others.
Yes.
So they feel like they need to go hide just to
Yeah.
go take their medication. But I'm a pep talk coach, like, don't worry about that. You got this type of attitude.
Yeah.
And so, but sometimes I can see on her face that if she has to pull out her inhaler in front of her friends, especially with everybody wanting to record you nowadays and put you on TikTok,
right? Yeah.
It's upsetting. So how do y'all instill some type of measure of confidence in the person to know that I have a medical condition and I need to take my medicine no
Yeah.
matter what?
Yeah, I mean, that's a great point. And we do hear about kids hiding in the bathroom, right, to take their inhalers because they don't want to be embarrassed in front of other people. But one of the things that we've done is, we've had school-based groups with kids together where they're talking about their asthma, which is, I think, helpful. And we had one study where we trained high school students with asthma to coach the middle school students with asthma. And so having, like somebody who is cool and, older than you and in high school and has asthma telling you, that's all right. You can take, find a friend, get your buddy to cover for you, whatever it is, that makes a big difference. And that particular intervention outperformed our regular asthma education for the kids. So.
Any further questions? Speak now, forever hold your peace. Just kidding. She'll be around after.
All right. Okay.
I don't know, actually. Let me not volunteer
Thank
your time
you.
after. Thank you, everyone. She said, have you noticed I'm a white lady? We know. I was surprised when you said that because I was like, is she? But now I was confirmed. I suspected that you were, but then when you said it, I was like, she is. Perfect. That was with me. How's everybody doing? Good. I'd give you time to stretch, but we don't have that time. So let's move on to, feel free to stretch on your own accord. So the next lecture we're going to be talking about indoor air quality and which is a social determinant of health. So that is going to be by our second dynamic duo. So Sheila Brown and Kelsey Lamb. So I'll do a little bio about them and then I'll let them take it away. So Sheila, we had the opportunity to meet earlier this year. Time goes by really fast. So earlier this year, she's a program analyst at EPA. She works with a team that leads the agency and really efforts towards asthma disparities. And she really focuses on the role of in-home environmental interventions. I think we talked about that earlier, talking about prevention of asthma, that type of thing. The in-home is really important. And so she really focuses about interventions more specifically in the home. And she works with stakeholders to do kind of more of a comprehensive asthma work across the country. So that's Sheila. And so Anne, she's the director of Regional Asthma Management and Prevention, RAMP. And she served as director for this since 2002. And she provides overall leadership, establishing RAM's vision and mission. And she leads all components of the organization's efforts to reduce the burden of asthma with a focus on equity. So under her guidance, in direction, RAMPS actually has evolved as an organization. It's expanded its breadth, its scope, its impact. And so these ladies today will be talking about the social determinant of health, specifically of indoor air quality. So please take it away, ladies.
Okay, I'm up here. Okay. And I'm learning how to use the clicker for the first time. All right, so, let me see. Okay, so good afternoon, everyone. Bear with me. We're going to get through this. We're on the home stretch. Thank you so much, Dr. Joseph, for your facilitation and your leadership. And similar to you, Ms. Quinn, I have my notes because my mind will go way someplace else. So on this first slide, the homepage slide, as we call it, please take a minute to note my email address, brown.sheila@epa.gov. And then the second thing I want to say, hopefully some of you all picked up our asthma flyer with resources, QR codes for resources. If you didn't pick it up outside at Marcella's desk, there are more out there. Okay. All right. Okay, so I'm here to talk with my family and friends, my new family and friends, about EPA's asthma program. Asthma program's work supporting community level solutions for addressing hard to control asthma with a focus on addressing asthma disparities and the critical role of in-home environmental interventions. Also, I will introduce, and it may not be new to some of you, but I will introduce a new term that we've developed
in our asthma program called Indoor Environmental Determinants of Health, or IEDOH. And how we hope this terminology will help drive progress and action now and moving forward. And then you'll hear from my friend and colleague and partner in crime, Ann Kelsey Lamb, the director of the Regional Asthma Management and Prevention Program, how asthma organizations can apply the IEDOH framework to their community-based asthma work to reduce disparities. So they threw in a polling question. Do I hit the green button to get the polling question? Okay. Okay. What percentage of children living in poverty suffer from asthma?
Give it about 5 more seconds.
So do we want to stop it? I think we can stop it. Oh, did you get some responses online? Okay. Okay, so on this slide, you'll hear the answer to the polling question. The EPA's asthma program's focus has always been on the reduction of asthma disparities and centering our work around the role of in-home environmental interventions has a critical component of comprehensive asthma care. Children in poor minority populations are disproportionately affected by asthma, experiencing more adverse health outcomes from and hard to control asthma. These children primarily receive coverage through Medicaid and are more likely to live in substandard housing. We know that the built environment plays a critical role in community health outcomes, and it has been challenging to get healthcare payers to finance or reimburse for in-home asthma services. So as you can see on this slide, the answer to the poll was about 10%. However, this has been our goal, again, for the past 15 years, addressing health equity by prioritizing support to communities to deliver and provide sustained access to in-home environmental interventions for children with hard to control asthma. The initial strategies we employed for achieving this goal were to build expertise by investing in projects that establish an evidence base and spotlighting best practices, as well as growing our networks and creating a system for spreading, effective practices to stakeholders. Over time, many of these program elements continue to grow, such as our National Environmental Leadership Award in Asthma Management. Hi, Erica. While others emerged out of a new focus on facilitating policy adoption. This work equipped the asthma program with valuable solutions to environmental asthma triggers that deliver a broad benefit in addressing social determinants of health. The social determinants of health, or SDOH, is terminology now commonly used in many sectors. How many people have heard the term SDOH before? Okay, I knew I was preaching to the choir. Okay, but I got a script, so I'm gonna keep going. Particularly in public health and also in the housing, environmental, energy, and community development sectors. SDOH are the conditions in the environments where people are born, live, work, play, and age, like I'm doing, aging, that affect a wide range of health, functioning, and quality of life outcomes and risks. As you can see in this infographic on the slide, SDOH can broadly be grouped into 5 categories: individual behavior, social circumstances, genetics and biology, medical care, and the physical environment. This infographic is based on a literature review, is one of the ways to visualize the categories of SDOH, as well as estimate each category's relative contribution to community health outcomes. This graphic also aligns with the Health and Human Services People 2030 initiative and the World Health Organization's definitions of social determinants of health. As part of our asthma program work, we have encountered this terminology more and more frequently and felt it necessary to contextualize where our work fell in the large spectrum of SDOH. Okay, there we go. All right, so zooming in on this graphic, which I know is hard to see, but we can always give you the slides later. The asthma team was able to see where our work fell in the category of the physical environment, which makes sense, right? Physical environment, indoor environments, right? Okay. And what we are calling indoor environmental determinants of health, or IEDOH. We define IEDOH as a subset clustered in the physical environment that co-vary with housing, quality, and medical care, the intersection of environment, health, and housing. There are modifiable environmental factors indoors, such as household air pollution, the presence of pests, mold and moisture, chemicals and irritants. I used to call these back in the day when I first started working with my team on asthma, I used to call these our filthy five. Among other examples highlighted in the yellow boxes in the graphic that influence risk and experience of chronic disease. IEDOH and SDOH cluster in medical care, which are highlighted in blue, are both key drivers of community health outcomes for asthma. Using this IEDOH lens to discuss our work brings into focus the critical role of in-home environmental interventions as a component of comprehensive asthma care. All health and structural work indoors offers a chance to address or worsen IEDOH, particularly in the case of asthma health outcomes. IEDOH within the context of social determinants of health, let's take a look at it within the context of EPA in our asthma program. Has the agency charged to protect public health and the environment, in this case, the indoor environment, we are uniquely positioned at the center of health and housing coverage. Through our work, we understand the role and impact of housing on health, particularly for children with hard to control asthma. It is also clear from leading innovators in the field that severe pediatric asthma is a sentinel of disproportionate IEDOH exposure, which is often associated with substandard housing quality. Put simply, homes and buildings, and I think I'm gonna go ahead and, well, school is a building too, but homes, schools, buildings, and their corresponding indoor environments where people spend 90% of their time may either reduce or amplify an individual's quality of life and disease outcomes. By focusing our asthma work within the context of IEDOH, we are uniquely positioned to help expand partnerships across health, housing, energy, and environmental sectors who are going into home and recognize the relationship between the built environment and health. So again, that interconnection between environment, health, and housing. Over the past year, we have started to incorporate this IEDOH terminology into our asthma program work. One example of this is our new webinar series. The first webinar in our new series, Solving for IEDOH in Asthma, was held on October 25th, just last month. One way to solve for IEDOH in asthma using data. We've heard a lot about using data today to prioritize in-home environmental interventions. Excuse me. We at EPA recognize that using data and analytics is a strategy for systems change. I love when our team talks about systems change and using data and analytics, and how to make your program have a foundation for what you want to do, to implement comprehensive asthma programs. The webinar emphasized that any and all asthma or environmental data can be used to help address IEDOH, to improve the indoor environments of people with asthma, and highlighted 3 compelling stories from different perspectives that showed this principle in action. The webinar started with a community-based organization, excuse me, who works at the hyper-local level, specifically at the level of public housing. Their community is not only impacted, but overwhelmed by IEDOH and the cumulative impact of multiple environmental stressors. Then we highlighted research done at the city level and how data on asthma ED visits can be used to predict substandard housing before a failing score on a housing inspection. Finally, we spotlighted a county public health department work on understanding environmental factors that affect different asthma ED rates throughout the county, and how their Healthy Homes program is using that analysis to prioritize communities for in-home environmental assessments and remediation. Excuse me. This recorded webinar will soon be posted on our asthmacommunitynetwork.org. That's another place that I offer you to go to and to join. And it is on the handy dandy flyer. So it will be posted there and archived. And then when we have the next webinar in our series, that's where you can also find out information and register for that webinar. Moving forward, we plan to continue to lead and learn by using the IEDOH terminology, and we hope to build meaningful partnerships across the health and housing sectors to create community-level systems that solve for IEDOH. As the health and housing sectors increasingly seek each other out to support sustained access to in-home interventions within the context of solving for social determinants of health, there is a potential to increase sustainable financing streams and workforce capacity. I'm thinking community health workers and expertise. When this occurs, communities have the ability to expand the scope of interventions they are offering. So rather than focusing on supplies and services tailored for asthma triggers, the interventions may also cover more structural remediations, such as housing that improve IAQ. As a community expands scope of an intervention, they shift from a focus on just asthma to providing multi-benefit solutions for children and their families, who are most affected by social determinants of health. When this happens, there is a potential to expand positive impacts on the population health level, as well as reach children with hard to control asthma and undiagnosed asthma. EPA is working to equip communities and asthma programs with the knowledge, examples, and insights they need to put into place comprehensive asthma care systems that address indoor environmental determinants of health. This is our objective because we know that when those systems exist, we can deliver on the vision that we know is possible where barriers for accessing environmental asthma home visits are eliminated and the lives of all people with asthma are improved. We hope that this terminology, indoor environmental determinants of health, will help create a shared understanding across sectors so that meaningful partnerships can be created to help create the high quality asthma care systems needed to deliver the vision. Though each community strategies may look different and different mechanisms for payments, workforce, data, and delivery will emerge, each suited to their unique policy landscape and asthma burden. We know there are common strategies that work for building, getting results with, and sustaining comprehensive asthma care systems. And we at EPA are here to help every community nationwide to take them. So in conclusion, for now, I'm from the government and we're here to help. And now I will turn it over to Ann.
All right, good afternoon. It's a pleasure to be here. Thank you to AAN for inviting us to be here today. First, for those who are not familiar with RAMP, our mission is to reduce the burden of asthma with a focus on health equity. We don't provide direct services to people with asthma, but we support those who do. We build capacity through providing tools and technical assistance. We bring people together for peer learning and network development, and we mobilize our networks for policy and systems change. We are a project of the Public Health Institute. We're based in Oakland. We lead work statewide, and we support work nationwide. So building off of Sheila's presentation, what does it mean for an asthma organization? How can focusing our asthma work within the context of indoor environmental determinants of health help reduce disparities? I believe there are 4 key actions. The first is to use data to prioritize in-home indoor environmental determinants of health interventions. The EPA is really leading the way on highlighting how organizations are already doing this, and I encourage you all to watch the webinar that Sheila described. Today, I'll focus on the last 3, which are use the proven intervention of asthma home visiting, make these interventions more sustainable through policy and systems change, and develop partnerships across sectors. So I'm sure I don't need to tell anyone in this crowd that asthma home visiting is an evidence-based intervention that has been proven in study after study to improve asthma outcomes, reduce healthcare costs, and reduce disparities. In 2019, the state of California allocated $12 million to support asthma home visiting programs. 28 organizations, including community-based organizations, local health departments, and clinics, were funded to provide asthma home visiting services for 3 years. An external evaluation team identified 6 components of successful home visiting programs based on this initiative. In sum, the model of success is comprehensive asthma education and trigger remediation provided through in-person and/or virtual visits by community health workers or others, practicing culturally responsive and patient-centered approaches. But most asthma home visiting programs have had to rely on grant funding. So how do we make these interventions more sustainable? For that, we need policy and systems change. For years, we at RAMP, in partnership with many advocates across the state, have been working toward two goals related to asthma home visiting services. The first is to expand asthma home visiting services for low-income Californians with poorly controlled asthma. The second is to improve the financial sustainability for asthma home visiting programs. And these two goals, of course, go hand in hand. Pictured here is California Senator Melissa Hurtado, who was introducing legislation on this topic back in 2019. And we have had success with two policies within California's Medicaid system called Medi-Cal. The Asthma Preventive Services benefit was enacted through a state plan amendment, and the asthma remediation option is under a program called Community Supports, which was enacted through the Medicaid waiver process. Asthma Preventive Services covers asthma education and a home trigger assessment. Asthma remediation covers remediation, both supplies like HEPA air cleaners to help reduce exposure to wildfire smoke and other sources of pollution, and services like mold removal or integrated pest management to control pests without the use of harmful pesticides. Importantly, these services can be provided by non-licensed professionals like community health workers. And most of these community health workers go through the training program that Natalie described, the Asthma Management Academy. So combined, these two policies support comprehensive asthma home visiting services. Now, there are many different paths to policy success, and there are many different policies that could achieve the same outcome. But the three key elements for us are likely necessary for anyone pursuing sustainable asthma home visiting services: persistence, agency engagement, and partnerships. So in terms of persistence, I'll just say it was a very long and winding road. Our policy efforts began in 2015, included two pieces of legislation, a state budget process, an allocation of funds for a 3-year grant program, and finally, here we are in 2023 with two policies in place. Then there's engagement with the state Medicaid agency. We built relationships with staff and stayed in communication over years to share our priorities, ideas, suggestions, data, etc. We engaged with leadership as they're the ultimate decision makers, but we also engaged with staff at the program management level because we found that they often have longevity and remain in their positions even when leadership changes due to politics. The third key to success was our partnerships. We worked hand in hand with two partner organizations on all of the policy efforts: the California Pan-Ethnic Health Network and Children Now. In addition, a whole network of partner organizations was instrumental to the policy successes. And this is just a partial list. Some of these organizations engaged directly with the advocacy process, providing testimony about the impact of asthma home visiting. Some provided information to inform our advocacy work, or data or research that we were able to use in the policy process. Regardless of the role, this work requires partners, and lots of them. The fourth key action to implementing an approach within the context of indoor environmental determinants of health is to develop partnerships across sectors. Sorry, I lost my place on my notes, and I'm in need of notes as well. Oops. Okay. 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 So developing partnerships, as Sheila described, across health, housing, and the energy sectors is really important, and it's really hard work. Fortunately, we have a lot of models in place. The Contra Costa County Health Department in California has an asthma home visiting program, And they partnered with an energy efficiency program to systematically do families that needed both. And the EPA has done a webinar on this topic that you can find on the Asthma Community Network. We also have developed partnerships with tenants' rights and affordable housing advocates because housing quality, affordability, and tenant protections are inextricably linked. And we lead the California Healthy Housing Coalition, which is a cross-sectoral statewide network that works on policy change. We made California the first state in the country to list mold as a substandard housing condition, which is kind of crazy to think about. And just this year, we had legislation signed to improve code enforcement because landlords need to be held accountable for providing safe and healthy housing. So hopefully through this brief presentation, I've provided some useful examples of how we can focus our asthma work within the context of indoor environmental determinants of health to help reduce disparities using these 4 actions. But I also want you to know that if you pursue this work, as you pursue this work, you do not have to do it on your own. RAMP has been partnering with the National Center for Healthy Housing on a cooperative agreement with the EPA. And as part of this agreement, we've developed a number of tools to help communities and states move toward sustainable asthma home visiting and cross-sectoral partnerships. The first tool here is called Unlocking the Power of Home-Based Asthma Services, and we published it in September of last year to equip managed care plans or other healthcare payers with the information they need to improve asthma outcomes. In December, we launched a new module of our e-learning course designed to support organizations in considering or implementing virtual asthma home visiting in part or in full as part of their approach. And the third resource pictured here is the roadmap to sustainable asthma home visiting, which we released just in July. And this is a roadmap, an interactive roadmap to support the development of asthma home visiting services. Oops. I got the right, okay. We also, both RAMP and the National Center for Healthy Housing, as part of our partnership with the EPA, provide free responsive technical assistance. So if you're part of a group or interested in thinking about some of these policy and systems change approaches, we encourage you to reach out to us. And thank you.
Thank you so much. Love both of your presentations, but this is a huge problem. And I know in New Jersey, it's not like it's the same everywhere, that you identify the problem and you are trying to fix the problem, but the problem does not have the money behind it to truly address the remediation. And the piece that I think that is most important is that in public housing in particular, in low-income housing, where there are shared triggers within that community, I'm wondering, and this may be a question for Sheila, and right now probably isn't the time with the legislature the way it is, but has there been any movement where HUD and where the money is for housing and where we really have the remediation dollars? Is there discussion about, and I believe that I heard some news recently that there was some funding that was awarded, but is it to address those types of systems where it's an entire community? Because you have, hundreds of families staying in a same community with the same triggers, next door neighbor to neighbor. And so I'm just wondering whether there's been talk about concerted efforts to address not just one house at a time, but address those whole communities.
Did you want to, or do you want to bring her mic? Yeah. Thank you.
Because I got to come down. So thank you for your question. We do work very closely with HUD, and I cannot really speak skillfully on what HUD is doing, but I would check out their site. And if you reach out to me, I can also try to put you in contact with one of our HUD contacts. They're one of our major players in the whole environment, health, and housing.
How does this impact legal status? Do you have to be legally in the United States to qualify for these services?
I'm gonna let Ann answer that about applying for services.
California provides Medi-Cal to most residents regardless of documentation status. And so the services that I described would be available to undocumented immigrants as well.
Any other? Figured if I move my shoulders, I'll move faster. Doesn't really work.
Keep you warm. Thank you to both of you. I've had the privilege of sitting with you for the day, so I've gotten some sneak previews. The RAMP program is outstanding, and the roadmap made it look probably much faster and easier, but I am beyond in awe of what you accomplished and probably how long and hard you had to work to get there. What kind of data are you still collecting about outcomes to go back just in the event that Cal Medicaid ever decided to change its mind about coverage to be sure that you were really showing the positive outcomes?
Yeah, that's a great question. So the 3-year grant program that I described was really the data that they were collecting. The first year of the grant was in 2020. And as I think everybody knows, in the asthma world, emergency department visits for asthma plummeted during that time. And it was just a really strange time. So while they were originally going to look at healthcare utilization and related costs, the evaluation team decided to shift. And they did look at some outcomes like, did asthma control improve self-reported missed school days and work days, and just massive improvements across the board consistent with what's in the literature. Now that it is being covered under Medi-Cal, yes, they will be looking at utilization and claims and outcomes. And so I have no doubt, though, that the services will continue to prove their incredible impact because the literature is so well established.
Sorry, it's me again. I have a question in regards of the resources available for our community. I started with a grant. I've been working for 23 years on these clinics, and I started with a grant of 1 year where we were able to get some funds to help the families in the community. And after that year, they find out that the asthma education, not me, but the asthma education given to the patients was actually getting a lot of good, impact on the patients and the parents. And we were looking into resources, and we do it inside our clinics because we couldn't get another resources after that grant was done. There was no more money for it. And us as employees, we give money from our paychecks. And we have a program that we call ISU, I Support You. And they present certainly programs on the clinics. And one of those programs is the asthma program. And then from the money that we provide, that's when we buy stuff for our patients as incentives. Now it's like people with economic situation and everything, it's not that easy that, they giving as is needed for our families. So my question comes, how we can get those resources or funds for our patients back so we can provide those for the home visits, because I was previously as well on a home visit programs, and it was such a good help for our patients. But now we're like very short on those resources. How we can get that help for our program, for our patients?
It's I was going to say, the first thing we should do is set up some time to talk after this conference. But real quickly, so this would apply to the second policy I described, which is called asthma remediation. The Medi-Cal managed care plans can opt in to provide this service. So it's not every plan is doing it, but we're pleasantly surprised to see that most have opted in. And then they contract with one or more organizations serving their geographic area to provide asthma remediation services. The policy allows them to spend up to $7,500 per individual on remediation supplies and services. So it provides a really important opportunity to support clients. And the next step would be figuring out how to get your organizations connected with some of the Medi-Cal managed care plans that have selected this option and to help form that relationship. And I'd love to support you in doing that.
Any other questions? I think we're all set.
Thank you.
Is it, right? Hey guys, guess what time it is? It's break time. I almost wanted to be like, hump day. You know that commercial with the camel? No, no one knows that commercial with the camel? Right? And he was like, Mike, guess what time it is? And Mike was like, what? And he was like, hump day. All right, y'all don't get it. It's break time. I'll come back. just wanted to make sure you weren't like, what? Really? He says that? Does he? Huh. Okay. Hello, hello. We are back. Before I forget, there is an evaluation form for on the table. Please fill it out. If you know a friend who has left already, please send them the information. Also, if they took a folder, let them know that it's in the folder as well. Oh, it's on the table? Oh, right, but also that little sheet on the table. Yeah, yep, so just scan that QR code. That's right. Come on, students, y'all better hold it up. I love it. I love a good, okay, a good helper is amazing. So, again, if you know somebody that's already left that was maybe at your table, please send the info to them so they can fill out that evaluation. Appreciate it, appreciate it. So we're gonna move on to our next lecturer. Good break, photo ops, networking, love it. So we'll get to Dr. Hogan. So she is the professor of pediatrics at Eastern Virginia Medical School in Norfolk, Virginia. Also, English is my third language. So is that how you say it, Norfolk? Okay. Because sometimes I have ESL moments. Norfolk, wonderful. Great. So she is also a senior partner of the Children's Specialty Group. She is a graduate of the University of Louisville Medical School, completed her peds residency, Corsair, see? Corsair Hospital AI Fellowship was in University of Virginia in Charlottesville. And she is a fellow of the ACAAI, and she is also a fellow of the Quad AI in the American Academy of Pediatrics, vice chair of ACAAI AsMA Committee, and the AAP-NCE Planning Group. She's a member of that. And she has developed, promoted, and participated in multiple outreach programs and EMT with EMT and community physicians. So in her most treasured time, because we all have these treasured times, and I appreciate that being part of your bio because I feel like you don't highlight that enough. But in her most precious time, she likes to spend time with her 3 amazing children and a dog, Oliver. Isn't that interesting when dogs have real people names? But she's currently learning to play bagpipes. Okay, I look forward to you telling us how that's going and giving us some GINA 2023 updates in the future of asthma care. Dr. Hogan, everybody. Oh, this is my phone, yeah.
Got to start the timer. Good afternoon. Thank you all very much for sticking around. And I'm very excited for this opportunity. And I'd like to thank the Allergy and Asthma Network for giving me this opportunity. And we are going to update and learn some fun things I think about asthma that will help us take care of patients better. So that's my title. The only disclosure, it's really not relevant, but I was on the Speakers Bureau for GSK. So what we are going to do today is I'm going to give you what I think are the 8 most important changes in GINA in 2023. Then we are going to discuss how to apply these changes to your patients and your practices. And then I'm going to propose what I think are smart tables for the US because they're really hard to find and nobody's really, I think, put forth a good table. So that is what I propose to do. So what I would like to remind you is that asthma is not one disease. It's sort of a dump term that we put lots of things into. The overwhelming thing that asthma is it is, as we know, reversibility. It's also airway inflammation, and it is airway hyperresponsiveness also. But we can see lots of different things that lead to that aspect of asthma. So, and there are many, many things that are triggers. For some people, it may be exercise. For other people, it may be viral infections. For other people, it may be allergens. And then we know that there's difference in symptoms. Sometimes there's people who just cough, and sometimes there's people who out and out wheeze, it seems like all the time. And then there's people who have combinations of those. We also know that there's clearly differences in severity. There are some people we call mild asthma and some people who we call very severe asthma. And we also know that all medicines don't fit every patient and that there are differences in responses to those medicines. And then we also know that there are other comorbid conditions that can impact asthma, like nasal polyps, or perhaps we have patients that have EOE or obesity, or all of those things that come together to impact how we manage asthma. So I want to remind you that one size doesn't fit all when we are talking about trying to manage asthma from many aspects and certainly from a pharmacological standpoint. I want to remind you that asthma is a big deal, especially financially. Asthma is the most common chronic disease in childhood. 6.2% of children under the age of 18, according to the 2022 statistics, currently have asthma. So that's a lot of children in the United States. And we know that 50% of those children have asthma that's considered uncontrolled. And of those children who have poorly controlled asthma, they cost twice the annual cost of care than those children who actually have controlled asthma. So poorly controlled asthma costs a lot more money. And then when we take into account severe asthma in children, which makes up about 5% of children who have asthma, they account for 50% of the healthcare dollars that are spent in the US on asthma care. Socioeconomically, asthma makes up about a $56 billion cost annually in the United States. So asthma is a big deal on multiple levels. So this is your polling question for this talk. What percentage of children less than 18 reported having one or more asthma attacks in the past year? Now do that over, under, kind of pick somewhere in between. And we are letting you poll now. And it looks like the blue has the upper edge. Haha, everyone's blue. And now we'll sing the Jeopardy theme and we will stop the question as soon as we hit the right button. Did we hit it? Perfect. All right. So what is the answer? How many kids have had an asthma attack in the past year? Well, according to the CDC statistics, the most recent data that we have from 2019 says that 44% of children less than 18 had one or more asthma attacks in the past year, which is a lot of asthma attacks in kids who supposedly at least 50% of them have well-controlled asthma, quote unquote. So we see a lot of morbidity that is associated with asthma, but there's also asthma mortality, and we always need to keep this in mind. What we know is that in 2020, if you can see here with my little laser pointer, 2020 was the first time in 20 years that we actually have seen once again a rise in asthma deaths. We were doing very well nationally, and we were seeing less and less asthma deaths, but something changed, and there's a whole bunch of theories which we won't have time to do today, but there has been a change again in asthma mortality. And on average, 11 people in the US die from asthma every day. And as we've heard so well today, there is a significant disparity, not only in morbidity, but also asthma mortality in terms of racial disparities. And what we know, as you can see here on this bar, that Black people in the US are nearly 3 times as likely to die from their asthma than white people in the US. So what are the potential mechanisms that lead to childhood asthma? One of the things that I'm very passionate about and very interested in is trying to do prevention or understanding of what things come together to lead us to have children who have asthma. And so I thought I would be very oversimplistic on this slide and actually give you some examples of things that all interplay together that lead to the development of childhood asthma. There's certainly prenatal factors, there's allergen exposures, both prenatally and early in life. and then ultimately in later childhood that come together to lead towards asthma. We know that the wrong virus at the wrong time can certainly lead to the development of asthma. We know that climate change and temperatures and the environment we live in. We know that our microbiome, which is what kinds of bacteria were colonized in our lungs, in our nose, all of those, which bugs are where and when they're there, certainly play a role in the development of asthma. And then we know there are other environmental factors and then human behavioral things like obesity and our diet. And then don't forget tobacco smoke and irritants and particle size and pollution. Oh my goodness, so many things that all come together that do lead us towards asthma. So now the topic that I have been given for you all, how many of you all have heard of GINA? And I don't mean Gina Davis, but I actually mean GINA, which is the Global Initiative for Asthma. Good, because that's what we get to talk about now for the rest of our time together. So the Global Initiative for Asthma is actually celebrating their 30th anniversary this year. And their main goals is that they want to improve the lives of individuals around the world who have asthma, thus the global part. And it's really not guidelines, although all of us who deal with asthma management will say the GINA guidelines, but they don't call themselves the GINA guidelines, by the way. They're actually, they say a global strategy, a report that is based on evidence-based medicine. They come together twice a year. They review what all the most recent literature and science, they grade that science, and then they come up with recommendations and things that they think are going to help support the best asthma care. So what are the key changes for 2023? Well, I'm going to give you 8, and number 1 of the first key changes, which I think is probably the most challenging, is they're changing words on us. They have decided to rename some of the terminology that we use for asthma. Most specifically, they have focused on changing the word controller to maintenance. They like the word maintenance better, and that's any asthma treatment that has been prescribed for everyday use. They also would like to use the word reliever because that doesn't have as many threatening terms as rescue or 911 inhaler that might keep people from using that medication because they think, oh, I should only use it if I can't breathe or I'm turning blue. They really want you to use the word reliever, which implies more that this is the as needed medication that we're going to use when we're having need quick relief of our symptoms. And then here's where it gets funny. When we just all thought, okay, I think I figured out what SMART means, they're now like saying, well, we don't really like the word SMART. So we're now going to split SMART into 2 different terms. But everybody you know is still going to call it SMART, by the way, until years and years go by. But they have a reason why they don't want you to use the word SMART. So the new words that they want to use is they want to use the word AIR. AIR stands for anti-inflammatory reliever. So what that is that's actually a medication that not only has a short-acting beta agonist like albuterol or formoterol in it, but it also has an inhaled steroid. Because what we know, as we've learned more and more about asthma, that unopposed albuterol can be dangerous. And if you need albuterol, there must be some reason why you need albuterol. And that reason must have some inflammation with it. So if you can throw a little steroid along with that, then you're going to be able to manage the asthma better. So they like the term AIR, meaning anti-inflammatory reliever medication. And in GINA, that only includes a couple of medications. That is an inhaled corticosteroid formoterol product or an inhaled corticosteroid SABA or albuterol product. And we'll go over these a little bit more clearly. But what they say is that AIR therapy can provide rapid relief, plus you get the little bonus of that extra steroid thrown in there. It can reduce exacerbations than just using albuterol alone. It can be used before exercise and before allergen exposure. And as we go through the GINA steps, it can be used in step 1 and 2. And now instead of SMART, they want to use the word MART. So when the word SMART came out, we talked about it meaning single maintenance and reliever therapy. They don't want to use the S anymore because a lot of people thought the S stood for Symbicort. And so it was Symbicort used as a maintenance and reliever therapy. And we all know that there are other medicines besides Symbicort or generic things that have the same medicine. The other thing too is when you imply that it's a single maintenance, they say, well, actually people should have 2 inhalers. You should have one at home and one at school, or one at home and one in your backpack. So you're not really just having one inhaler. They may be the same thing, but you're going to have 2 of them. And so we don't want to use SMART anymore. So as we move forward and look at the new GINA guidelines, the word MART is going to be used instead of SMART. And hopefully I will remember as I speak not to add that S in there. But anyway, that's the first change in terminology. And again, for them, what they say is that MART is one inhaler that's used as a maintenance and reliever, and then it can be increased whenever there are symptoms of illness or even short-term symptoms. And in this country, the medications that we have available are budesonide formoterol, under the trade name of Symbicort. And we also have memetazone formoterol, and that's under the trade name of Dulera. And the thing that all of those have in common is formoterol, and that's really important as we move forward in our discussion. There are now ICS SABAs that is called Airsupra in this country on the market most recently. But that's not supposed to be used for controller medicine, and we'll talk about that in just a second. So what is different about GINA? Well, as you can see, I have circled some of the changes on this next slide. This is for the asthmatics that are from 12 and up. And the first thing that GINA did is GINA said, hey, let's put the date on these charts because there's so many versions of them out there now. You might have one put up and you look at it and what year was that one? So now moving forward, they're going to put the year that the chart was done. And so 2023, they put 2023 on the chart so that you know that's when the chart is. The next thing that they also did is they used their new terminology talking about what's preferred and what track. They use controller and the reliever. And they also are now using the terms AIR, as we just mentioned, and also the term MART. And what they say in these new guidelines is that they're being very strong about there is a preferred track that we think patients with asthma should be on. And that preferred track should be on steps 1 and 2 in the older individuals, that they get as needed low dose ICS formoterol. And for their rescue, it's ICS formoterol, so 1 inhaler. And then as you step up in your asthma therapy, we step up in the amount of steroid combo that you get, and you're still using the ICS formoterol as a rescue. And they say that's so much simpler. Everybody should follow that because it's 1 inhaler. And so what they say is the reason why that's so very helpful is because you can easily step up and down. Oh, and by the way, I am told that you all get to have my slides if you'd like to have them, that they're going to be posted because there's a couple tables I think you're going to want, that they will be posted after today's over, some link or key, and they'll tell you how to get there. So don't panic about like, oh, I need to have that slide, because you will in fact have that slide. But anyway, back to this. So the other thing that it is very helpful is that as symptoms occur, you don't have to change the maintenance medicine. You can just go up and down on how much you need to help relieve the symptoms. So it avoids confusion. And then we're not trying to teach them multiple devices and have a spacer for this one or not a spacer for that one. We simply need to teach them one device and make sure they know how to use it. And that's much easier and simpler for families. I'm sure you all have asthma patients who, in the midst of they're having an asthma attack, what do they run to? They run to their albuterol, and they take a lot of it because they get immediate relief from it. And that may be the only inhaler they can find. And they forget, oh, I did have a controller medication somewhere, and I don't know where it is, but I've got my albuterol. And as we know, more and more albuterol use is not necessarily going to abort an asthma exacerbation. So having one inhaler is going to be able to help them from have not as severe of an exacerbation. And so they really emphasize this preferred track is much more simple. And they actually have a lot of science and a lot of patients to back up their position. What they know is that for step 1 and 2, that there is significant evidence that says this ICS formoterol combination is very effective and very safe and much better than using albuterol alone. And they have roughly about 10,000 patients now from studies that demonstrate that for step 1 and 2, this is the preferred way that Gina says we should do it. And then in steps 3 and 4, they have about 30,000 patients from studies that demonstrate the effectiveness of MART therapy, having the one inhaler that is both a maintenance and a reliever therapy, the safety of it, and also the efficacy of it. And we know that both the ICS and formoterol contribute to reduction in the severity of the exacerbations, and the safety of it has well been demonstrated. And a couple of these are actually Cochrane reviews, which many of us feel is the standard of supreme evidence-based medicine that you can to look at a subject. If a Cochrane review says this is how it is, many of us feel that's how it is. So there is a lot of science to support this ICS formoterol. The third thing that we know is that something new has come on the market, and Gina has now added that to their guidelines. The new thing that has come on the market is this ICS SABA, the inhaled corticosteroid that's with an albuterol. And in this country, the FDA approved this medication in January of this year for 18 and up. So big asterisks on that one at this point. And this is the Supra. I want to put the R in the wrong place. This is the Air Supra product that is out. There's only one of them so far on the market, but it makes good sense. Again, if you need albuterol, you probably need some inhaled steroid too, and you might as well put them both in the same container, because then you're more likely to chase away the inflammation. But because of this new product, we need to update the tables and discuss where would that fit in our asthma guidelines. So as you notice here from the asthma guidelines, again, we are still in the 12 and up. You can see here in track 2, which is not the preferred, but better than plain old albuterol alone, you can see that the ICS SABA or ICS albuterol has now been added as a reliever option in addition to the old as needed albuterol. And one of the important points that it's also here is that you should not mix LABAs. Okay, remember LABAs are long-acting beta agonists, so you may have patients who are on something like Advair for say, that they are on that combination product that has fluticasone and salmeterol, and let's say you got that, and now you're gonna give them, say, Symbicort as their reliever. Don't do that, because they're gonna be on 2 LABAs, and the safety of 2 different LABAs together has not been demonstrated. And when will that really become an issue? It'll become an issue if you take care of patients out here that are on step 5. So step 5 patients are on triple medications oftentimes. So they may have a long-acting muscarinic antagonist added to it. And if you buy that product with all 3 in one inhaler, and then you start using a formoterol, ICS formoterol as a rescue, you might have a potential there to have 2 LABAs that are not the same. So they caution you about making sure that whatever medicines you're mixing, you're not mixing LABAs. Okay? Does that make sense? Good. All right. So, so then the question comes up, okay, well, now you have this ICS SABA, short-acting albuterol and an inhaled steroid. How does that compare with using albuterol alone? Is there anything to support that we should be having an inhaled steroid go along with this albuterol? And the answer is yes. There was a recent study from last year that was published in the New England Journal of Medicine, and it was called the Mandela study. And the Mandela study actually was a very interesting study because they took, first of all, it was a double-blind, placebo-controlled study, and they took patients and they put them in one of three arms. So in all three arms, they all three got equal amounts of albuterol for their rescue medication, but in one arm, they got no steroids. In one arm, they got a medium dose of steroid, and in the third arm, they got a higher dose of steroid. And what they looked at is they were to use that medication as their rescue medicine, and they looked to see how long does it take these severe asthmatics who were prone to severe exacerbations to fall out and have a bad attack. And what they found is that in the patients who got the higher dose ICS SABA than the ones who got the SABA alone, it took them longer to have their asthma attack. And they felt like it was more protective because they had that inhaled corticosteroid there to help preserve their asthma function. And actually in the actual numbers, the time to the first severe exacerbation was increased by 41% in those patients that had the higher dose of budesonide and albuterol compared to those that just had albuterol alone. But there's still a lot more studies that need to be done. We don't have head-to-head comparisons of ICS LABAs with ICS SABAs with MART therapy. And so we really don't know it yet, but I'm sure it will be coming, how to argue for the exact place where ICS SABA should fit in. We still think, we meaning Gina, and I'm now on Gina's team, we still think that SMART or MART therapy is still the best way because it's just one inhaler and they're not confused about which inhaler to use when. Number 4, there is new commentary and continued emphasis on asthma management cycle. We've seen these from Gina. They talk about assess, adjust, and review. I put for you here what the goals of asthma treatment are. And what the long and short of it is Gina wants to remind you that before you escalate therapy, you need to make sure that they're doing what you say correctly, that they have the inhaler, that they know how to use the inhaler, that you've addressed comorbidities, that you have made sure that everyone's on board with understanding the medicines, that you've addressed their concerns, that you know what exacerbations they've had, what their lung function is. Every time you see the asthmatic patient, we should be reviewing their techniques and make sure that, like many times in my teenage asthmatics, oh yeah, I didn't like that spacer, it looked dorky, so I don't use it anymore. Or maybe they've totally forgotten how they were supposed to have used the inhaler at all. So we want to refocus on those before we escalate therapy. And then at the same time, if they're doing well, then we want to be able to step down and manage their asthma better. So one of the other things that has been added to the GINA 23, on this table, I have for you the 6 to 11-year-olds. And what I want to point out for you in the 6 to 11-year-olds is that MART is not an option until step 3 or step 4. We do not use in step 1 or 2 in this age group an ICS LABA as a rescue-only inhaler. And the other thing that's been added also is that anti-IL-5 is now approved down to the age of 6, and that has been added as an effective step 5 therapy that is mepolizumab or Nucala. That is now approved and has been shown to be effective as a step 5 agent in this particular age group. Number 5, Gina has a lot to say about severe asthma and how to manage it. And so what they say again is that we should not be escalating to biologicals in patients that we have not adequately controlled their asthma with primary asthma medications. And as we know, biologics can run up to $34,000 to $50,000 a year to somebody in the healthcare system, and we shouldn't necessarily escalate to them until we have proven that they are in fact a severe asthmatic. And there's a lot of confusion about the biologics. Certainly there are no head-to-head studies. There's a lot of confusion on which one of them is best for each patient. Gina has published in 2023 some severe asthma guideline updates. And also I put together for you a little table of how the biologics are currently. So in my table, basically I have listed for you the biologics that are available: omalizumab, dupilumab, let's see, the mepolizumab, benralizumab, and tezepelumab. I think I put an extra syllable in that, tezi. But basically what we know is that most of these are now approved for 6 or 12 and up. We know that many of them can be given at different intervals every 2 to 4 weeks. So I've put that on this table for you. Many of them can be given in the home or the office. They come in pre-filled syringes or pens. So I tried to put that in the table also. And some of them are approved for other conditions. And so that may be by a priority why we may think about using that particular biological in kids because of that. And some of those conditions are listed there. And then there are special considerations that we want to know. For example, with Xolair, we know that there is a risk for anaphylaxis. We also have some concerns about live vaccines potentially with Dupixent, especially because we may use it in kids as young as 6 months. And then there's also a question about herpes zoster with Nucala, and their mode of action is listed there also on the slide for you. In addition to that, I want to bring up the table, the 6th change, which is treatment in children less than 5. And the main thing that Gina wanted to do here was make a clarification. So what many of us do in patients who have a wheezing episode is we give them a short-acting beta agonist. And Gina says that's appropriate. If you have a wheezing child, you should do a trial of a short-acting beta agonist, unless it is, of course, RSV or bronchiolitis, which short-acting beta agonists have not been shown to be very effective. But in addition to that, what do you do for the kid who has multiple episodes of wheezing, and when do you need to start a controller medication? So what Gina has tried to do is clarify that better. And what they say in step 1, if you have someone who has used albuterol, it has been helpful, and they have a new viral onset, we might consider a short course of an inhaled corticosteroid during that viral illness to help them get over it more quickly. But if they are someone who uses short-acting beta agonists more than twice a week for over a month, meaning that virus is long gone and they're still having symptoms even when the virus isn't there, then we should be thinking about a controller medication for these particular children. And you can see here in the GINA guidelines from 5 and younger, you can see here that in step 1, we don't need an everyday controller medicine, but we may consider using short courses of inhaled corticosteroids during those particular illnesses. And number 7, there is practical guidance on medication dosing. There's at least 6 slides in the GINA guidelines of how do you dose the medicine. But the problem is they are for European medications that we do not have in the United States, which we're going to go over in 1 second. But basically what they say is if you want to use MART therapy, you should reassure the patients that it's just as good as using an inhaled corticosteroid with a SABA, that we would like for the patients to have 2 inhalers, 1 for home and 1 for school. And that the other thing that's very interesting is we don't see much thrush at all with Salmeter or with Symbicort or Formoterol and budesonide. So we probably don't need to stress over and over again about rinsing your mouth out. They say you can certainly do it with maintenance, but you probably don't need to worry about them rinsing their mouth out if they are using it for rescue. There's very low frequency of thrush. And they say it's also important that patients have an MART action plan. But the confusion comes with how many puffs do you use and when do you use it? So this is this beautiful table that has the medications that are available in Europe, not in the US. So what are the medications that are available in yours? Yes, there's budesonide for Motorol, but it's a dry powder inhaler and it's a 200 per 6. And then they have beclomethasone that's available as an MDI, and we don't even have that in this country, and it's a 100 per 6. And so when we look at what the recommendations are for Gina with dosing, these are what the steps are. And Gina says, oh, if you're using an MDI that contains 3 of formoterol, then you need to take 2 puffs. But in the US, we have formoterol in 4.5, or if we look at Dulera, we have it in 5, and 4 and 5 are not 6 and 3. The math just doesn't work for me. So based on that, how many puffs should you take with the medicines that we have available in the US? And then if you go to our NHLBI guidelines, they tell us that you can't just have all the formoterol that you want. There's a certain amount that you can have that's safe. And what they actually say in those guidelines are that in the 4 to 11-year-olds, that's 36 micrograms. And in the 12-year-olds, that's 54 micrograms. So how does all that work out? And then in addition to that, what we know is that there are a whole lot of other things that make the water very fuzzy, of which SMART is not approved in this country. If you go look at the package insert for Symbicort, it does not say that you can use Symbicort for PRN use. And it says you should take 2 puffs of it, because in this country, we worry about with MDIs that you might not be able to get both puffs out. So we dose everything as 2 puffs. But if we go look at the particular data that's in Gina, Gina talks about doing 1 puff all the time. So all of this math does not add up for me. And so the other thing that Gina says is that Gina says that there's no data to say mometasone formoterol is actually just as effective as budesonide formoterol. There's just no data. It wasn't in the SMART trials. So here in this country, not only do we not have the right dosing or the right medicines, but we even have another medicine that we say is okay for SMART, but it's not even in the SMART studies. So how do we come to terms with that? And then we need to have asthma guidelines that show that. So this is a very good review article that I like from Jackie in Practice, and I'll have you go back and look at it. But this is what their asthma action plan, and incidentally, the Asthma and Allergy Network, Allergy and Asthma Network action plan looks almost identical. But this is the table that I have come up with today on Veterans Day of what I think the correct dosing for SMART is. And for those of you that have been filling out these tables, I was very surprised because I apparently am using a lot more puffs than I actually need to use to put patients on MART or SMART therapy. And so just to go over it with you, in kids who are 12 and over, they can use the 160 per 4.5 of Symbicort. If they're on step 1 or 2, they just use 1 puff as needed. If they're on maintenance, maintenance is 1 puff twice a day with 1 puff as needed. And then as they escalate their therapy, they can go up to 12 puffs. I put here in gray what Dulera would be if we in fact applied our numbered scheme. But again, Gina doesn't say that necessarily it's correct to do Dulera. And what I want to point out for you is nowhere does Gina say the 200 per 5 even fits into the asthma paradigm that we think of when we are looking to use MART therapy in patients with asthma. So I think this table will be helpful. And then as I mentioned, this is the allergy and asthma. The other changes, number 8, that are present in Gina, 1 is don't overly rely on pulse oximetry. It can be abnormal, especially in skin of color. There's also some discussion about FeNO. FeNO may not really help us that much. It really isn't going to predict very well who's going to have an asthma attack. And then there are lots of other changes that Gina has discussed, and I highlighted those in these boxes, and we'll point some of those out to you. They talk a little bit about the safety of the flu vaccine, how important addressing outdoor air pollution is, also some discussion about how to transition children to adult asthma specialists, and those are several of the other changes that you will find there. So what I hope you take away from this is that we're learning more. Gina has some great ideas, And the questions I know that are going to come are, how are we going to apply these to this country, since we cannot be able to use the medicines we want to use in the way that Gina tells us. And we're going to have to be very proactive and continue to lobby so that the medications can be properly labeled for PRN use. And then we have to play a whole bunch of games with the insurance companies to make sure that we get the medicines to the patients as we feel deemed appropriate. So thank you for hanging with me. I don't think I'm over. I think I made it. Did I make it? I made it. Good. All right. So do you want me to stay up here for questions, or you want me to shut up? Okay. All right.
We have a couple online questions. One question, there are many severe asthma patients that can't tolerate albuterol. So where does levobuterol come into play?
So I always call levoalbuterol gourmet albuterol. I sort of view it like Starbucks versus Folgers. And so I do think there are some patients who maybe because they have, abnormal cardiac conditions, or maybe they don't, enjoy the tachycardia for the 3 or 4 minutes that they get it, that they may do better with levoalbuterol. But when you see an asthmatic patient who's going to the emergency room, who's having a severe exacerbation, they're not getting put on a levoalbuterol drip or continuous nebs or, whatever. They're getting albuterol in those acute settings. So I'm sure there's a small percentage of patients that probably levoalbuterol does make a difference for. But in general, what I'm hoping ultimately is that we move away from albuterol completely. So.
Another online question, in SMART or MART, is there any data using salmeterol instead of formoterol?
So you cannot use salmeterol for MART because it's a long-acting beta agonist that is not a short-acting beta agonist too. As the early slide said, you can only use formoterol for MART or SMART therapy. It's the only one that has a rapid enough onset to be like a SABA, but also has the long-acting beta agonist effect. So formoterol is the only long-acting beta agonist to date that can be used for SMART or MART.
And one more real quick. I'm not sure if you'll be able to answer this. Is there any time frame for insurance approval for MART or SMART therapy?
Well, I don't have a time frame, but I do know that I am moving ahead as the chair of the asthma committee for the college, and I have a 4-point agenda. And number one on that is actually to tackle that from an advocacy standpoint, so that we can get some FDA labeling changes, so that it's not such a game of numbers and that we can adequately treat our asthma patients. That's it.
Great.
Thank
Thank
you. Oh, there's still another question. Gotcha.
Sir, thank you for your presentation. So, my question was that all I've been hearing this morning is that there's a disparity between Black and white. Okay, we're all in the same country. For example, what is it do we think is making it more Black than any other people? Is it the constitution? Is it the treatment? Is it the availability of the doctor? Or is it the availability of, when you do study, the medication itself? In your statement, you say that there's overestimation of oxygen saturated in a Black and a color people. Will that affect it? Why there's more death and there's more in Black community? What do you think can be done from the ongoing medication, the doctors, and
So I think the disparities, racial disparities, are multifactorial. And I think probably many of the things that you addressed, but many of them are, for example, many of our drug trials are very skewed. And, the populations that are enrolled in those studies are not representing minority populations. And because of that, and many individuals, they don't embrace what we say, oh, this is the medicine as a physician you need to take, because we don't necessarily have good studies that are well-rounded, that demonstrate that across the board in all populations, this is the appropriate medicine. We have, you know, many beliefs, as we heard this afternoon, that different populations have as to what's appropriate therapy. And I don't know, as a healthcare system, that even in the office, which is only 20% of, I've got my, thank you, which is only 20% of, much better, which is only 20% obviously of the social determinants of health are actually in the actual office, and 80% of social determinants of health are outside of the office. I don't know that we do a great job in the office, even though we try as physicians or healthcare providers, of understanding everything that goes into a medication choice and then application of those medications. As we heard today, you know, there are so many obstacles. So I think it's very multifactorial. And even if we had the right medicine and I can get, you know, the insurance company to pay for it, there are still 15 other things that stand in the way or need to be addressed in order for us to provide optimal asthma care. So.
Overestimation of the oxygen.
Oh, I think it's just a study that demonstrated that when we are looking at pulse oximetry in skin of color, that the devices actually overestimate what the oxygen saturation level is, and that it may actually be lower than what the device is actually picking up. And that's what Gina stated as a potential alert that we all need to be aware of.
I promise is my last question. We have been using as educators the curriculum from the NHLBI, but that one it was still based on the 2007 asthma guidelines. And just myself, I tried to translate to actually go for compared to the GINA and new guidelines as teaching forward towards to the parents. So teaching all this that we're even ourselves, it's hard to follow. We would like to know if there is any point through the all organizations on a specific organization that is looking into put together a new curriculum that it's based on the GINA and the new guidelines to teach and present the parents.
And that's ideally, again, what Gina is trying to say is that one inhaler does everything. You step up when you're having symptoms. You can step up in the actual dose if they're having prolonged symptoms, and then you step down. And so they're trying to simplify it so that it is easier for the families, that they're not trying to have one inhaler for this and one inhaler for the other. But we do need better educational programs, not only for the families to understand. We need new action plans. So I applaud the new action plans that are put out there that help guide when to go up and when to go down. But we need new educational tools for healthcare providers. We need a good slide set, which is my second objective, by the way, when I moved to chair of the asthma committee. A good slide set that can be easily taken out into the communities and taught for people who manage asthma so that they understand what MART and SMART are, so that they can help people who are on the front lines with asthma patients manage asthma more effectively.
Yes, thank you. So hoping any organizations can start putting together that curriculum, then we can keep
I'm
using
on it.
Thank you.
Gotcha. Thank you all very much. Oh, no, I've still got time. All right.
Hi.
Sure.
I'm an asthma care manager. I've noticed some patients who've had
Symbicort Smart Therapy prescribed, and then more recently, they picked up albuterol. And when I asked them about, they said that the Symbicort, when they use it as needed, doesn't work as well as the albuterol as needed. Have you noticed any patients like that?
So some people will say that, but actually Gina addresses that this year in their guidelines, and they actually have some information that says at least 69 to 70% of patients do report equal or better improvement by using the combination product. So I think, and they actually address that also in the guidelines, that you just need to tell the parents to stay with it, give it a little longer, and they'll ultimately see. I mean, everything with change is a little bit hard, but there is good evidence-based medicine that says actually it is equally as rapid in onset. And because you get the long-acting beta agonist part of it too, it lasts longer. So in the long run, that may be beneficial. All right. Thank you. Thank you all.
Great. Home stretch for anyone who was concerned, because I was walking around looking concerned. I found it. It was up here, Lynda, see this whole time? Listen, when you lose something and you're like, but I spent time, where is it? Girl, it's on the podium. Okay. So the last but not least, we will have a presentation by the EPA winners, which is the Wisconsin Asthma Program. But we'll have Sheila Brown introduce them and go on to the presentation. Take it away, Sheila.
Okay, so thank you again for your time and attention in the conversation today. Excuse me. EPA's National Environmental Leadership Award in Asthma Management successfully recognizes successful programs that have implemented innovative approaches to providing comprehensive asthma care and are helping to bring asthma disparities under control. Each year through this prestigious award, EPA honors, exceptional whole community systems that coordinate public health, housing, environment, clinical care, healthcare, and community partners to deliver comprehensive care at scale. Here you will see about half of our 52 previous winners, representing the best in healthcare providers, health plans, and community programs across the country, who are delivering comprehensive services for asthma. Esperanza, you're on there. I'm sorry, I'm pronouncing the name wrong. You're on there. And Dee Dee, you're on there with Diane Rhodes, yes. And the program was the Asthma Network of West Michigan. Excuse me. These programs, once receiving the award, become part of our network, serve as mentors to other programs, serve as faculty to spread their best practices. Each year, winners are featured on a national webinar, and you can access archived webinars again on asthmacommunitynetwork.org. And you can read about these programs in their program profiles on acn.org. So this is another depiction of the previous slide, more of a map type. And as you can see, we've highlighted Wisconsin as the 2023 Asthma Award winner. So recognition and celebration of best practices for sustaining and expanding access to in-home interventions. Past award winners serve as mentors to spread the learning and help other programs achieve success. Speaking of recognition and celebration of best practices for sustaining and expanding access to in-home interventions, EPA announced the Wisconsin Asthma Program as the 2023 Asthma Award winner in a national press release on May 1st, 2023. Representatives from the Wisconsin Asthma Program came to Washington, DC to attend the Allergy and Asthma Network reception. Marcella knows how to put on a good party, a good reception, where they were presented their award. Additionally, they attended the Allergy and Asthma Day on Capitol Hill, congressional briefing on May 3rd. Wisconsin Asthma Program has showcased on a national webinar, during Asthma Awareness Month in May, and they are here today to share their award-winning best practices with you. As you're hearing their presentation, the Wisconsin Asthma Program addresses indoor environmental determinants of health by building and maintaining strong partnerships with housing, healthcare systems, and local schools. It is now my pleasure to introduce Erica Glutenmeyer. Okay, she's representing the Wisconsin Asthma Program. She is an environmental health communication strategist. Erica has been working at the intersection of social science, health, and environmental quality for nearly 3 decades to create health, sustainable communities where everyone can thrive. Welcome, Erica.
Ooh, I'm in the spotlight, but I need to share the spotlight. Thank you for that introduction, Sheila. Are we all good? Yep. Okay. So as you heard, I'm Erica Klutmeyer. While my title is Communication Strategist at the Department of Health Services, I wear a lot of different hats. I do a lot of community-based work, a lot of program and project design, and I also do a lot of community engagement and community involvement. So I'm really happy to be here today, and it is the season of gratitude. So I'm going to start out with a lot of thanks. I want to lead off with a thanks to EPA for recognizing our efforts to improve asthma care. And I also want to thank our CDC asthma partners who've supported our work every step of the way with funding through our CDC asthma grant. And I also want to send thanks to the Asthma and Allergy Network for organizing us today. And finally, I want to send a big thanks to my colleagues in Wisconsin. You saw their pictures earlier. They are an amazing group of people. And without them, we wouldn't be here. I love that they think big and shoot for the moon and the stars. And as a mom of a big kid with severe persistent asthma, who's actually now in the realm of adult, but she's still my kid. I really appreciate my colleagues' work and their big hearts, talents, and commitment to helping all Wisconsinites with asthma live their best lives. And I have one more shout out I forgot earlier, our stalwart partner, Children's Health Alliance of Wisconsin. So you'll see them featured prominently in a lot of our project initiatives that I'm going to cover today. So all of those folks that I talked about are back in Madison hosting a conference with our Wisconsin Asthma Coalition. So you guys got me today. So a little overview of what I'm going to cover today is first to give you a little bit of background on Wisconsin's asthma program, provide some context on asthma burden in our state, share our current initiatives, talk about our stable funding for asthma services, and then end with our program's vision for the future. So we are part of the Department of Health Services Environmental and Occupational Health Programs. So for those of you who aren't as familiar with public health structures, this is somewhat unique in state health departments to have asthma with the environmental arm of the agency, environmental health arm, as opposed to chronic diseases. So it creates so many opportunities. And I'll just say I came from the environmental world. So for me, this organization really plays to my strengths and I love working there. So we're able to work across program areas to address environmental asthma triggers. We work very closely with our environmental public health tracking and climate and health programs, as well as our indoor air quality programs. And we work on a lot of healthy homes initiatives as well. A little bit about where we've been just around over 2 decades, we started our program, mostly focused on surveillance activities. And in 2001, we were able to expand our focus with our CDC funding. In 2003, we created our first asthma state plan, which we revise annually and update every 5 years, which really guides our work. I'll talk a little bit more about that on the next slide. So this is CDC's Exhale framework, and this is what we use to guide our strategic priorities in the Wisconsin Asthma Plan. We address each element of the framework, including asthma management education, smoking cessation, and tobacco exposure prevention. We work a lot with our tobacco program at the health department. We focus on home visits to identify, reduce, and mitigate asthma triggers, promoting the adoption of guidelines-based medical management, coordinating care across homes, schools, daycares, and healthcare, and creating environmental initiatives and policies that reduce asthma triggers. How many of you are familiar with Exhale? I should have asked you that before. Okay, a few. Good, I'm glad. That was new information for some. Okay, in this next section, I'll be providing some context for Wisconsin's asthma burden through our surveillance activities. And then later on, I'll also share a case study that demonstrates how we've used surveillance data to make a case for new funding. So another data-driven point for you. This is going to be a little bit of a rapid fire section, so I'm going to take a big breath and launch in. Here's Wisconsin again. This map shows that Wisconsin's asthma prevalence is above the national average as compared to other states. Using 2021 data, we found that 15% of Wisconsin adults reported ever having asthma and 11% still have it. For kids, 10% reported ever having asthma and 6% currently have the disease. Wisconsin's asthma prevalence data shows stark disparities in our Black and Indigenous populations. Both have an asthma prevalence about 2 times higher than that of white population. So another theme from the day. These disparities exist because of systemic racism that touches many parts of people's lives, such as access to quality healthcare, safe and affordable housing, good paying jobs, and exposure to pollutants that can trigger asthma, and many other social determinants of health. We also see large asthma disparities among income levels. People in the smallest income group have asthma at 2.5 times the rate of those in the highest income group. Like racial disparities, people in lower income groups are also affected by the same social determinants of health. And they're disproportionately exposed to higher concentrations of pollutants that can trigger asthma. There are added disparities in asthma rates when we look at race and income together. Within each group, people on Medicaid are about twice as likely to have asthma than those not on Medicaid. And then when you look at just the blue bars of people on Medicaid, you still see a disparity by race. Black and Indigenous populations on Medicaid still have 1.5 times higher rates of asthma than white people on Medicaid. This chart adds data based on the level of asthma control. The number of people with very poorly controlled asthma is greatest among the lowest income group at approximately 31%. If you look at the far right, you can see very clear inverse relationship of asthma control by income. And as income increases, the prevalence of very poorly controlled asthma decreases. We also use asthma emergency department visits and hospitalization rates for surveillance. The rates on this slide are per 10,000 people. In 2020, we saw a large dip in ED visits, which was not unique to asthma, and we heard about that in some earlier talks as well. We suspect that stay-at-home orders most likely stop people from going to the ED, or it could have just been the way health agency communicated COVID risks and the fact that hospitals were already overflowing with COVID patients. In 2021, the rates started to go up again, but not as high as pre-pandemic levels. And we'll be getting our 2022 data soon, so it'll be interesting to see if the pandemic had a continuing impact on emergency asthma care rates. The slide shows ED and hospitalization rates by age group using data from 2019 to 2021. People in the younger age groups have higher rates of both ED visits and hospitalizations, with the highest rates among kids under 5 years of age. Southeast Wisconsin and Menominee counties continue to have the highest rates of asthma ED visits. Notice the Menominee Tribal Nations Reservation encompasses an entire county in northeastern Wisconsin, circled in red. In recent years, we've seen higher ED rates in some central and northern counties as well. And again, many of these areas serve tribal members. We use the surveillance data to target our interventions. So you can see all of the icons, especially crowding the southeastern part of the state. They represent different interventions that we support through our CDC funding and Medicaid reimbursement. And most of the activities fall within counties with high asthma burden, which are shown in darker blue. We do support some activities in lower burden counties, those that have an asthma champion, someone who's advocating to improve asthma outcomes in their community. This slide shows asthma mortality rates per 1 million people. Over the past 2 decades in Wisconsin, age-adjusted asthma mortality rates have been on a slow decline that sort of resemble a roller coaster. In 2000, the asthma mortality rate in Wisconsin was 16 deaths per 1 million people. In 2021, it was at 9.5 deaths per 1 million. One thing that hasn't really changed in mortality rates is the racial disparity among asthma deaths. In Wisconsin, Black people are 4 times more likely to die from asthma than white people. The 2021 death rate for Wisconsin's Black population was 39.2 million compared to 9.7 for our white population. Again, systemic racism and social determinants of health likely play a large role in this disparity. So I'm going to take another deep breath. I know I threw a lot at you, but I really wanted to lay the foundation so you understand why we're focusing on what we're doing. So our program provides leadership in delivering comprehensive asthma care services that reflect the NAEPP 2020 focused updates to the asthma management guidelines and CDC's X-Health strategies. We also work with a lot of partners who provide targeted, risk stratified and tailored treatment plans as part of their asthma care services. In the next slide, I will dive deeper into the innovative community approaches we use to reduce asthma burden. Okay, more logos for you. We didn't have enough space to list everyone, but this group has been with us every step of the way. Once again, we couldn't have achieved the level of success and impact without them. Again, I want to call out the Children's Health Alliance of Wisconsin. They are a nonprofit foundation arm of the Wisconsin Children's Hospital System, and they manage a lot of initiatives, large and small, including our Wisconsin Asthma Coalition that's having their annual conference today. The coalition, the Wisconsin Asthma Coalition, is a diverse group of more than 180 members spanning healthcare, public health, tribal health, schools, government, nonprofits, and community-based organizations. Okay, this project is near and dear to my heart, so I have a lot to say about it. This is our new Love My Ear Wisconsin initiative, and it aims to empower people with asthma and their caregivers with access to real-time PM 2.5, that's particulate matter or fine particles, PM 2.5 data, and education on taking actions to minimize exposure when levels of fine particle pollution are unsafe. So air quality can vary block by block, yet our regulatory monitors are too expensive to deploy on a large scale. So we don't really have a good understanding of those hyper-local air quality conditions and what the sources of the spikes are in particle pollution. So this initiative is going to help us learn more about that so that we can design better interventions. So there's a lot of different elements I'll talk about in just a minute. In 2022, we set out to fill those data gaps using low-cost sensors with the goal of building a larger network of air monitors in areas with high asthma burden and air pollution loads. We partnered with the Alliance to pilot our concept at 2 Milwaukee public schools, and thankfully with funding from EPA last spring, we're now able to expand to 15 schools. And for those of you who are following community or neighborhood-based air monitoring, that was the EPA grant that many of the states were awarded multiple grants, and in Wisconsin we have 3. So we were really fortunate to get that funding. I also wanted to give a shout out to Colorado. If there's anyone listening from Colorado, Love My Air will sound very familiar. The program's been around for, I think, 4-ish years. And the city of Denver started it, and they are now graciously helping us replicate it in Wisconsin. So we're not starting out from ground zero. We have a lot of support and mentoring from a lot of different organizations that have already built these programs, many of whom are in California as well. So the 5 elements of our program in Wisconsin are: first, coalition building to create an accessible shared data portal, an app where all partners can upload comparable data, and then community members can access it easily and take action. Formation of community and school planning groups to tailor template action plans and then implement them. And our model is really working with schools and communities surrounding schools. And there's a lot of different information on sort of the range of air quality for these low-cost air monitors. They're called sensors. But we really felt that it was important to include the community in this initiative to find out what their concerns are, what they want to do, what's important to them, how they're affected. And so we're just creating templates and a lot of resources and helping out where we can. And we really want to build the capacity for communities and neighborhoods to lead these efforts eventually. So after the community plans are in place, then installation of both fixed air monitors at schools and portable monitors. On the photo at the right, you can see 2 of those types of monitors. The purple air one is the one on the upper right, which is probably the most common one used around the country. And then the one on the bottom is called an air beam, and that's portable. You can take it anywhere indoors or outdoors and measure air quality. And we're focused on particle pollution, but there's a few other things you can measure as well. And then we're going to dig into curriculum development with the schools and integration in STEAM subjects. So science, technology, engineering, arts, and math. And I think there's a fit for just about any subject. And finally, anti-idling campaigns to reduce PM 2.5 exposures at school drop-off and pickup times. And we're going to do a lot of good process and outcome evaluation. I think I lingered on this one too long, so I'm going to make up for the lost time, talk about medication therapy management initiative, or MTM. This is a service provided by pharmacists to ensure the best therapeutic outcomes for patients. MTM includes 5 core elements: medication therapy review, personal medication records, medication-related action plans, intervention or referrals, and documentation and follow-up. And some pharmacies also provide in-home education. We do partner with one pharmacy in Milwaukee, Hyatt, to provide MTM and medication synchronization in underserved communities. And they really serve as a bridge between the patient and provider. We also launched a new initiative with the Pharmacy Society of Wisconsin recently to enhance pharmacy services to Medicaid eligible asthma patients in 6 pharmacies in 4 counties. Next one is our Patient Voice Initiative. The goal is to empower people with asthma and their caregivers in underserved communities to overcome asthma management challenges and healthcare barriers. We hosted focus groups and distributed a survey to learn more about what their challenges and barriers are. And we also wanted to know where they get their information about asthma, so those trusted sources of information. So people told us they wanted more education on asthma management, more resources and programs, and better support systems. So we are working to tackle the implementation part of the project right now. Improving asthma healthcare. We have a lot of quality improvement initiatives going on that I will talk about. In partnership with the Wisconsin Collaborative for Healthcare Quality, we work with partners or providers and experts from across the state to develop measures of asthma quality that will be deployed across the WCHQ membership. And the measure will assess the proportion of patients with asthma who receive an annual asthma control test, which will allow healthcare systems to track and increase the use of asthma control test self-assessment. We're also working with the American Lung Association to strengthen healthcare clinics' use of guidelines-based medical care through an ongoing asthma quality improvement initiative. I'm going to go really fast now. And finally, we work with the National Environmental Education Foundation, or NEEF, on using their environmental management of pediatric asthma guidelines. So it's training for pediatric healthcare providers and other clinicians. School-based initiatives are really important. We know effective school asthma management programs help kids stay healthy so they can learn, reduces absences, allows for full participation in physical activities, reduces classroom disruptions, provides appropriate asthma emergency care, and improves access and adherence to asthma meds. We also have a SAMPRO project or initiative that we support. And that's a framework that coordinates support for kids with asthma among families, clinicians, and school nurses. And so it has a lot of different elements to improve asthma management, ensure those asthma action plans or asthma management plans are at schools, and develop a comprehensive environmental asthma plan to assess and reduce triggers. And we do that through an environmental school walkthrough program. We also have a small grant program that we kicked off recently. It covers staff education, school walkthrough program, and working with families and clinicians to provide an asthma action plan at school. This is a testimonial. I'll let you look at it in the slides when they're available, but a school nurse in Southeastern Wisconsin found a lot of value in the walkthrough programs to help identify indoor and outdoor asthma triggers. Okay, this is kind of the centerpiece of our program. So if you want to like push me off stage, I can tell you to go to our website, but this is our Asthma Safe Homes program. It is a new program that provides asthma management tools and addresses asthma triggers in the homes with kids who have poorly controlled asthma. And so I can definitely cut this down. This is the funding model using Medicaid reimbursement for asthma self-management education, durables like HEPA vacs and air cleaners, or air conditioners, home asthma trigger assessments, and home repair services. So I'm going to, I think I'm going to go really quickly and skip this one. Yeah, absolutely. Yeah. Yeah, so our precursor to the Asthma Safe Homes program was a pilot that we went on for 8 years. And this is part of the persistence of us not giving up and really fighting to get that Medicaid reimbursement agreement. So that program, we were able to show through data how the value of it and the impact that it had. So you can see here, a third of the services right. So the case control study examined Medicaid claims for asthma-related services 1 year prior to asthma care program versus 1 year post. And so you can see we had roughly 1/3 fewer ED visits, hospitalizations, total days of inpatient stays for pilot participants. 79% of participants had improvement in their ACT scores. Nearly half or more than half had fewer missed days of school or work. This is the big one. This is how we were able to persuade our asthma program to provide the reimbursement. For every we found a saving of $2.34 for every dollar spent. Again, home visit, education, basic home assessment, and yeah, that's what that program entailed. So here's our path to Asthma Safe Homes program. I'm not going to go through it now, but the one I wanted to highlight is the Medicaid funding from a Medicaid HMO that was contracting directly with their hospital system. So that's a model that we really want to continue into the future. Here's a little bit of information on our budget. That covers asthma home visits, durables, home assessment, and home repairs, training, workforce training, and state program administration. So these are more details that I pretty much already covered. Again, this is for children ages 2 to 18 who are Medicaid eligible and need a referral, and they need to live in southeastern Wisconsin where we're starting this program. Okay, looking ahead, we want to expand our Asthma Safe Homes program statewide, boost adoption of Asthma Safe Homes program model and Medicaid HMOs, promote other asthma quality improvement initiatives with Medicaid, and apply lessons learned from our asthma MTM program, and expand Love My Air to schools statewide. All right, and here we are. More contacts. If you have questions, please reach out.
Thank you, Erica. You know, we work in partnership with Sheila and her team to be one of the evaluators of the applicants for the award that the Wisconsin group won. And I just want to tell you, I was the one who had to go through that application, and it was such a strong application. There was a map with where everything was being done throughout the state, and it was everywhere. There was stuff everywhere. It was just so impressive, and you could see that it was really well coordinated. And like you said, it was really saving, you know, substantial lives and health, but also it was saving money. And it was such a good investment to improve the lives and health of people with asthma in Wisconsin. So congratulations on that. You've done a lot of hard work there in Wisconsin to make the lives better for people with asthma.
Thank you so much. I appreciate that. That's the power of like I said, I should not be here in the spotlight, but I will say that's the power of data, surveillance data, and evaluation.
Yeah, the data was really what drove.
Yeah,
you could see the results, you could see the impact, and it was really impressive.
Yeah, thank you.
You bet.
Let's not all jump at once. You guys are tired. Got it. Okay. Thanks. Oh, you do. Oh.
The last slide where you talked about 2.5 million, that's state funding, that investment, that's tremendous. Bless you for getting that. Is that split between you and Medicaid investment, or is that solely the funds that go into the Department of Health where your unit is, and for the things that you mentioned there that your team is, that the team there is managing? Just out of curiosity.
I don't know the exact split, but our piece is really small. We have two full-time people working on it in Department of Health, and it's a reimbursement program. So they have built the program and contracted with service providers in the first target area in southeastern Wisconsin. So the bulk of the money is going to services to the community through service providers, and then they have some management and administrative time as well. But it's when I know that when you look at our budget, the bulk of it is going to services, which is great. We are good at working with small budgets, and this one, to have a budget like this for us in environmental health, is huge.
Amazing, amazing, amazing. Thank you so much.
Thank you.
You made it. Look at you and I see eyes. That means everybody's awake still. Your legs are still working. No one's having numbness and tingling. I'm an allergy doctor, not a neuro. But if you need that, I don't know what to tell you. This is an allergy conference here. But anyways, thank you guys so much for being here and sticking with us at the Asthma Summit and really being engaging. I really, really appreciate it. So I really wanted to say that. But before I forget, please, please, please fill out that evaluation. QR codes in your folder and also on the table. Things on tables have a way of having legs. So just in case it's not on your table, it's in your folders as well. We really appreciate it. Anybody who didn't fill out a photo release, please do so that we can use them. Please do so. And I will leave the floor to Lynda. So she's the CEO of the Asthma or the Allergy Asthma Network. And to say, but thank you guys for allowing me to be your moderator today. I really appreciate it. And definitely follow the National Medical Association at nmanet.org and also the Asthma Allergy Network. She'll have all the info about where to follow them on social media and stuff like that. But the NMA is at NMA or National, it's like National Med Association, ASSN on Instagram and all this stuff. So and I'm at the Dynamic Doc, one word, on everything else you can find, like thedynamicdoc.com, Dynamic Doc on Instagram, and then I have a Facebook page, for your Facebookers. But yeah, well, thanks a lot for having me, guys. Lynda, take it away.
Thank you all for staying here and for hanging in there until the end. I hope you had a day of learning where you have a lot of takeaways and you got to network and meet some other people. We've really enjoyed putting on this. We worked really hard. I have to give a shout out to my team, to Gary, to Dee Dee, to Marcella, who really drives the program and brings everything together logistically for today. And thank you so much for just hanging in here until the end, because it was a long day, but we learned a lot and I learned a lot. And so I really appreciate that. We will do a follow-up email. So all of those Facebook things and stuff, that social media connections that Dr. Joseph talked about, we will let you know about those. So you have those, and then we'll follow up with some just, things that I said that I would give to you, like the evidence-based about the asthma versus daily control. I'm kind of getting tired now to talk. So in any case, we'll follow up with all the things I promised you and make sure that you get the information about next year. And the US Asthma Summit will be in Boston next year. Hope you can make it there. If not, we'll have it online again virtually. And then our Asthma and Allergy Day on Capitol Hill is in May. It's going to be May 8th this year. We're going to do it a week later so that we can actually make sure that Congress isn't open and that we'll be able to actually go to their offices. So thank you again for joining us. I think there were some slides that were supposed to happen, but they didn't seem to proceed. But we will. Oh, okay. Somebody was moving them the last time.
I'm about to say, oh, no, well, you know, we can just, did you want to?
Yeah, just why don't you go ahead? Yeah, go ahead. There you go. That's all of our connections. We will give them to you in a follow-up email.
If you get like, you know, but you can take a picture of that too, so you'll have it on your phone and you can favorite it, and you can go back to it regularly. So then just in case you get lost in the abyss of emails, you'll have that too.
Thank you.
No problem.
Next year we'll put yours in, right?
Well, but no, you have to. I also talk like this at the speed of light, so.
So anyway, so I will stop talking now. Just say thank you again, and have a good night. And if you're staying here for the rest of the conference, I hope you have a really good one. Bye, everybody.